online. Thank you. Good morning, everyone. Welcome to the Committee on Health Coverage Insurance and Financial Services. We have a full day ahead of us today with hearings on 5 healthcare related and prescription drug related bills this morning, followed by a break at which we will caucus and prepare for our afternoon work sessions. And we have several of those that are not healthcare related, so we'll get to switch gears a little bit for the afternoon. And so without further ado, and so that we can get to our public hearings right away, I'm going to ask the committee to introduce themselves. We'll start today with Representative Connor.
Thank you, Madam Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Quinn.
My name is Tracy Quinn. I represent House District 144, which is the Greater Holston area.
Representative Evans.
Thank you, Madam Chair. My name is Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Hornerville Township, and Lakeview Plantation.
Representative Arford.
Thank you very much, Madam Chair. I am Representative Poppy Arford, and I represent District 49, the western part of Brunswick.
Representative Blyer.
Thank you, Madam Chair. I'm Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Representative Melrano.
Good morning. My name is Gina Melrano. I represent House District 62, which is part of Auburn.
Representative Morris.
Good morning. I am Representative Joshua Morris. I represent the towns of Turner, Leeds, and Livermore, House District 75.
Representative Tepler.
Good morning and thank you. Senator Sanborn, I represent House District number 54. I'm Denise Tepler, and it is all of the town of Topsom, and I serve as co-chair of the committee.
And we're assisted today, as always, by our talented clerk, Christian Ritchie, and by Colleen McCarthy-Reed, our OPA analyst. And the order of the bills today will be LD 120, followed by LD 1117, followed by LD 673, followed by LD 675, and then wrapping up hopefully our morning with LD 686. Aside from members of the legislature who may testify today, I will be running a 3-minute clock on all other testimony, and that's in order to ensure that everyone has a reasonable time to present their opinions and their testimony for the committee, but that we can still get through the large number of people that we do have signed up to testify today. And so with that in mind, I'm going to open a public hearing on LD 120. A couple of further notes as we're bringing the sponsor in today. Please note that the chat function is not for any substantive discussion, questions, or communications to the panel, but instead can be used only in cases where there's some sort of technical glitch or some sort of administrative question that needs to be addressed, usually by our clerk. So please refrain from using the chat function for any other purpose. It is not streamed onto YouTube and is not part of the record. And the only other thing I will just say today is that when you are testifying, there is we will pull you into the panel, and there's a moment where it will appear that you have lost the Zoom call. Just sit tight. It just takes a minute, and then you will magically re-enter the Zoom call in this panelist world with your ability to turn on your video and unmute yourself so that we can hear your testimony. So it feels a little bit like going through a wormhole in some kind of sci-fi movie, but you come out the other end really quickly. So I did just want to mention that because we have a lot more members of the community here today to testify than we often do in this particular committee, where we deal with some pretty wonky topics most of the time. So, so with those caveats, I would like to welcome Senate President Troy Jackson to present LD 120 for us. Good morning, Senator.
Good morning, Senator. And I definitely just came through the wormhole, and I can assure you that it's nice to be on this side of it. So, but thank you all. And I know you have a long day, and I appreciate the work of the entire committee. So Senator Sanborn, Representative Tepler, members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Troy Jackson. I serve as president of the Maine Senate and have the great honor of representing Senate District 1, which is made up of the good people of Northern Aroostook County. I'm here today to introduce LD 120, an act to lower healthcare costs through the establishment of the Office of Affordable Healthcare. This bill was heard by your committee last session and was voted out with some amendments, but unfortunately died when the legislature adjourned due to the pandemic. You know, all across the state, families sit around the kitchen table each night trying to figure out how to stretch their budgets to make ends meet and afford health care. They go over their budgets with a fine-tooth comb and do everything they can to make each dollar count. But it is hard to keep up with the cost of health care. I know this because I hear it from folks daily, and I've certainly been there myself. At some point, we have to say stop and have to say enough is enough. When I first introduced the bill last year, I had heard from a single mother in Kennebec County about how she often resorts to skipping her own care because she never knows how much her son's care will cost. He has significant health needs, and without estimates from their provider or insurance company, it's really impossible for her to budget for. No one should have to live like this. Yet I know her story is all too common. At a press conference earlier this year, Susan Kinney of Belgrade shared the challenges that her family faces trying to keep her 17-year-old daughter, Marissa, healthy. Marissa has Crohn's disease. While the Kinneys are doing everything they can to make ends meet so she can focus on being a kid, Susan worries about how Marissa will afford to stay healthy as an adult. That's heartbreaking. And I think we all need to do better. 1 in 7 Mainers have gone without treatment or care because the costs were just too high. Maine people tend to be held hostage by pharmaceutical and health insurance companies. It's why my colleagues and I have put together the Making Healthcare Work for Maine package. This package includes a group of 5 bills that work to lower drug costs, improve transparency, and ensure that Mainers have access to life-saving medication. This proposal is a key part of the package. To truly address the high cost of healthcare, the healthcare necessary for Maine people to lead healthy and productive lives, we need to get a handle on what's driving those costs in the first place. We need to understand how the self-insured, Medicare, and Medicaid markets, as well as the uninsured Mainers, affect costs. We also need to ensure that providers are paid fairly for producing good health outcomes. LD 120 would create the Maine Office of Affordable Healthcare. The Office of Affordable Healthcare would help us understand the complicated health system and take meaningful action against high healthcare costs. It would also give Maine people somewhere to turn when they are dealing with health insurance disputes that the Bureau of Insurance or Maine Consumers for Affordable Healthcare aren't equipped to handle. This bill would also create a council within the Office of Affordable Healthcare to carry out the duties and goals of the office. The council will consist of 10 members who will provide input from all aspects of the healthcare system. Using data already available from the Maine Health Data Organization, the council will examine the factors that contribute to growth in total healthcare expenditures and make recommendations for strategies to increase the efficiency of the healthcare system. Instead of being frustrated by the fractured system and federal restraints, the council established in this bill will help us understand both what is driving the cost of growth and how creative, collaborative reforms can ease the financial pressure, not only on consumers, but also on small businesses, self-insured businesses, insurance companies, and medical providers who are working at odds to protect their interests. There's no doubt that healthcare is complicated, and I'm talking to a whole group of people that understand it a lot better than I do. But it's why politicians have often thrown up their hands in frustration. But I believe the Maine people deserve a healthcare system that works for them. They deserve lawmakers who fight for them and deliver for their families. And that's exactly what we're going to do here in Maine. We're going to do everything we can to rein in prices and ensure that Maine families can get the care they need without going bankrupt. As with most healthcare proposals, you're going to hear from people who benefit from the current healthcare system just the way it is. I'm sure they're going to tell you that the sky's falling, but we know that that's just not the case. Last session, we passed a suite of prescription drug reform bills and legislation to address abusive medical bills, and average insurance costs only went down. Not to mention that other states are already seeing the benefits of similar bills. Massachusetts, Maryland, Oregon, Vermont, and Pennsylvania all have bodies charged with monitoring healthcare spending. And Governors Raimondo in Rhode Island, Lamont in Connecticut, and Kearney in Delaware have all introduced healthcare cost growth benchmarks in the past few years, which is a system that could have developed from the creation of the office that this bill would establish. These states are looking out for their residents, and we owe it to Mainers to do the same. I've been working with the governor's office and MaineCare to ensure that the Office of Affordable Health Care is able to achieve its goals and work seamlessly with other healthcare entities in the state. Based on the feedback that I've received, I plan to propose an amendment to this bill that would specify that all committees having jurisdiction over health matters and public paid insurance will be responsible for legislative oversight in the office. I will also propose that definitions in this bill align with the Healthcare Payment Learning Action Network's definitions to ensure clarity and consistency. And I'll be proposing 3 additional members for the council, 1 behavioral health specialist and 2 academics with backgrounds in health economics and research. LD 120 is a part of a package of healthcare bills, including 1117, 673, 675, and 686, designed to make healthcare work for Maine. And I look forward to working with all of you to pass this package of bills into law. I want to thank you for your time, and I'll take any questions.
Thank you, Senator Jackson. Are there questions for Senator Jackson? All right, seeing none, we thank you for your testimony, President Jackson, and we'll see you again in a few minutes. Yeah. All right, next we'll hear from a co-sponsor of the bill, our own Senator Brenner. Welcome, Senator Brenner. You'll get a chance to introduce yourself as you present your testimony.
Wonderful. Thank you, Madam Chair. Senator Sanborn, Representative Tepler, and honorable colleagues of the Health Coverage, Insurance, and Financial Services Committee. I'm Stacy Brenner. I represent Senate District 30, which includes Gorham, most of Scarborough, and part of Buxton. I'm here today to speak in support of LD 120, an act to lower healthcare costs through the establishment of the Office of Affordable Healthcare. Throughout my career as a nurse midwife, I've seen many of my patients struggle with the high cost of healthcare. I've sat with patients who needed to ask for a less expensive medication option, or had them tell me they had skipped taking their medications because they couldn't afford it. This is not a unique experience among healthcare providers. As medical professionals, we always do our best to care for patients and help them achieve the best possible outcomes. The fact that cost stands in the way of folks getting and staying healthy is unexcusable. It doesn't matter who they are, the cost of healthcare and prescription drugs can be devastating for one's finances and health. Time and time again, the overarching consistent message from my constituents includes a profound dissatisfaction with the cost-benefit analysis of their experience accessing and receiving healthcare. We know we have to take action, and that's why I'm proud to testify in support of this bill. By creating the Office of Affordable Healthcare, we can have an entity solely dedicated to identifying the root causes of skyrocketing healthcare costs. To tackle a massive issue such as this, we need bold action. Establishing this new office with a missive to analyze data and develop strategy based in data science will be a game changer for Maine. As you very well know, with most bills that come before us on HCIFS, we're just picking away at the problem. This bill is a vehicle to help us achieve a more systemic and informed approach to the kinds of policy that will really make a difference for healthcare affordability in Maine. My friends, the federal government is not coming to anytime soon to save us from the despair and real challenge of our healthcare system. Real change comes from innovative state actions that are smart, courageous, and forward-thinking. The Office of Affordable Healthcare is just that kind of action. Thank you for your time, and I urge you to support this bill along with the others that we're hearing today.
Thank you, Senator Brenner. Next, we are going to turn to some members of the public who are here to testify in favor of the bill. And just as a reminder, I didn't ask if there were questions from the committee for Senator Brenner, so I apologize for that. All right, seeing none, I think I need to refresh my order of operations here because I missed that Senator Hickman has submitted testimony and is here as well. So we'll bring in Senator Hickman now. I just refreshed my list so that I'll get the most up-to-date folks, and I apologize, Senator Hickman, for almost missing you. Welcome, go ahead.
Good morning. Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Craig Hickman. I represent Senate District 14, which is 11 towns in southern Kennebec County, including my hometown of Winthrop in the Maine Senate. I Zoom here today to testify in support of LD 120, as well as LD 675, 673, 686, and 1117, also known as the Making Healthcare Work for Maine bill package. As a former public health professional who has now confronted 2 deadly pandemics in my short lifetime, I believe that equal access to preventative and life-saving healthcare is a fundamental right. The coronavirus pandemic has revealed beyond all doubt that it's beyond time that we renegotiate our contracts with one another as a society. It's not just okay that our healthcare systems values some lives more than others. If we all have a right to life, liberty, and the pursuit of happiness, then we must also have a right to our own bodily health and well-being. No illness, whether chronic or catastrophic, should force a person into bankruptcy. Today, I am happy to build on my long legislative record of backing and ultimately voting for healthcare policy that works for the people, not big pharma, by supporting the Making Healthcare Work for Maine package. And so I am proud to stand today in solidarity with President Jackson, Majority Leader Vitelli, Senator Breen, and Senator Claxton as well as the co-sponsors of all this legislation for taking bold and innovative action today. Establishing the Office of Affordable Health to prohibit price gouging of life-saving drugs, fining pharmaceutical companies for unsupported price hikes, increasing transparency between the costs of prescription drugs and the people, and providing Mainers with diabetes who are in dire need of emergency supplies of insulin are measures to support at any time, but most especially during a public health crisis. Thank you for the opportunity to testify today, and I will take any questions that you have.
Thank you, Senator Hickman. Are there questions for Senator Hickman? All right, seeing none, we thank you for joining us this morning. So now I will say that we will be applying a 3-minute clock for folks, and would just ask that you state your name as well as the town that you're from when you begin your testimony. And we will start with Bonnie Dean. Good morning. You can unmute yourself and turn on your camera.
Can you hear me now?
We sure can. We can't see you, but that's okay if that's not an option.
Well, hold on. I'm not exactly sure why you can't see me. I apologize. I'm not great at this.
That's all right.
But I'll just start because I don't want to waste my time. I apologize.
Perfect. Go ahead.
This testimony is in support of the LD 120. My name is Bonnie Dean, and I live in Appleton, Maine. My son Dakota was diagnosed with severe Crohn's and juvenile arthritis in 2014 when he was 14 years of age. When he was diagnosed with the disease, he began receiving Remicade infusions every 6 to 9 weeks to treat the rheumatoid arthritis and severe Crohn's disease. The cost of each of these infusions are $78,000. When my son was first diagnosed, I was working 4 jobs and had health insurance through my employer, but the coverage was not good. We had to meet a deductible, and after the deductible was met, we were responsible for a copay for the infusions. Each and every year since, we've had to pay over $10,000 or more towards the deductibles and copays and have hit the maximums every year. These medication and insurance expenses have placed our family into deep financial distress. All of the bills we have ended up in collections, which is very stressful. There is no choice for these bills. We're trying to pay these medical bills off to the best of our ability. These are life and death decisions parents have to make when a child has a disease. We signed up for a discount program through the drug manufacturer, but even with that, my husband and I have medical debt in the 6-figure range because of the cost of Remicade and other family medical expenses. Our medical debt is more than what we paid for our house. My husband and I are almost 60, and we're going to be dealing with this medical debt for the rest of our lives. My son has to have this drug or he'll die. He is 21 years old now and has just recently qualified for main care after losing his job. But I worry about how he'll afford the infusions once he's back on his feet and working again. It's definitely an eye-opener. Anyone who has a child who has any kind of disease, it's financially devastating for people. There is no help, but he has to have it to live. What I want you to understand is that it doesn't matter if you're a blue collar, you're a millionaire, or you're on welfare. If you're really sick and you need a drug like Remicade to survive, you're going to have to lose everything. And there's something wrong with that. I don't want anyone else to ever go through what we continue to go through. Thank you, Bonnie Dean from Appleton, Maine.
Thank you very much, Ms. Dean, for being here this morning. Are there any questions? All right, seeing none, we thank you for your testimony. Next, we'll hear from Susan Kinney from Kennebec County. Ms. Kinney, we can see you, or we can hear you. We can't see you, but if you want to turn on your camera, you're welcome to. And please go ahead.
There we
There
go.
you are.
Good morning. I am Susan Kinney of Kennebec County and the wife of a small business owner. I am here to testify in support of LD 120 and the remainder of the bill package. I am also here to testify on behalf of my family, including my daughter Marissa, who is now 23 years old. I would like to explain the impact of the continued rising healthcare costs on our family and on our business. Our struggles with healthcare are very frustrating, but I will be concise. In 2015, my 17-year-old daughter Marissa was diagnosed with Crohn's disease. It is an inflammatory bowel disease that causes chronic inflammation in the gastrointestinal tract. I cannot even begin to express what an oversimplification this statement is. This disease is unpredictable and can spiral out of control quickly, leading to hospitalization. Over the years, we have struggled to afford coverage that would meet our healthcare needs and provide Marissa with the medication she needs to not only be healthy, but to thrive. Keeping her healthy has not been easy, and we constantly worry what the future holds if she cannot access the medicine and care necessary. Currently, our family coverage costs us over $1,900 a month. The in-network deductibles are $5,500 individual and $11,100 family. The out-of-pocket maximum is the same. The out-of-network, out-of-pocket maximum are $16,650 individual, $33,300 family. Marissa currently takes Remicade, a prescription infusion treatment that costs about $5,922 every 8 weeks. This is on top of our other healthcare needs. We have to pay out of pocket for these treatments until our deductible is met each year. After the deductible is met, the treatments are covered by our insurance 100%. Included in the cost is the medicine, $4,300, and the infusion center of $1,600. She receives infusions every 8 weeks and is currently on the lowest dose. If the dosing increases, so does the cost by thousands of dollars. At one point, we were told by our insurance company that our coverage was ending in our location, and for approval of coverage, a Pennsylvania site was recommended. I researched and found a clinic in Maine that was in network and provided coverage. I had less than 8 weeks to find a clinic, have the paperwork sent over, and the infusion approved by the insurance company. It was at this facility we enrolled in the Janssen Care Path. This is the prescription drug patient assistance program with drug maker Johnson & Johnson that may be able to help out with the cost of my daughter's medication. I am unsure as to the amount and just received a bill for the infusion center from last year. I am waiting to find out the final
Ms. Kinney,
cost.
can I ask you to wrap it up for us?
Absolutely. I just want to simply say that I'm asking you to please support these prescription drug bills and do what you can to address the high prescription drug and care costs in Maine. The growth of small business and retention of college graduates is important and in the state. And for this to happen, the state must provide affordable medical coverage and prescription costs for individuals like Marissa. Thank you very much.
Thank you, Ms. Kinney. Are there questions for Ms. Kinney? All right, thanks for sharing your story with us this morning. Next, we will hear from Hillary Koch. Good morning, Ms. Koch. Go ahead.
Good morning. My name is Hillary Koch, Senator Sanborn, Representative Tepler, distinguished members of the committee. I live in Waterville, and I am the main Insulin for All chapter leader for T1 International. That is a global nonprofit organization fighting for access to affordable insulin and diabetes supplies. But I want to make clear, I am not a paid lobbyist. I'm a volunteer. We are all patient advocates. And by patient, I mean I'm actually a proxy for my son who has type 1 diabetes. There are about 1.6 million Americans living with type 1 diabetes. There are about 200,000 of those people who are children. When we talk about healthcare in the United States, this is very real. It's not an abstract idea. This is something that affects people's lives. But the problems for patients is that we need time to advocate, and it's something that patients often don't have. So I'm heartened to hear how many people are here today to speak, but the reality is most of the people who really need these bills to pass can't be here today. So I'm here on behalf of Maine's chapter to support all 5 bills. I will be speaking more in depth on 2 of these bills, but I want to let you know that our chapter supports all 5 of them. You should also know I'm really under the weather today, but I'm going to be here for the duration because we feel so strongly that these bills will do so much for Mainers. This bill particularly is important because it does have a group of people who would serve on this council. The one minor thing that we note is that it has one patient advocate, but that patient would be a senior. We'd like to see a representative that would be someone who's a patient in addition to a senior, because we recognize that the challenges that seniors face can be different. That's the only note that we would make. Otherwise, we'll be speaking on other bills later. Thank you so much.
Thank you very much, Ms. Koch. Are there any questions for Ms. Koch? All right, seeing none, we thank you for being here today. Next, we'll hear from Sammy Ellie McKinnon.
Senator, I believe one of our committee members had her hand up for a question.
Oh, okay. Sorry, Representative Arford, it was blending into the background and I didn't see it. Is it a question that we should get Ms. Koch back?
I think I can wait until this particular individual comes back to testify.
Yeah, she'll be testifying on at least 2 more of the bills later. Yep.
But thank you,
okay, sorry
Representative.
about that.
Thank you both.
Yep, I apologize. I didn't see it go up. Okay, Ms. McKinnon, we can see that you're with us if you want to unmute and turn on your video.
Senator Sanborn, Representative Tepler, and honorable members of the Health Coverage, Insurance, and Financial Services Committee. My name is Sammy Ellie McKinnon. I'm a resident of South Portland, and I'm here today to testify in favor of LD 120. I have a pre-existing condition, or as the rest of the world calls it, a medical history. I was diagnosed with Becker muscular dystrophy at 8 years of age, and at various points in my life, I've seen multiple specialists: neurologists, pulmonologists, cardiologists, orthopedists, and physical therapists. I know the medical system pretty well by now. I also know the struggles of having subpar insurance coverage. I remember being only 10 or 11 and hearing my mother yelling and crying on the phone to the insurance company. They wanted to deny coverage to me, her daughter, for something I was born with at a genetic level. I have been lucky enough to access these services in part because my parents never stopped fighting. They made sure we were covered, found in-network doctors, and immediately reached out if there were any issues coming from a provider's office or the insurance company. Not everyone has access to this type of support system or even coverage. We as individuals largely have to push back and advocate against these for-profit companies on our own with no one in our corner to back us. This is the reason, I am the reason, why LD 120 is needed to establish the Office of Affordable Healthcare and make healthcare truly work for Mainers. Constituents like me who have pre-existing conditions, diabetes, or need specialty medications also need an advocate in government to support us. Someone who will implement policies that place people over profits and individuals over pharmaceutical and health insurance lobbies. Please, don't force us to keep fighting for our well-being alone. Thank you all for your time. I urge you to vote to advance this bill.
Thank you so much for your testimony. Are there questions? All right, seeing none. Next, we will hear from Jim Clymer, Mick Clymer, excuse me. Good morning. Go ahead.
Thank you. Sorry, it's weird going through the wormhole. I'm Jim McClymer of Glenburn. I'm also a physics professor at the University of Maine and president of the faculty union, AFM. And I really appreciate Senator Sandburg's wormhole comment. I've actively participated in a longstanding health insurance task force at the University of Maine system, which includes our insurance company representatives. Our charge is to maintain quality and affordable insurance. One thing I've learned is that progress requires us to be well informed, and LD 120 is a needed step forward to keep people well informed so that we can make some progress with a very difficult problem. And hopefully LD 120 can create a state office that can go further than the task force I'm on can do on its own. Some of you may know that last year, University of Maine system tried to end group insurance for retirees. I got to talk to many retirees and hear their stories, like some of the stories we were hearing earlier this morning. And the stories are heart-wrenching. They would really make some really tough choices for people about their quality of life. One in particular, a husband was worried that his spouse would not continue her life because they couldn't afford drugs that kept him alive and kept her pain tolerable. So for those of you who supported us in turning back this effort, I greatly appreciate it. And now you have an opportunity to help many, many more Mainers with this set of bills you're talking about today. These things, as we already heard, are complicated. There are many challenges and opportunities. One, low-cost generic drugs can really be helpful, but there are roadblocks such as heavy advertising for name brand drugs that are no more effective than the generics or more effective than lower cost name brands, or in some cases, over-the-counter drugs that are much less expensive. Drug pricing is all over the place in Maine. I was recently examining prices of some drugs that I take, and I see that some places, such as Hannaford, has much lower cost than many of the chain drugstores, the big box stores that are in Maine. Yet state law seems to inhibit any kind of steerage to lower cost sources. Specialty drugs, which we heard about this morning, pose unique challenges. These drugs are extremely expensive and are critical. They save people's lives, they maintain quality of care, and the price for these drugs varies again by thousands depending on where you get them. There is no reason for this. We also know that there's places called pharmacy benefit managers, PBMs, that act as middlemen between the consumers, the companies, and the insurers. There are rebates. Rebates sometimes go to the employer, sometimes not. I see 20 seconds. I want to just recommend that LD 120 is a needed step to understand and make meaningful progress on this complicated problem. Thank you.
Thank you, Mr. McClymer. Are there any questions? All right, seeing none, we thank you for your testimony. And next we will hear from Pat Tanyanshavili. I have no idea if I did that well or not, but I gave it a try. Good morning, and you're welcome to proceed when you're ready. Go ahead.
Good morning. My name is Pat Tanyanshavili, and I live in Surrey. This testimony is in support of LD 120, LD 675, LD 1117, and LD 686. I'm speaking today on behalf of and in support of my husband, Yosef, whose first language is Georgian and second language is Russian. Yosef recently retired from his job and has type 2 diabetes. He currently has a health insurance plan through the ACA marketplace with a deductible of $5,700. I'm a retired teacher, so I can't put him on my insurance, and he is not yet eligible for Medicare. Trulicity is the type 2 diabetes drug that works best for him. He's gone without this drug for the last 2 years because it is so expensive. The drug was approved by the FDA in 2014, and yet there is no generic available. Yosef has tried other diabetic drugs, but they are either unaffordable or don't work as well. Trulicity costs $600 a month with his insurance. Yosef's only income is once a month Social Security check in the amount of $1,008. According to Yosef's doctor, his diabetes is uncontrolled without Trulicity, and I'm very concerned about his health. This is not his fault. He watches his diet and does everything he can to control his diabetes. We are doing everything we can, yet we are still faced with only one option, which is to charge the cost of Trulicity to my credit card and end up with a huge debt. When you're stuck in this kind of a catch-22, the only choice is to personally incur a big debt. This is unconscionable, charging so much for an essential medication. Yosef's blood sugar is over 200 on a daily basis, and he sleeps all the time because his diabetes isn't being properly treated because of the cost of this drug. It's immoral when you have a life-changing drug and then jack up the price to make more money. We already have a second mortgage on our home and can't afford a third mortgage to pay for Trulicity. We feel like we're being squeezed. If you as legislators have the capacity to control these drug prices in some way, which it appears you would with this package of bills, it is your duty. We are not the only ones suffering. There are children and adults with type 1 diabetes in the same dire situation, and this is patently unfair to them and us. We are human beings, not bank accounts. Yosef retired from trucking at the end of January, and instead of doing things he loves like fishing, he has no energy to get out of bed. He is generally an on-the-go person, but he can't be that way.
Can I ask you to wrap it up for me?
Yes.
Thanks.
I was just going to say that I lived in the Soviet Union for a year, and I thought that our country was the best on earth, and we do have the best medication, but it's not happening now. It's not what I was brought up to understand what this country is all about. I reiterate my request that you please support these prescription drug bills. Thank you.
Thank you for your testimony. Are there any questions? All right. Seeing none, we thank you for being here this morning. Next, we will hear from Ann Wallison. Good morning. Go ahead.
Hi, Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage, Insurance, and Financial Services Committee. Thank you for your time this morning. I am Ann Wallison. I'm Executive Director of Consumers for Affordable Health Care, and I am here right now to support LD 120, but to be clear that Consumers for Affordable Health Care supports the entire package before you this morning. Consumers for Affordable Health Care serves as Maine's Health Insurance Consumer Assistance Program. And last year we fielded almost 9,000 calls from Mainers seeking assistance, finding affordable health coverage. We often hear from people who struggle to afford the health coverage and health care they need, including prescription medicine. In fact, our polling from last October shows that 1 out of 3 Mainers worry about losing their health insurance and becoming uninsured, and 3 out of 4 Mainers are concerned about not being able to afford the prescription drugs they need. Small businesses in Maine also struggle to afford health coverage. Between 2018 and 2020, small business health insurance premiums in Maine increased by almost 17%, according to the Bureau of Insurance. And the cumulative impact of rate increases from 2014 to 2021 for small businesses was over 57%. It's no surprise to all of us here this morning that high healthcare costs in the US and Maine are a problem. Healthcare has gone from being 17% of Maine's economy in 2001 to 25% today. And by 2026, healthcare will comprise of more than 27% of the state's economy. This is just not sustainable. Healthcare costs affects us all individually. It affects both state budgets and local governments, public entities such as municipalities, public schools, community colleges, and our university system, as we just heard, are all struggling with the cost of health care. Concerns about high cost have been addressed by this committee and by the legislature and the governor recently, but it's clear that more needs to be done. And LD 120 is an attempt to provide the legislature with a real tool to not only make suggestions, but to look at data and best practices to address rising costs in Maine. It would also staff the Maine Prescription Drug Affordability Board that was passed with bipartisan support out of this committee 3 years ago, passed through the legislature with almost unanimous bipartisan support. The board has met several times, but has fallen behind in making its recommendations to the legislature to control prescription drug costs, in part because of the lack of staffing. I could go on, but you need to hear from a lot of people, and I ask that you support LD 120. This was a bill that passed through the legislature and this committee with bipartisan support last year, but failed final enactment because the legislature ended early due to the pandemic. So I hope that you will continue the work of the legislature and support LD 120. Thank you very much.
Thank you, Ms. Wilson. Are there questions?
Thanks.
All right, seeing none, thank you. And next we'll hear from Pat Pinto. Good morning, Ms. Pinto. Welcome to turn on your camera and get started when you can. And you are on mute.
Okay, I
There
think
you
I'll
are.
successfully get myself off of mute. Can you see me
Yes.
as well? Okay,
We can hear
great.
you, but we can't see you at the moment. If you want to try starting your video, you're welcome to, or you can proceed without video. Either one is fine. There you go.
Okay, here we go. Okay, great. Thank you very much. Good morning, Chairs Sanborn and Tepler, and honorable members of the Joint Committee on Health Insurance Coverage and Financial Services. My name is Pat Pinto, Patricia Pinto, and I live in Portland. And I am the volunteer state president for ARP Maine. And we support the entire package of bills before you today. ARP Maine represents more than 200,000 members who are 50 and older statewide. And again, as I said, we support this package of drug bills being heard today because it provides a vital and common sense approach to reining in continued drug price escalation, ensuring that all Mainers have access to affordable prescription drugs. In a recent ARP Maine survey, 75% of Maine residents, 45 and older, said paying for prescription drugs is an important healthcare concern. Being able to afford needed prescription drugs is particularly crucial for older Maine residents. The statistics show the extent of the problem. Although 235,000 Mainers collected Social Security in 2020, their average annual benefit amount is only $17,185. And while 346,003 Maine residents were enrolled in Medicare as of July 2020, over 77,000 had no prescription drug coverage, and 27% of Maine's residents 50 and older fall below the poverty line. Rising drug prices mean people sometimes must make a choice between getting needed prescriptions or paying for rent and other basic necessities. According to the Peterson Kaiser Family Foundation Health System Tracker, annual prescription drug pricing spending per person in the United States has increased from $90 in 1960 to $1,025 in 2017. For many drugs, U.S. patients pay more than those in other countries. For example, Humira prescribed to treat rheumatoid arthritis is priced 96% higher than the United Kingdom and 225% higher than in Switzerland. Brand name drug prices have increased over 60% since 2014, but generic drug prices have dropped by 35%. While the drop in generic drug prices is good news for consumers, pharmaceutical companies have devised ways to limit their supply. When a drug's patent expires after 20 years, pharmaceutical companies use several methods to discourage production of a generic alternative. Maine has the highest percentage of residents 65 plus in the nation and an average age of 45. It's time to help assure Maine families that they will be able to pay for necessary prescription drugs. For these reasons, ARP Maine supports the prescription drug package before you today, and we respectfully ask you to vote in favor of these bills.
Thank you very much, Ms. Pinto. Are there questions for Ms. Pinto? All right, seeing none, we thank you for being with us this morning. And next we'll hear from Jess Maurer.
Thank you.
Good morning, Ms. Maurer. You can go ahead. Oh, now you've put yourself on mute, so you can unmute again and turn on your video.
There we go.
There you go.
Good morning, Senator Sanborn, Representative Tepler, and esteemed members of the committee. My name is Jess Maurer, and I am the Executive Director of the Maine Council on Aging, and we are in favor of all of the bills that you will be considering today. I am speaking, however, in favor right now, obviously, of LD 120, because the establishment of the Office of Affordable Health Care would encourage a coordinated, nonpartisan, and data-driven approach to moderating healthcare costs, which would definitely benefit Mainers of all age. A comprehensive and unbiased examination of healthcare costs and quality is an essential first step in their improvement. This office will also be charged with analysis and recommendations to improve consumer experience within the healthcare system. While people of all ages are consumers of healthcare services, older people are more likely to be engaged with the healthcare system more frequently and more extensively than younger people. Older people would not only benefit from the efforts to improve the system, cost and quality, but also will have a great deal to offer to help make processes more consumer friendly for everyone. Healthcare and community supports are in desperate need of transformational improvement. These systems should be easily able to share information and resources to coordinate and care and services and support health. In fact, I think that's why the Robert Wood Johnson Foundation has actually just put out a grant opportunity for figuring out why and which dollars are going into the wrong pocket in relation to healthcare. And so I thought I would actually offer a little bit of an example of something we're working on specifically related to data-driven decisions, which is falls. And I just want to say that when a person falls and is assisted by EMS, but not transported to the hospital, the incident is not recorded anywhere in the person's electronic health record, meaning that their primary care provider never knows. The cause of the fall is unexplored and unresolved, and the person may fall again, this time resulting in serious injury or death. In fact, falls are the leading cause of fatal and non-fatal injuries of people over 65 in the US. People with histories of falls are 2 to 6 times more likely to fall again. It should be that every fall in Maine is immediately included in a person's electronic health record with immediate follow-up by professionals who are trained to respond at reducing future falls. We are a long way from this reality, but the establishment of the Office of Affordable Health Care would be a positive step toward identifying these sorts of needed system reforms. Falls is only one cost driver out of many, several of which have been identified by the federal government and CMS that could be improved, not only to reduce overall healthcare costs, but also to increase the quality of life and productivity of older people who are needlessly harmed by the lack of coordinated care in this state, in this country. We urge you, therefore, to vote in favor of LD 120, as well as the additional bills you're hearing today. Thank you very much.
Thank you for your testimony. Are there questions? All right, seeing none, we thank you for joining us this morning. And next I'll call on Kimberly Cook. Good morning, Ms. Cook. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, and members of the committee. I'm pleased to be with you today on behalf of Community Health Options, testifying in support of LD 120. We will be up again later when some other bills are before you. So as Maine's only nonprofit co-op health insurance company, we exist for the benefit of our members and our mission, which is to provide affordable, high-quality benefits that promote health and well-being. We see the goals of this bill as fully aligned with our goals and mission. We applaud Senator Jackson, Speaker Fecto, and all of the co-sponsors for their focus on ensuring cost-efficient, high-quality healthcare in our state, and we urge the committee to support it. As often noted, the cost of health insurance premiums reflects the underlying cost of healthcare. When healthcare costs go up, the cost of health coverage in turn goes up. This is true for all types of health coverage, whether fully insured plans, self-funded plans, or government-funded coverage. The state budget sees the impacts of these underlying costs of healthcare through the amount dedicated in the biennial budget to covering the healthcare claims through the state employee health plan, as well as in the state share of paying for the main care program. Consumers see the cost of healthcare reflected in their premiums and their out-of-pocket costs that they are bearing, such as deductibles, copays, and coinsurance. According to the Centers for Medicare and Medicaid Services, healthcare spending increased by 4.6% in 2019 alone and accounted for nearly 18% of the United States gross domestic product. By comparison, according to the US Bureau of Labor Statistics, the Consumer Price Index went up only 2.3% in that same period. Leading among healthcare cost drivers in 2019 were a 6.2% cost increase in hospital care and a 5.7% cost increase in retail prescription drugs. This bill would establish a nonpartisan, independent Office of Affordable Healthcare within the legislature, and it establishes as well a well-balanced advisory council to provide advice to the office. The strength of the proposed structure is that it ensures independent, professional, nonpartisan, and well-rounded approach to these complex issues. We believe the legislature will be in a much stronger position to make sound policy decisions with respect to health care and health coverage as a result. In my written testimony, I see I'm running out of time. I'll briefly say that we believe this bill holds the promise of moving Maine forward in achieving the Institute in Healthcare Improvements triple aim. That triple aim briefly is about improving the patient experience of care, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. This is an important bill towards the state being able to achieve the triple aim, and we wholly support that. So we urge your support for this bill and would be happy to answer any questions.
Thank you, Ms. Cook. Are there questions for Ms. Cook? All right, thank you for supporting the bill and being with us today. That is the end of my list of those who had signed up in advance to testify in favor of the bill. Oof, it's early for me to get twisted around already. If there are additional participants in the Zoom meeting who had intended to speak with oral testimony on this particular bill, you can raise your hand at this time. Seeing none, I will call on those who wish to test. Oh, I did see a hand go up briefly. So if that person wants to put their hand back up, if you intend to testify in favor of this bill. Okay, so seeing none, I will next call for anyone who wishes to testify against this bill. I did not have anyone signed up in advance to testify in opposition. And I see no hands up. So next we'll move to those who have signed up to testify neither for nor against. And I will call on Jeff Austin first.
Can you hear me?
We can. Go ahead, Mr. Austin.
Senator Sanborn, Representative Tepler, members of the committee, my name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak neither for nor against this bill. I'd like to make two sort of broad points. First, we appreciate Senator Jackson and Senator Sanborn and the rest of last year's committee's patience with us as we worked on this bill last session. It was a big, complicated bill last session, and both Senator Jackson and Senator Sanborn graciously worked with us, and the committee gave us time to work on it. And we believe within the four corners of this bill, it is an idea that we can understand why the legislature wants this help. Our primary comment today is outside of the four corners of the bill. I don't know what the fiscal note is on this new state agency. I think last year it was in the neighborhood of $200,000. I'm not exactly sure the size of this agency and what the fiscal note will be. But in the budget you adopted 2 weeks ago, you cut hospitals $500,000 as part of the hospital tax program. That makes the total loss to hospitals about $23 million. So healthcare costs are not the only driver of premiums, as you just heard. When the state creates losses of $23 million, including an additional $500,000 from this session, that money has to be found somewhere. It often falls to the commercial market and the patients you've heard from today. Our request to you is that if you can find money for this new state agency, please find the $149,000 that the HHS committee unanimously supported, but was left out of the Appropriations Committee budget to make hospitals whole so that the $23 million loss we currently experience doesn't grow. So again, I appreciate your indulgence. I went outside the four corners of the bill, but if you have money for a new state agency, please find money not to make our losses worse. Thank you. I'd be happy to take any questions.
Thank you, Mr. Austin. Are there questions for Mr. Austin? All right, seeing none, thank you. Next, we'll hear from Ms. Pelletreau, Catherine Pelletreau. Go ahead, Ms. Pelletreau.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm speaking for the Maine Association of Health Plans today, neither for nor against this bill. You have written testimony, so you can see sort of the more formal comments, but I wanted to give you a little bit less formal context. Let you know that we actually supported the original version of this bill last year. And there actually is a tremendous amount of support among the health plans for, a deeper dive into what the cost drivers of high healthcare costs and therefore high premium costs in this state are. So just to sort of level set, there's a lot of support for that concept in general, and we think it would be useful to the state. However, there are a couple of concerns that pushed us out of the support category and into for nor. And that is, really the concern about duplication of effort. There are two places in the bill specifically that we're worried are duplicative of things that are already happening in the state. The first is at MHDO, Maine Quality Forum, around non-claims-based payments or alternative payments. MHDO and the Maine Quality Forum are already working on that issue. There is a stakeholder group. Carriers are at the table along with a wide array of other stakeholders. So we want to make sure that that effort doesn't get derailed in favor of some new effort that is discussed in this bill. And the second piece there is the Consumer Healthcare Division at the Bureau of Insurance. As you know, that already exists. There's substantial resource at the Bureau of Insurance to investigate consumer complaints. And we would ask that the committee note that there is no alternative for the provider community. We would caution against putting more money towards regulation of health insurers in the absence of any, kind of protection for consumers on the provider side. So those are our two primary comments. A couple of other things. We'd urge the office to consider existing data resources, which we actually already in part fund at MHDO, rather than asking plans to come up with and other stakeholders to come up with a whole lot of new data. We'd urge existing data sources be used primarily. And then secondly, we'd suggest shifting the date of the annual public hearing slightly so that it does not overlap with the exact same date in Massachusetts. For many of our health plans, they have the same staff people working on these issues, and it would be helpful to not have the hearings on the same week. So we've suggested language to that effect. Thank you very much. I'm happy to answer any questions.
Thank you, Ms. Pelletreau. Are there questions? Okay. Seeing none, we appreciate your testimony. We did have another participant request to testify, so I'll next call on Kathleen London. Good morning. You can unmute and start your camera and go ahead.
Good morning. Thank you for having me, and thank you to the committee, chairwomen and other members. So I lean against this. I applaud the idea. Yes, so let me start. I'm a physician in Washington County, a family medicine physician, and I'm also here on behalf of Doctors for America. So Doctors for America supports that concept, and then me as an individual physician, here's my concern. So I'm in Washington County, which is an extremely underserved area. My population is either uninsured or underinsured. I'm just not sure this is the way. Physicians are the most regulated professional group. So much of my time as a family medicine physician is spent not on patient care. Administration is already at least 20% of healthcare costs, if not more. And if you look at in the last 20 years where the increase of medical costs have been, it's not in direct patient care. It's the layers of administration that have been added. And I worry that this is going to increase that burden and not solve the issues. I think the other bills, which I've already submitted testimony for and will return to discuss, offer much more, but I'm a little concerned that this is going to add a cost without direct. Thank you, and I see there's questions.
Senator, you were muted if you were calling on me.
Sorry, Representative Tepler, I did call on you. Go ahead.
Thank you, Senator, and thank you for being here, Dr. London. I guess one advantage of this Zoom environment is that we get to hear from physicians as far north as you're working. So thank you for that work. I do want to ask you though, do you think that the administrative costs that have risen so much, and I know that they have, are a result of government regulation or of insurance company demands of providers?
I think that's a good question. I think, like, if you look back even before the ACA, administrative costs that were from private insurance. So Medicare and Medicaid have about a 5% administrative overhead, and private insurance was at about 15 and is now leaning to 20 to 25%. So I think that is part of your answer. And when I look at my own time and we'll get to it when we get to medication. The amount of time I spend on prior auths and other things is outrageous. And I've gotten around some of that with things like direct primary care. So when we talk about some of the innovations that are going on, so I'm a hybrid practice, so I bring on all the hell, where I do take insurance, but I also do, for my uninsured patients, something called direct primary care, where for a monthly small fee, they get all their care. So it's why I'm very intimately aware of what medications cost, because I deal with 4 wholesalers and have a dispensary. So I can tell you exactly what things cost and why there shouldn't be a prior auth for a medication that I can dispense for $5. Really? So I know the games way too well and have been a physician for 26 years. So I'm worried about adding another layer. That's where I'm holding.
Thank you, Dr. Lennon, but I think what I heard you say was that the majority of your time in administration is spent dealing with insurance company requirements of physicians, not state requirements of physicians.
Correct.
Thank you.
Senator Brenner, go ahead.
Thank you, Madam Chair. And thank you, Dr. Lennon, for being with us today. Your practice that you described sounds actually quite innovative and interesting. And it would be, for me, the exact sort of thing that I would want an Office of Affordable Healthcare to study in terms of kind of data is coming out of your practice. So I'm just wondering, when you're thinking about how we might move forward, thinking about healthcare policy, what would be the approach that you would put forward to analyze data so that we can have outcomes-based policy?
So I guess I'm not clear what this particular office is trying to do, because I agree with the previous speaker that some of this data is there already. We have it, and there's other organizations doing this. Kaiser Foundation is one, Robert Wood Johnson is another. And can't we take some of that data that exists already and move it forward? Couldn't there be a subcommittee from existing what's already existing, in a sense, rather than earmarking a whole lot of money that could be otherwise spent?
Thank you.
Thanks, Dr. London. As the chair of this committee for many years, I'll just say that I'm a part-time legislator and not an expert in health data analysis. And so really, I think the purpose of the office is to help us and our committee make good policy by integrating the data. So I hope that sheds a little bit of light on why we're looking at a legislative office in particular. But we are in a public hearing, so I do want to just make sure we're sticking to that. Representative Tepler, do you want to ask another question?
No, Madam Chair, but when we come to the, before we close the hearing, I would like to ask some questions of our analyst for the work session.
Okay. So are there any additional questions for Dr. London? All right, seeing none, thanks for joining us. And next I'm going to just call one more time for whether there's anyone in our Zoom meeting who wished to testify on this bill before I close the public testimony on the bill. Seeing none, we will close the hearing on LD 120. And Representative Tepler, you can go ahead.
Thank you, Madam Chair. And just want to ask Ms. McCarthy-Reed to please, in your bill analysis, when you get to that point, address some of the issues raised by Ms. Molly Bogart in her testimony on behalf of DHHS. That's written testimony. And it has some interesting commentary that I'm afraid I don't fully understand. So I would like some information on that for the work session. And the other thing is, I think that it would be helpful to have a distinction between, particularly given Mr. Austin's testimony, a state agency and a legislative office, and an explanation of the difference between those things and what they do and how they grow.
Great.
Thank you.
Okay. Are there any additional requests for our analysts related to LD 120? All right, so seeing none, I think in the interest of time, we're just gonna go right into the next hearing, which is LD 1117. And Senator Jackson, President Jackson is back with us to present 1117. President Jackson, go ahead.
Thank you, Senator Sanborn, Representative Tepler, members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. Again, my name is Troy Jackson. I serve as President of the Maine Senate. I have the great honor of representing Senate District 1, which is made up of the good people of Northern Mercer County. I'm here today to introduce LD 1117, an act to prevent excessive prices for prescription drugs. In 2016, a young woman from my district received some difficult news that 1 in 8 women in this country will get at some point in their lives. She had breast cancer. When she arrived at her first chemotherapy appointment and learned how much the treatment would cost, her first thought was, oh my God, I'm going to die just because I can't afford the medications. Those words have stuck with me since she shared her story with me in 2019. She had to refinance her home, refinance her car, and use 5 different credit cards just to afford her medication. When you're battling a life-threatening disease, the last thing you should have to deal with is worrying that you'll go into bankruptcy just to keep yourself alive. Yet we know that too many people deal with this every day due to the high costs of prescription drugs. In this country, 1 in 4 Americans find it difficult to pay for their prescription medication, and 77% believe that drug costs are unreasonable. Still, the cost of prescription medication continues to rise. It's why I've introduced LD 1117 to protect Mainers from price gouging. The outrageous overnight price hikes of generic medication that often grabs headlines. These tend to be drugs that have been on the market for years with no new developments. LD 1117 will prevent drug manufacturers from engaging in price gouging behaviors by prohibiting excessive price increases for generics and off-patent prescription drugs sold in Maine. An excessive price increase is defined as having an increase of the cost of a drug by more than 15% of the wholesale acquisition cost within 1 year, or of 40% within 3 years, when that increase amounts to more than $30 for a 30-day supply. This bill also allows the Attorney General to investigate allegations of drug price gouging and penalize pharmaceutical companies found in violation of the law. An exception is provided that would allow price increases for drugs where additional costs exist that led to an increase. We've allowed the Attorney General to go after companies charging astronomical prices for basic essentials, like $10 for a roll of toilet paper. There's no reason why we shouldn't have basic protection for Maine people when it comes to medication. Pharmaceutical companies shouldn't be allowed to exploit Maine people who rely on life-saving medication to pad shareholders' pockets. Unfortunately, price gouging has become more and more common as large corporations acquire essential drugs and use them to maximize profits while Maine people pay the price. Recent examples of this practice include raising the cost of a single tablet for the treatment of parasitic infection by $736.50. 50 cents. I'm not sure why they couldn't have rounded that one way or the other, but That seems to be kind of an odd thing, $736.50. Raising the cost of a drug for heart conditions by $2,260 for a single vial, and raising the cost of a drug for tuberculosis by over $9,500. I don't even understand how anyone can make these things up. I know I certainly couldn't, and I guess I'm glad I only have heart trouble. Increases like these are why retail prescription drug spending rose from 1.4% in 2017 to 2.5% in 2018. This bill is a small but essential step towards stopping the corporate greed that profits off of Mainers who have nowhere else to turn. One diagnosis shouldn't mark the end of someone's financial security, nor should the cost of treatment be a death sentence. Make no mistake, I know that we're not going to repair our broken healthcare system overnight, but you can bet that my colleagues and I will do everything we can to ensure that no Mainer looks at the price of their treatment and thinks, oh my God, I'm going to die just because I can't afford the medications. With the other bills in the Making Healthcare Work for Maine package, this bill will hold powerful pharmaceutical companies accountable for playing corporate games with people's lives. Also wanted to say that I expect that you're going to hear from some people in opposition today that this is unconstitutional, and I disagree. You know, we've crafted similar things in the same fashion. One of the things I would live for an example is last session's internet privacy bill was crafted similarly to this bill to try and create a carve out as far as for constitutionality. But I'm sure you're still going to hear that because that's a favorite argument for people trying to kill bills that are designed to help protect consumers. Also wanted to say that there's a great many generic drug manufacturers that I have great support for, belief in, know that they're trying to do what is best for the consumer. So this bill is designed to, and we've worked closely with those generics, this bill is designed to try and go after the bad actors, which is unfortunate that there are some that makes shine a light on a bad light on generics. That's not my intention. My intention is to try and go after people that have definitely risen the cost of these drugs because they can, and it fattens their bottom line. So with that, I'll try and take any questions and look forward to working with the committee. And once again, I appreciate the long day you have in store for you and the work that you're doing today.
Thank you, President Jackson. Representative Evans, go ahead. You just muted yourself. Go ahead.
Thank you, Madam Chair. Thank you, Senator Jackson, for bringing all of this before our committee. One question, how do we address the situation where you have a brand name drug that goes off patent? That seems to be part of a big part of the problem.
Yeah. This bill, I believe, handles that also, generics and off-brand, off-patent drugs. And like I said, if it's been on the market for that long, then it shouldn't be at the whim of these large increases in prices overnight. And the second page, we've put in there what we see as an excessive price increase, defined as the drug increasing more than 15% of the wholesale acquisition cost within 1 year, or 40% over 3. That would take into account for drugs that were brand name that have gone off patent. along with the generics. Again, that gives the Attorney General the ability to investigate. Obviously, if the drug manufacturer comes back with legitimate reasons why that is, then it would be allowed. But if there is none, if the Attorney General's office doesn't feel that there is the adequate, then they have obviously the ability to go forward. You know, we're not trying to say that there isn't a time that this may be a reason that there was an increase. But as you all know, we've seen increases that I don't think are justifiable, huge increases. Things that have been on the market for a long, long time hasn't changed. The patent has, you know, the makeup hasn't changed, but because they became even more sought after by the public, the drug manufacturers knew they could raise the price, and they did. And you know, I don't think that's fair.
Thank you.
Are there additional questions for President Jackson? Okay. The next person that I had signed up to testify is not with us. He is chairing another committee at the moment. So when he does arrive, we'll circle back to him. And so for now, we will switch over to the public, members of the public who are testifying in favor of the bill. And we'll start with Bonnie Dean.
I don't see Bonnie on the call anymore.
Okay. We will skip over Bonnie Dean, and I'll call on Susan Kinney.
I also don't see Susan Kinney on the call anymore.
Okay. Both of them have submitted written testimony, so I'll just direct the committee to look for that. And next, we'll hear from Pat Tunyan-Shavili again. She's still here.
I also don't see Pat on the call anymore.
Okay. And so next we'll hear from Kathleen London if she's stayed with us. Good morning again, Dr. London. Go ahead.
Good morning. This one I very much support. So prescription drug prices are a huge burden on my patients. And this has only become worse with the cost shifting by insurance companies, with extraordinary out-of-pocket deductibles, the use of pharmacy benefit managers, backroom deals that I don't know about. So I'll look at a wholesale cost of a drug, but not know that insurance A has made a deal, so they want this one. And increasingly, the pharmaceutical industry stranglehold on our economy. As I said earlier, I'm quite familiar with wholesale medication costs, as I have a dispensary in my office and I deal with 4 different wholesalers. I'm now also a second-year law student, and I don't understand how antitrust laws are not broken when I see pricing within pennies of each other across different generics. I've been a physician for 26 years. I also struggle to understand why medications that have been around since I was a small child and should cost pennies have been increasing at alarming rates. For example, doxycycline. We use this for Lyme disease prevention and treatment. It was around when I was an infant, and I'm 58 years old. It should be pennies, but it's about $1 to $2 a capsule. Pharmaceutical companies use the excuses of the need to recoup the cost of research, but these are medications that have long ago been repaid. The industry has had record profits, and my patients are struggling. And COVID has exacerbated that. 37.3% report difficulty affording medications, loss of jobs with healthcare, large out-of-pocket deductibles, 20% have tapped into savings. Others don't have that option. 20% went into debt due to medication costs in 2020. 38% have stopped their medications, and this is what I see. So these bills seek to address these problems, and our state has an aging population and a sick population. So many of my patients have asthma, COPD, diabetes, and these are medications that have extraordinarily high costs. Asthma inhalers, when CFCs were taken out and they went to HFA inhalers, all suddenly became not generic. So these inhalers, the cheapest I can get them for when I do it in the dispensary are $55 an inhaler, and that's nothing. Many of them are hundreds of dollars. So I beg and plead with pharmaceutical companies to get samples to give out to patients. You know, and when we'll get to the diabetes medications, it's not just insulin, it's the somebody mentioned Trulicity earlier, that's in the class of GLP-1 inhibitors, which we depend on greatly, and they are extraordinarily expensive, and not every patient is, the criteria for the patient assistance programs is pretty tight. So I'll have the patients who don't meet main care, they make just enough to not meet main care, they don't meet the patient assistance programs, I'm begging for samples and keeping them afloat that way. And I see that I'm going to be out of time, so I'm going to wrap it up. But this is a huge need, and we need to find a way to make medications affordable for all. And I'll take any questions you might have.
Thanks, Dr. London. Are there questions? All right, seeing none, we thank you for joining us again this morning. And next we'll hear from Kate Endy from Consumers for Affordable Healthcare. Good morning, Ms. Endy, go ahead.
Good morning. Senator Sanborn, Representative Kepler, and the members of the committee, thank you for the opportunity to submit these comments in support of LD 1117, an act to prevent excessive prices for prescription drugs. And as my colleague Ann Walton already mentioned, we are testifying today in support of the entire package. My name is Kate Endy. I'm the Policy Director at Consumers for Affordable Healthcare, nonprofit, nonpartisan organization that advocates for Maine people to be heard, respected, and well served in a system that provides coverage, access, and quality affordable care to all. As you know, CAKE serves as Maine's consumer assistance program for health insurance and operate a toll-free helpline, where we help answer questions about eligibility, help people apply for and enroll in coverage, and assist with other issues regarding insurance and accessing care. Through this work, we often hear from people who have difficulty affording the prescription drugs that they need. And it is our experience with that work that drives our support for the bill today. We know that the experiences of our helpline callers are not unique. And in fact, recent polling conducted by Critical Insights revealed that 3 out of 4 Mainers remain concerned about prescription drug costs, which is no surprise considering the skyrocketing prices, which exceed inflation. According to data from the US CDC, because of unaffordable prescription drugs, almost 1 in 10 Americans don't take their medicine as prescribed. Findings from a recent study conducted by Harvard University and University of California found that increasing prescription drug costs by just over $10 significantly lowered medication adherence and was actually associated with a 33% increase in mortality for Medicare enrollees. Medications are prescribed for a reason, and it's unconscionable that Mainers are being forced to abandon their medicine at the pharmacy because of the sticker shock of their unaffordable drug prices. In addition to individual expenses paid at the pharmacy, as you've heard, the cost of overpriced prescriptions also drives up insurance rates for small businesses and individuals, as well as the state. Between 2018 and 2020, small business health insurance premiums in Maine increased by nearly 17%. Oftentimes, prescription drugs are the #1 factor in the rate increases associated with additional medical cost and utilization, the vast majority of which is attributed to inflation, not an increase in utilization. A survey conducted by the National Alliance of Healthcare Purchaser Coalitions shows support among employers for prescription drug reform, with 87% of employers viewing drug pricing regulation as helpful. In discussions about prescription drug costs, one topic that frequently arises is the need to expand access to less expensive generics and off-patent drugs. However, prices for many generics and off-patent drugs are still out of reach for many people and still see significant increases. The data published by the Maine Health Data Organization shows that the cost paid by individuals in health plans in Maine for one drug, a generic drug that's used to treat Wilson's disease, rheumatoid arthritis, and prevent kidney stones.
Ms. Endy, can you wrap it up?
Absolutely. I will submit written testimony, but would just urge the committee to vote in favor of this bill today, and I'm happy to answer any questions.
Thank you. Are there questions for Ms. Endy? All right, seeing none, we thank you for being here this morning. Next, we'll hear from Kim Cook. Good morning, Ms. Cook. Go ahead. You're on mute.
I was surprised to see my camera came on and it distracted me from that. Thank you for that. Good morning, Senator Sanborn, Representative Tepler, members of the committee. I am Kim Cook and here on behalf of Community Health Options in support of LD 1117. Prescription drugs are a significant percentage, as you've heard, of the total amount Americans spend on healthcare, and this bill would protect Maine people from excessive increases to the cost of some prescription drugs. Health Options is supportive of efforts to rein in the price of prescription drugs, and we actively work to reduce the cost our members pay for medically necessary pharmaceuticals. Saying my camera's off. Our chronic illness support program is designed to improve the health of members with chronic conditions such as asthma and diabetes, while also saving them money. Our program provides members with access to $0 Tier 1 generic medications used to treat chronic illness and a 50% cost reduction for select Tier 2 and 3 preferred brand medications, also to treat their chronic illness. We are also proactive in identifying and contacting our members who could be saving money on prescriptions through another program we have called Script Saver. We recognize that lowering the cost of prescription drugs is essential for Maine people to receive affordable health care. Our program to reduce the cost of prescription drugs, though successful and appreciated by our members, would be more effective with the passage of this bill. Passing this bill, prohibiting excessive price increases for generic and off-patent prescription drugs sold in Maine, is a tangible step in the right direction. We urge you to support it, and we thank you for the opportunity to provide our comments. I'd be happy to answer any questions.
Thank you, Ms. Cook. Are there questions for Ms. Cook? All right, seeing none, we thank you for providing testimony on the bill. Are there additional folks in the meeting who wish to testify in favor of the bill? I haven't seen Senator Curry up here, so he did submit written testimony, and as did a number of other folks. So definitely recommend that the committee check out the written testimony on this bill, as there's a number of important pieces of that. Seeing no one else registered to testify in favor of the bill, we'll now switch to those who had registered in opposition to the bill, and I'll call on Ashley Van Meter. Good morning, Ms. Van Meter, go ahead.
Good morning. I should say that I did submit written testimony that really focuses on the constitutionality that President Jackson referenced. I represent AAM, which is the nation's leading trade organization for generic and biosimilar drugs. This bill is based on a law that was passed in the state of Maryland, which AAM actually sued on and won in the district and circuit courts for it violating the Dormant Commerce Clause. As I said, that is primarily what my written testimony is about, but I think here I would like to highlight that many of the issues that have been raised as far as the problems with drug prices, stuff dealing with PBMs, also dealing with, folks not being able to afford their medication, are really truly aimed at things that are happening in the branded side and not the generic side. And this bill does nothing to really truly get at the driver of prescription drug costs, which is branded pharmaceuticals. Currently, in last year alone, generics saved the state of Maine $1.2 billion. Currently, a study that was done across the country that showed the spend of all overall healthcare found that generics currently only represent 2% of overall healthcare spend. with things like medical expenses being 74%, branded specialty drugs at 9%. Also heard a lot about rising costs. If you look at data from IQVIA, over the past 5 years, there have been changes in prices on brands that have generated an estimated $21 billion in net revenue for branded pharmaceuticals, while generic drug prices have actually gone down, leading to a $7 billion decrease in prices over the same time period. I think it's important to note that there are currently a lot of obstacles in the current system that this bill will not get to that are preventing patients from being able to access, for example, biosimilars for cancer patients. President Jackson was talking about folks that were not able to afford the medication. A lot of those medications are branded only. And if there were not obstacles in the way of biosimilars coming to market like there currently are, that could be remedied. Also, we heard references about problems with the PBM system. That is a brand issue, not a generic issue. We do not use PBMs, we use wholesalers. And also, I would just like to highlight, there was reference also to tiering issues and generics not getting disadvantaged and generics not being picked up. So for overall healthcare costs, spend, generic drugs are not the problem. And we find it troublesome that this bill does nothing to, get at the cost of branded pharmaceuticals and targets the generic industry.
Thank you, Ms. Van Meter. Are there questions for Ms. Van Meter? All right, seeing none, we thank you for being here today. Are there additional folks who wish to testify in opposition to the bill? All right, have not seen any hands go up, so we'll switch to neither for nor against, and I'll call on Bruce Garrity first.
I do not see Bruce on the call.
Oh, okay. This is a shorter hearing than my worksheet would have led me to believe, which I will be fine with. And so we'll hear from Jennifer Reck from NASHP. Good morning, Ms. Reck, go ahead.
Hi, good morning, Senator Sanborn, Representative Tepler, and distinguished members of the committee. I am Jennifer Reck, Project Director for the National Academy for State Health Policy Center on Drug Pricing. NASHP is a nonpartisan nonprofit organization that helps states develop and implement effective state health policy. NASHP works with state officials and legal experts to craft model legislation for state action on drug pricing. And LD 1117 builds off NASHP's model legislation on price gouging. Because NASHP is not an advocacy organization, I'm not here to testify for or against the bill, but to provide information and to help answer questions. The first point I would like to make is that this bill applies to generic and off-patent drugs only, because patent law allows drug companies a level of protection when it comes to naming their price for brand name drugs. However, the same patent protections do not apply to generic or off-patent drugs. LD 675, which I will speak to later today, does, however, offer remedies for price hikes for brand name drugs. This bill, LD 1117, would make generic and off-patent price gouging illegal, specifically for drugs surpassing the price increase thresholds that Senator Jackson has already shared this morning. Those drugs would be referred to the State Attorney General for investigation. If the AG determines a drug manufacturer engaged in price gouging, the manufacturer would have to pay penalties, roll back the inflated prices, and pay back their profits from price gouging, either directly to consumers when possible or to the state for consumer relief when not. LD 1117 was crafted as a second-generation anti-price gouging bill designed to withstand legal challenge. NASHP worked with a team of legal experts to address the specific points of constitutional law that brought down Maryland's anti-price gouging law in 2018. To that end, this bill includes language making it clear that it applies to in-state transactions only in order to avoid violating the Dormant Commerce Clause, which prohibits state regulation from placing undue burden on interstate commerce. And to further strengthen the connection to in-state transaction, this bill includes a requirement for drug wholesalers to maintain a registered agent and office within the state. Finally, the bill is very specific in scope and clearly defines what constitutes price gouging in order to withstand potential legal challenges of vagueness or patent infringement. Thank you.
Thank you, Ms. Reck. Are there questions? Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you for being here, Ms. Reck. We appreciate your advice. I am looking at some written testimony from the director of the Office of Main Care Services, who expresses some concerns about requirements that Main Care pay I'm sorry, I'm losing my spot here. The lesser of ingredient cost plus a professional dispensing fee or usual and customary charge to the public. So I'm wondering how we can address the concerns of the Main Care Administrator within the scope of this bill.
Thank you, Representative Tepler. I am honestly not seeing the connection between that expressed concern in this legislation. It's something I'd be happy to come back and work with the committee on otherwise to see if we can get to the heart of what that issue is there and address it. But you know, having reviewed the legislation and crafted the model, I'm not seeing the connection, but would be happy to work with you all on that.
Thank you. I think it'll be important for you to do that. I appreciate it.
Happy to.
Are there additional questions for Ms. Reck? Okay, great. And yeah, I had a question about the intersection with Main Care as well, given what Ms. Probert wrote. So are there any additional folks in our Zoom meeting who wish to testify verbally on this bill? Please raise your hand at this time. Seeing no hands raised, I will bring this hearing to a close. And we will be scheduling all of these bills for work sessions in the coming weeks, probably not too far away since we've got a lot of bills left to get through and it is already mid-April. Are there any committee requests for preparing for the work session on this? All right, seeing none. I am going to suggest that we take just about a 5-minute break. We're going to do one more hearing and then we're going to have lunch. Then we'll do the 2 more hearings after that. And then we'll probably take another break and then do work sessions. It's going to be a long day, guys. So take about a 5-minute break now and then we will proceed with 673. Thanks.
All right. It's been about 5 minutes. Committee members could turn on their video, let me know they're here. You can turn it back off again if you need to. Great. We'll wait for a couple more folks to reappear. And then we will get started on our next hearing. The next bill that we will hear today is LD 673, an act to create the Insulin Safety Net Program. And we will begin that hearing by calling on the sponsor of the bill, who's already with us, Senator Breen. Senator Breen, welcome. Go ahead.
Good morning. I think it's still morning. Yes, for 3 more minutes. Senator Sanborn, Representative Tepler, and distinguished members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Kathy Breen. I represent Maine Senate District 25, which includes 6.5 communities in Cumberland County. And I'm here to introduce LD 673, an act to create the Insulin Safety Net Program. Too many people live with type 1 diabetes, are struggling with the high cost of insulin, a situation only made worse since the onset of the COVID-19 pandemic. This leads to having to make very difficult financial choices, and in many cases, patients taking less than they need in order to make their insulin supply last longer. It was this rationing of doses that led to the tragedy that inspired this bill. Minnesota now provides an emergency supply of insulin to people who can't afford it, a measure that resulted from an uninsured young man stretching his supply too thin and dying because of it. In short, this was a young man who had aged out of his parents' insurance program at age 26 and had not completed registration in another program, so he was temporarily uninsured. This bill represents a lifeline to many of the more than 100,000 Mainers with type 1 diabetes, especially those who don't have health insurance or even state-regulated healthcare plans. The program works like this. A patient will have to complete a form attesting that they are a resident of Maine, that they are not enrolled in MaineCare or other insurance that covers insulin for $75 or less out of pocket, that they are in urgent need of insulin, and that they have not received a supply of insulin through this program during the previous year. The patient will then bring the form to a pharmacy along with a valid insulin prescription and a Maine state ID, driver's license, or permit. The pharmacist will provide the patient with a 30-day supply of insulin for a copay of no more than $35. The pharmacist will also provide the patient with a sheet on prescription discount programs, how to apply for MaineCare, how to find an insurance policy on the Affordable Care Act marketplace, and other helpful information. After serving the patient, the pharmacy will submit a request to the insulin manufacturer to either reimburse them for the remaining cost of the insulin after the patient's copay, or provide the pharmacy with a replacement supply of the same insulin at no cost to the pharmacy. We all know that people make impossible choices every day with respect to budgeting for medication, and this can be especially dangerous when it comes to insulin. Last year, the legislature passed a measure to cap the out-of-pocket cost of insulin for patients relying on state-regulated plans. While this bill was an excellent start, it only affected those who have health insurance. LD 673 will go one step further to give Mainers with type 1 diabetes peace of mind that comes with knowing they will not run out of a life-saving medication, whether or not they are insured. I hope you'll support the bill, and I'd be happy to take any questions.
Thank you, Senator Breen. Are there questions for Senator Breen? All right, seeing none, we thank you for bringing us this bill today.
Thank you, Madam Chair.
You're welcome. I don't see any additional legislators who wish to testify on this bill. So next we'll hear from those in support of the bill. And first I'll call on Ted Clausen. Good morning, Mr. Clausen, or afternoon now, I guess. By 1 minute, you can turn on your video and unmute your camera, or unmute your microphone, excuse me.
There we go. Okay.
There you are. Welcome. Please proceed.
Okay. Senator Sanborn, Representative Tepler, distinguished members of the committee. My name is Ted Clausen. I live in Bristol. If you'll give me a moment of your time, I'd like to tell you about my friend, Shane Patrick Boyle. Shane was a gentle person, soft-spoken, easygoing. He was a writer. He wrote comics about superheroes and community life, sometimes intertwining the two. We were both active in a creative writing program at the University of Houston in Texas back in 2010. In his free time, Shane would bike everywhere. For those unfamiliar, that's an activity in car-centric Houston where you would take your life in your hands just rolling out of your dooryard. But he was safe, wore his helmet, and loved the outdoors and exploring the city. Shane was well known and well loved within the community of people where he'd lived for over a decade. It was through him that I got to know some of the other artists within the vibrant hidden gems that turned out to be Houston's art scene. Shane was a wonderful, kind human being. 2 days after Shane's mother passed, he'd left Houston to take care of her in Arkansas. A friend and neighbor reported online that they'd found him collapsed and unconscious in his apartment. By the time he reached the nearby hospital, it was too late. I had no idea Shane was a diabetic. I'd seen a GoFundMe campaign he'd started, but hadn't been paying enough attention. When I looked for it later on, I saw that for 2 weeks, the last 2 weeks of his life, he'd been $50 short of money he needed for his insulin. The symptoms for diabetic ketoacidosis, the condition which overtakes the body of type 1 diabetic when insulin becomes unavailable, are vomiting, abdominal pain, shortness of breath, confusion. The blood becomes acidic and bodily organs begin to fail. Shane died in horrible pain. After all this happened, I wrote and illustrated a comic about Shane. I've submitted it electronically as part of my testimony. At the conclusion of that comic, I spoke about a vision of care, of civic virtue, of community, and the social contract. I was hoping at the time that my words were general enough they could speak to every American who would read them. But when I wrote those words, I'll confess, I was thinking about everyone. I wasn't thinking about everyone. I was thinking about the people who'd raised me, who I'd grown up around. I was thinking about a state and a region I'd returned to after living all over the country. It was Maine. It was you. It was us. It was the people I'd witnessed when there was hardness and difficulty who came together in crisis, who cared for and sheltered one another. I still believe that's who we are. My friend Shane is gone. A law like this would have saved his life. But it's not too late for others here in Maine. I encourage you to commit to a piece of legislation that embodies this spirit in LD 673. Thank you.
Thank you, Mr. Clausen. Are there questions for Mr. Clausen? Okay, thanks for your testimony this morning. Next, we'll hear from Deep Acharya.
Hi.
Hello. Hello. Good morning. Go ahead.
Good afternoon. Senator Sanborn, Representative Tepler, and the distinguished members of the committee, my name is Deep Acharya, and I'm an emergency room physician working in Inland Hospital, Northern Light Inland Hospital in Waterville, Maine. I have been in Maine for more than 12 years now and work in the emergency rooms, many emergency rooms here. I wish to share with you guys a little snapshot of what it is when I'm treating a patient with diabetic ketoacidosis. Already, Ted Clausen before me has described some of the features to you guys, but I would like to take you on a journey on my typical day This is a true story that I'm sharing. I'm changing names, but this is in the summer of 2012. So if you guys all are with me, we'll go on a journey in Waterville on a busy emergency day in the summer when I am running about seeing patients with chest pain, a kid who had swallowed a penny, some young person who had gotten drunk and fell off a boat ramp. When my nurses informed me that the paramedics were calling because they were bringing a 23-year-old young woman, let's just call her Rachel, with diabetes, basically a type 1 diabetic who was unresponsive. So here they roll in with Rachel, who is completely unresponsive and has no IV lines in her. And we are trying to save her. We start by drilling a needle into her shin bone because there is no IV access available, and go on to start the infusion of saline, as well as, most importantly, insulin. And this is what goes on to save her life. She has a smell of ketones on her breath, which is a distinct, sweet, slightly bitter, nail polish-like aroma that I recognize way too well. And it sends jitters through my body because I know that the next few hours are going to be survival for battle for somebody's life. In that case, we go on to save her. After several days of hard work by my colleagues, she's saved. It happened to her because she was on a tipping point, not having enough insulin. Insulin was discovered invented exactly 100 years back. And I really wish to tell the committee from the bottom of the depth of my heart that this will really make a huge difference, this bill, in supporting and preventing these kind of issues. Thank you very much, guys.
Thank you very much, Doctor. Are there questions? All right, seeing none, we thank you for being here today. Next, we'll hear from Catherine Began.
Hi, my name. Good morning, afternoon. Senator Sanborn, Representative Tupper, and members of the committee. My name is Catherine Began, and I live in Waterville. When my middle son was 24, he had lost a lot of weight. He was 6'1", and he had lost 35 pounds really fast, and he was suddenly having a hard time seeing. At one point, he was having such a hard time seeing, he was sitting right in front of the TV to watch it. He then got really sick and was thirsty and tired all the time, and it hit me that he may have diabetes, so I told them that he had to get checked out right away. When they tested his blood sugar, it was over 1,200. He then was diagnosed with type 1 diabetes. As a point of reference, the average person's blood sugar is between 70 to 100. He was in the critical care unit for at least 5 days before they transferred him to a regular room. The doctors told me if I hadn't gotten him to the hospital when I did, that he would have died within hours. Nick worked at Oakland House of Pizza and always struggled to afford his insulin and supplies. Because of this, he had a hard time managing his diabetes. He often would reuse syringes and lancets until they hurt because he couldn't afford new ones. Test strips for his meter are so expensive he didn't test his blood sugar as regularly as he should have. His insulin was the most expensive, over $400 at the time, and that didn't include all the supplies he needed. He often couldn't afford it, and he relied on the kindness of doctors who tried to help provide insulin for him. But because the costs were so expensive, his care and management suffered greatly. He rationed his insulin all the time. Sometimes he gave too little and sometimes too much. And he landed in the hospital on many occasions because of this. One time, one of his co-workers found him lying on the ground unconscious, and he had to be rushed to the hospital and treated until his blood sugar levels were stable again. In 2017, when Nick was 36, I noticed one day that he was really cranky, which is a symptom of high blood sugar, and is sitting really close to the television. In my gut, I sensed his blood sugar was probably high and asked him if I could take him to the ER, but he said he was fine. He was fine, Mom. Wished I had taken him. 2 days later, my youngest son found Nick lifeless on the floor. He had rationed his insulin again and had died. For the last 4 years, I felt guilty. I wish I could have just taken him, but I couldn't make him get into the car. I wish I could have saved him. But then I realized it wasn't my fault and it wasn't Nick's fault. It wasn't his fault he couldn't afford his insulin. It costs about $5 to make a vial of insulin, but they sell it for more money than the average person can afford. If they can sell it for $38 in Canada, why don't they do that here? When I heard about the LD673, I burst into tears and said, this bill would have saved Nick's life. This bill will provide a 1 month supply of insulin to people like my son who can't afford it. It won't bring Nick back, but I pray you'll all vote to pass it so it can prevent others from losing their lives. Thank you.
Thank you, Ms. Egan. Are there any questions? Okay, thank you for being with us today. Next, we will hear from Leo Koch. Good afternoon, Mr. Koch. You can go ahead.
My name is Leo Koch. I live in Waterville, Maine, and I'm 14 years old. I was diagnosed with type 1 diabetes when I was 2.5. Type 1 diabetes is an autoimmune disease. It means my pancreas doesn't make insulin, and I have to take artificial insulin, or I will die. I don't have to take it just when I eat. My body needs it 24 hours a day. I either have to give myself shots or use an insulin pump. I've used an insulin pump almost from the day of my diagnosis. I don't remember life without diabetes, but I know it makes me different even though I look the same. When I was little, sometimes I would miss playtime because my blood sugar was low, but everyone else got to play. Sometimes I have to wait 45 minutes to eat dinner because my blood sugar is high, but the food is hot and ready to eat. I remember I'm different when it's 2 a.m. and we have to change my insulin pump because it's clogged and my friends are asleep. And I'm tired at school the next day and my teachers don't know why. When everyone eats ice cream after a big season win, or when my insulin pump falls off during basketball camp because I'm so sweaty, I am reminded I am different. When I send my mom a picture of a plate of food waiting to eat and give myself insulin because I'm not sure how to count the carbs, and everyone else is almost done eating, I know what my body feels like when it aches so much because my blood sugar is too high, or when it shakes and sweats because my blood sugar is so low. I may not remember what it's like to not have diabetes, but I see what it looks like. I can try and describe to you what it feels like to have diabetes, but you can never fully understand. I'm only 14, and there's a lot about diabetes that I don't have to worry about yet, but I know I will when I get older. I want to think about the Celtics and saving money for a car. I don't want to have to think about saving money for insulin. I'm lucky that my parents make sure I don't have to worry about it now, but I'm afraid that I will have to in the future. So I'm here today to ask you to please pass LD 673. It's not my fault I have type 1 diabetes. It's not right for companies to take advantage of me. My life depends on insulin. I think it's okay for them to make a profit, but I shouldn't be held hostage or die. No one should. Please vote to pass LD 673. Thank you.
Thank you, Mr. Koch, for giving that testimony. Are there any questions for Mr. Koch? All right, thanks for joining us today. Next, we're going to hear from Mr. Koch's mom, Hillary Koch. Good afternoon, Ms. Koch. Go ahead. You have a very brave boy.
You're going to make me cry. Okay. Hillary Koch again, a chapter leader for T1 International. I have 3 minutes to save my son's life. It took 7 years to have my first son, 9 to have my second. 10 fingers and toes, they were all there. 6 minutes later, I became Mama Bear. My son had hydrocephalus, his brain fatally swelling. I didn't understand, though the doctors' faces were telling. His first neurosurgery wouldn't be his last, and I had to learn about insurance, and I had to learn fast. He may never speak or walk, we'll only know with time. One thing was certain, good insurance would be prime. We can do this, I told my husband. I'll give up my career, we'll be fine. And life became better, at least for a time. 2 years later, our world stopped, and hydrocephalus became a cakewalk. It's type 1 diabetes, they told us. It's not like type 2. He can't take a pill, and exercise won't do. I held him down while he screamed, pricked his fingers, gave him shots. I didn't have a medical degree, but this was our lot. Things will get better, it's manageable, right? Let me tell you the reality of diabetes in America. It's always a fight. My son may live 10 years fewer because he has type 1. He may lose his eyesight, his limbs, his thumbs. This disease has taken so much. He's missed thousands of hours of sleep, recess and parties. He waits to eat breakfast, lunch, and dinner. He is a human pincushion, a cyborg. And no, it doesn't get easier. It's always hard. It's always scary. One mistake and he's dead. Insulin is cheap to make, and pharma knows my son needs it. Raising prices like a cartel, their greed grows as their stocks split. 1 in 4 ration insulin, we've done it too. Pharma knows, doesn't care. Though they'll claim that they do. Hey, we have coupons. Here, we'll give you 5. Are you kidding me? No one in America should need a coupon to stay alive. So I won't tell my son to follow his dreams and find his true self. This is America's son. Put those dreams on a shelf. He must always have a job, and one with good insurance. Without it, his fate is sealed. I give you my insurance. His name could join others like Alec, Jessamiah, Alan, Nick, and Shane. Will those in power step up, or am I speaking in vain? Pharma's going to talk about innovation and states' limits. Your bill is illegal, they're going to fume. I'm begging you today, wield your power, lower the boom. You see, my son never signed up as a donor for Pharma. He's only 14. It's not his duty to fund innovation for future medications for you or for me. $5 to make one vial, $339 to purchase over $1,000 for 1 month, 11 years until my son ages out of our insurance, 3 minutes to save his life. LD 673 could save his and others. Thank you.
Thank you, Ms. Koch. Are there questions for Ms. Koch? Representative Arford, yes, you had a question last time and you've waited patiently for a couple of hours. Go ahead.
Thank you, Madam Chair. And I've also changed the color of my hand because you were correct. It did blend in very nicely with the background. So yes, Ms. Koch, first of all, thank you and your son so much for being with us today. And then you had mentioned in testifying for the previous bill that you suggested that there be additional, I'm not sure how many patient advocates added to the roster of people on the advisory council. And I just wondered if you wanted to say anything more about that.
Sure, let me bring up the bill. As it stands right now, I believe there are, let me look at it. 4 members appointed by the President of the Senate. And there was 1 member who represents the interests of older residents of the state. Now that, to us, we took it, it's not necessarily a professional, so it could be a patient advocate. We'd like it to be a patient advocate, but we didn't see any other member that would represent patients who weren't necessarily seniors. We would be satisfied with 1, not necessarily anymore, but we do think seniors are really important, especially in the state of Maine. But again, their needs are particular, so just 1 more.
Okay, thank you so much for making that suggestion.
Representative Evans, go ahead.
Thank you, Madam Chair, and thank you for Mrs. Koch for what you have done with your kids. And I know it must be trying. I am a little curious. Your first son was diagnosed at birth. How old was your second son when he was diagnosed?
Actually, this is one and the same. Leo has
That's all.
hydrocephalus. Leo has
Okay.
hydrocephalus and
All right.
type 1 diabetes. Yep.
Okay, so he has been on a pump since birth.
No, Leo was diagnosed with type 1 diabetes at the age of 2.5.
Okay. What I'm getting at is, did you notice a difference in the price of insulin before he got the pump and after he got the pump?
No, the price of insulin itself has changed, though, in the time that he got diagnosed and the time now, but his insulin has not changed. It's the exact same insulin. Yeah,
But the cost is the same.
No, the cost is not the same. The insulin is the same, but the cost is not the same. Pharma has raised over a 20-year period 1,200%.
No, I understand that, but what I'm just trying to get to
Our personal cost?
Yeah.
Yeah, that's totally dependent on insurance.
Yeah.
Or out-of-pocket expenses.
Representative Evans, can I clarify? I think if your question is about whether the insulin is more expensive if the patient is using a pump versus not using a pump to deliver insulin.
Oh, I see what you're saying.
Yeah.
No, when we did insulin shots, we still had to buy vials, and we still buy vials for a pump. It's just how we administer it. So actually, on occasion, we still on occasion have to do shots if its pump is included. We just extract it from a vial. It's the same.
Oh, okay. Thank you. That helps. Thanks.
Sure.
Thanks, Representative Evans. Are there other questions for Ms. Koch? All right, seeing none, thanks for being with us today and for sharing your very brave boy with us. Next, we will hear from Sarah Lukyanov. Good morning. Go ahead. Actually,
good morning.
Good afternoon. Go ahead.
Yeah. Good afternoon. My name is Sarah Lukyanov from Bath, and I've had type 1 diabetes for 24 years, diagnosed in the 5th grade. I'm here to support LD 673, modeled after the Alex Smith Insulin Affordability Act, named for Alex Smith, a type 1 diabetic who lost his life when a lack of affordable insulin access led his body to suffer diabetic ketoacidosis, also known as DKA. I'd like to tell you what it feels like to have DKA from someone who knows. Me. It feels like you're burning from the inside. Exhaustion pulls at every limb until you can barely lift a finger. Breaths come in gasps between the stabbing pains in your stomach. It is both excruciating pain and absolute terror. You feel like you're dying, and that's because you are. I'd also like to tell you what it's like to ration your insulin as I have done. Health insurance companies often approve just enough insulin for a person to get by on for a single month if everything goes according to plan. But we are not robots, and try as we might, it's difficult to recreate the function of the human pancreas. Some months we require more insulin than others. Some months we require less. But rarely is there surplus. Rarely is there enough to stockpile even one extra vial for our own safety net. I depend on 2 insulins, a long-acting and a short-acting. A few years ago, I dropped the vial of my long-acting insulin on the kitchen floor where it shattered. I begged my insurance company to cover an emergency vial, but they just told me I could pay over $300 out of pocket to buy the insulin at the pharmacy. I was shocked at the price, so I decided I'd wait the days until I could pick up the next month's supply. I figured I could make it with just my fast-acting insulin if I rationed what I had left. This led to me going 3 days without enough insulin, sending my body into the beginning stages of DKA, the same thing that almost killed me when I was first diagnosed at 10, the same thing that killed Alex Smith. Within 2 days of breaking the vial, I remember walking up the stairs of my house after work, gasping for breath, wondering if I was about to die. I'm lucky that DKA didn't kill me like it has so many others who've had to ration insulin because of the cost, even though synthetic insulin has been around for 100 years. In fact, this year is its birthday. The patent was sold for $1 by insulin's co-discoverer, Dr. Frederick Banting, who upon sale of the patent reportedly said, "Insulin belongs to the world, not to me." Pharmaceutical companies don't seem to agree with Dr. Banting, charging over $300 for something that costs them less than $10 to produce. There is no alternative for type 1 diabetics. Without insulin, we die quickly and painfully. I'm asking you to help protect the insulin-dependent Mainers whose lives are repeatedly endangered by the well-documented price gouging at the hands of Big Pharma. Please support this bill so that we can keep insulin-dependent Mainers secure in the knowledge that they never have to fear the possibility of running out of insulin. Thank you.
Thank you. Oh, excellent timing. Are there any questions? All right. Seeing none, we thank you for telling that personal story today, for being with us. The next person on my list is Allison Perkins, but I don't see her in the list. Christian, do you see her? All right. So we'll move on to Kate Sharp. Good afternoon. Go ahead.
Hi there. Senator Sanborn, Representative Tepler, and distinguished members of the committee, my name is Kate Sharp, and I grew up in Harpswell and recently moved back to Portland. I'm here to urge you to support LD 673. Every human being needs insulin to live. Most people, including I imagine most of the people on this committee, have bodies that make and distribute that insulin for free. For the first 28 years of my life, mine did too. As a relatively newly diagnosed person with diabetes, I'd like to tell you, fresh from recent memory, what it feels like when you do not have insulin in your body. In January 2020, I started drinking a lot of water. At first, I was pleased with my unending hydrating, thinking I was just acing this whole self-care thing to start the new year. No matter how much water I drank, however, I was always thirsty. I started having to wake up 5 times a night to drink a pint of water and go to the bathroom. I bought a humidifier for my room because I felt so dry that my nose and lips would crack and bleed. I used to be incredibly active, exercising almost every day, but I found myself short of breath even walking up the stairs. I started having to work from home because I was too exhausted to make it through a full workday without resting. The night before a big presentation at work, I passed out climbing up the stairs. I couldn't keep food down. I couldn't keep the water I so desperately needed down. I woke up on the day of my presentation and my lips had turned blue. My boyfriend had to drive me to work because we didn't think I could manage to drive a car. Trying to give my presentation, my mouth wouldn't work properly. My lips stuck to my teeth. They were so dry. I couldn't form words. My breathing was so labored, I couldn't get through a full sentence. My coworkers were incredibly concerned. A few said I looked like I was having a heart attack or stroke. My employee begged me to go to the hospital. I left work. My entire body screamed in pain. We got home and I had to crawl up the stairs to get into bed. My boyfriend convinced me to go to the ER. When we got there, I was seen almost immediately. My face was gray, my lips blue, and I couldn't breathe or speak. My blood had turned to acid inside of my body. If my boyfriend hadn't convinced me to go to the hospital that day, I would have almost certainly gone into a coma or died. The only reason I'm alive today was because they gave me insulin in the ER. I spent a week in the ICU. This is what happens when your body doesn't get insulin. This happened to me because I didn't know I had diabetes, but this happens all the time to people who cannot afford to pay for their insulin. This should never happen to anyone because they cannot pay hundreds of dollars for a vial of something that every single one of us needs to live. Thank you.
Thank you for your testimony and sharing your personal story with us. Are there any questions for Ms. Sharp? All right, we thank you for being here today. Next, we'll hear from Nicole Smith-Holt. Good afternoon. Go ahead.
Oh, thank you, and good morning to all the committee members. And thank you for allowing me to join you today. It's difficult going after Sarah and Kate and hearing what their bodies went through when they were not able to have access to insulin. My name is Nicole Smith Holt, and I'm from Richfield, Minnesota. I'm the charity ambassador for T1 International, and I'm here today to talk about a crisis that is affecting roughly 1 in 4 people who require insulin injections to live. Over the past 3.5 years, I've become somewhat of a subject matter specialist in rationing of insulin. In June of 2017, my 26-year-old type 1 diabetic son, Alex Smith, aged off of my health insurance, and without my knowledge was unable to afford his insulin and began to ration it. He was living alone. He was a restaurant manager and earned approximately $40,000 a year before taxes and did not have health insurance. His job did not offer it, and to purchase a plan through the marketplace as a single person earning $40,000 a year, it was not affordable. The plan that I found for him would cost over $450 a month and have a deductible of $7,600 a year. My son decided not to buy the insurance and use that $450 a month to apply towards his insulin cost. Little did he know that the cost of his insulin when he went to the pharmacy would be $1,300, and that did not include all the other diabetic supplies that are required to stay healthy. When my son went to the pharmacy the first time without insurance and was told that he needed to pay $1,300, he left without his life source and began to ration. Within a few days, he became so ill that he called in sick to work, and within 24 hours of that, his body was found. What most people don't understand about insulin is that just one missed dosage can cause the body to start shutting down and can lead to lifelong health consequences. And a few missed doses can lead to death. Over the past 20 years, the price of insulin has increased for no reason other than corporate greed by more than 1,200%, making it the 6th most expensive liquid in the world. Since we have been unable to convince the insulin manufacturing companies to willingly reduce the price of insulin to make it more affordable, we've had to look at other ways to keep people out of the hospital and out of the morgues. One of these ways was to work with legislators in Minnesota to create and pass the Alex Smith Insulin Affordability Bill. Our program consists of an urgent need program and a continuing need program. And as a result of these 2 programs, it has helped more than 500 people in Minnesota since July 1st of 2020. These 2 programs have had a real impact in Minnesota and will continue to impact lives. And my goal is to make this possible in as many states as possible. If these programs were in place in 2017, Alec would not be dead today. You have the ability to save lives in your state as well. As long as the insulin manufacturing companies have the ability to control prices, people like Alec are at risk of losing their lives. You have the ability to stand up to these companies and tell them that it won't happen on your watch. You can tell them that lives are more important than profit and that access to affordable insulin is a human right. I encourage you to work on creating a bill like what we did in Minnesota. I encourage you to stand up to corporate greed. In closing, I would like to remind you that all type 1 diabetes is an autoimmune disease. There's no prevention, no cure, and no treatment other than injection of insulin. A type 1 diabetic is no different than somebody who has MS or any other countless immune diseases. They did not cause this, and it could happen at any point in your life to any one of us. We've seen studies that show
Can you wrap it up for us, Ms. Smith-Holt?
Okay. So just know that COVID-19, as a result of COVID-19, we've seen a great increase of type 1 diabetes diagnosis.
Okay, thank you for your testimony and for being with us today. I have a question for you, and I'm hoping I can draw on your Minnesota experience to kind of help us think through. Eli Lilly submitted written testimony, but isn't here to testify in person today. But their written testimony suggests that a program like the one in Minnesota is unnecessary because Eli Lilly has so many programs to help folks pay for their medicines. Can you speak to that and why that wasn't sufficient, and why you think we need more than Eli Lilly's generosity?
Yeah. Well, there's, Eli Lilly, Novo Nordisk, and Sanofi will all three tell you that they have patient assistance programs available. And I will tell you that before Alec aged off of my insurance, we applied to each and every patient assistance program available and was denied. More denials come about of their programs than approvals. They make it very tedious and difficult to apply for these programs. You have to jump through a lot of hurdles, which tends to deter people from applying to them because it's just a lot of work. They have a lot of conditions. 1 month you can have private insurance, and the next month they say it's only for uninsured individuals. 1 month they'll say people on Medicare can qualify for it, and the next month people on Medicare don't qualify for it. Their patient assistance programs, because there's no law in place to require that they have them, can remove them at any point. And we have seen them do that over and over again. Without policy in place, it's a program at will, and it's not good enough.
Thank you. Are there any additional questions for Ms. Smith-Holt? All right. Thanks for joining us today.
Thank you.
Okay. Sorry, I've got to reload my list now because I was just looking at some testimony. Bear with me for just a moment. Next, we'll hear from Erwin Brodsky. Good afternoon. Go ahead.
Thank you. Senator Sanborn, Representative Tepler, distinguished members of the Joint Committee, and distinguished people with diabetes who've testified today. I'm Erwin Brodsky, an endocrinologist of Maine Medical Partners. I'm here to testify in support of LD 673. Maine Health and our providers strongly support ensuring a patient's access to insulin in an emergency situation, and insulin that is affordable. And if I may share an important lesson that others have shared today as well, that I've learned over 37 years that I've worked at my subspecialty in endocrinology and diabetes, a person with diabetes who has a profound deficiency of naturally produced insulin may experience vomiting, coma, and approach death within hours of running out of prescribed insulin. Patients fear this scenario, as you have heard. Their family and friends fear it. They will skimp on their insulin doses to make their supplies last so they can avoid a medical catastrophe. A person's insulin requirements are not easily predicted, varying with unanticipated injury or illness or stress. Running out of insulin is always a possibility, even if a patient and doctor estimate insulin requirements carefully. This legislation, with provision for an emergency insulin supply, maintains an important safeguard that will provide Maine residents with diabetes the assurance that they will not lose access to a life-saving therapy. Additionally, LD 673 is important for the fact that it requires insulin manufacturers to provide insulin capped at $35 for a 30-day supply to patients who cannot otherwise afford it by virtue of having high deductible or high co-pay insurance coverage by a self-funded insurance plan that was not covered by public law, Chapter 666, or no insurance. While we are supportive of the legislation before you today, I have a few questions that are not clearly answered in the bill and that I'd like to pose to you, and they would include the following. Will caregivers be allowed to receive an emergency supply of insulin for a patient that is homebound and can't present to a pharmacy with identification? Will assistance be provided, and by whom, to patients with limited literacy or otherwise limited ability to complete the applications for assistance? In the event that an insulin emergency occurs when pharmacies are closed, would a patient be able to receive an emergency supply elsewhere, perhaps an urgent care center? And could that entity also receive reimbursement and resupply of the insulin? The legislation before you today will save lives, prevent severe morbidity, reduce emergency department visits, and reduce hospitalizations. With that said, I urge you to vote ought to pass on LD 673. Thank you, and I would be happy to answer any questions you may have.
Thank you, Dr. Brodsky. Representative Tepler, go ahead.
Thank you very much, Madam Chair. And in full disclosure, I have to say that Dr. Brodsky is my endocrinologist diabetologist, but I also want to ask him if the questions that he's posed to the committee are in his written testimony, because I think they're important questions that we may need to grapple with as we work this bill.
They're in my written testimony.
Thank you, Dr. Brodsky.
Are there additional questions for Dr. Brodsky? All right, thanks for being with us today. Next, we'll hear from Kate Brogan. Good afternoon, Ms. Brogan, go ahead.
Hi, hello everyone.
Now we can see you. Go ahead.
It's amazing how that works. Senator Sanborn, Representative Tepler, and distinguished members of the committee, thank you for this opportunity. My name is Kate Brogan. I live in Portland, and I'm here on behalf of Consumers for Affordable Healthcare and as the mother of a child with type 1 diabetes whose life depends on the availability of injected insulin. Insulin is a naturally occurring hormone. Unlike other prescribed substances, insulin doesn't reduce symptoms or heal a condition. Instead, it simply is essential for staying alive. We all need insulin every day to enable our bodies to absorb and use the carbohydrates we eat. Most of us can produce the insulin we need, but people with type 1 diabetes are unable to make insulin and must buy it and inject it. Without adequate insulin, the body will break down fat for fuel at a rate that produces a buildup of acids in the bloodstream, known as diabetic ketoacidosis. The best case scenario for somebody with DKA is a trip to the emergency room and maybe a stay in the ICU. The worst is death. I want to interject here. This is my son, Nathan, who has type 1 diabetes. And he's been listening to this and loving hearing from all of the other folks with type 1 diabetes. As you have heard, insulin is incredibly expensive. Of the 25 costliest drugs identified in the most recent report of the Maine Health Data Organization, 8 are insulin products. When Eli Lilly introduced Humalog, the rapid-acting insulin that my son uses, to the market in 1996, a vial sold for $23. In the 25 years since then, Eli Lilly has increased the price of that vial of Humalog more than 35 times to a current price over $300 for the same vial. That same vial is sold across the border in Canada for about $30, and it is manufactured for about $6. Legislation approved by this committee in 2020, please stop that, imposed a copay price cap on insulin, which is helping my family and many others to afford insulin. But it doesn't help those who are uninsured or those with a federally regulated health plan. It doesn't help those without a current prescription. And that raises a concern I have with the current version of the bill. Section 3C of the bill states that an eligible individual must present a valid insurance prescription to the pharmacist. As anyone who manages a chronic illness can tell you, prescriptions expire, and we all jump through hoops to get new prescriptions and new approvals for the same drugs that we've been using for years. Any parent can imagine their child at 22 or 23 on their own for the first time, forgetting to pay the electric bill or to get their snow tires put on. For a type 1 parent, the fear is that they'll forget to get their prescriptions renewed and will run out of insulin at a time that they can't reach their doctor's office. It would be a tragedy if this safety net program is unable to protect someone from a life-threatening situation because their prescription has recently expired. I hope the committee will consider amending the bill to allow patients to access the program with a recently expired prescription on record. I know that for us, we go to the same pharmacy every month to get our prescription, to get our insulin and all of our supplies. And very often, once a year, the pharmacist will say, that prescription has expired, you need to get it renewed. If that happens on a Friday night, we would all be in trouble. I hope you'll consider that situation. And I urge you to support this bill. Thank you for the opportunity to present this testimony.
Thank you, Ms. Brogan. And we thank both of you for joining us. today during the hearing and for being patient as you were the last ones on our list. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you, Ms. Brogan, and your son for being here.
His name is Nate.
Hi, Nate. My quick question for you, Ms. Brogan and Nate, is whether or not you have taken a look at the Kevin's Law portion of the bill that we passed in the last session and the new update to Kevin's Law, and whether that covers the situation that you were concerned about. I think it does, but I'm not absolutely positive.
To be honest with you, I remember that happening, but I don't remember the specifics of Kevin's Law.
Kevin's Law allows persons who have had a prescription that has expired to receive an emergency 1 month refill of that prescription.
Okay.
So yeah. I think that situation is something we've already covered in law.
Great. Thank you.
The price controls are not in that bill. So this bill provides the price controls on top of that.
Great.
Yeah.
Thank you.
Yeah, it was good to bring it up, though. We may need to add a cross-reference to make clear that if you qualify under that, then we can tie everything together.
Great.
Great. Thank you. Are there any additional questions for Ms. Brogan? All right. Seeing none, I will do a call for whether there's anyone else in our participant list who wishes to testify in favor of the bill. All right, seeing no hands go up, we'll call for anyone in our participant list who wishes to testify verbally in opposition to the bill. Seeing no hands go up, we'll turn to those neither for nor against, and I'll call on Kathleen London. Good afternoon, Dr. London. Go ahead.
Good afternoon. Good afternoon. Thank you, committee members and chairwomen and committee members for your time. So I chose to be neither for nor against because I want this bill to go further. I am here both in my role as a primary care physician and as the main state director of Doctors for America, which is a nonpartisan organization of doctors and medical students that puts patients over politics to improve the health of our patients, communities, and nation. We envision a healthy America for everyone. And we believe that everyone in America has a fundamental right to equitable, high quality, affordable health care. Everyone should have the opportunity to lead a healthy life. Every part of society should value and promote healthy families and communities. And physicians should take a leadership role in improving healthcare and ending health disparities. So as a physician in an underserved county, I really like the intent of this bill, but I think it should be 90 days, not 30 days. I cannot count the number of patients that I gather samples of insulin and then also the GLP-1 inhibitors, so Bydureon, Trulicity, Victoza, from pharmaceutical companies to treat their diabetes. Coupons do not work if you do not have insurance or if you have Medicare or Medicaid. Patient assistance programs rarely get approved, as somebody previously testified, and are quite onerous. We often have to help our patients through them to even apply to. COVID has further unmasked how bad this is, and even patients with coverage have enormous deductibles, and they've come in and have stopped their medications due to cost. This past year, I have seen just outrageous hemoglobin A1C numbers, the numbers that we use to track diabetes. My patient, I've changed names. Patient Donna, whose hemoglobin A1C went from 6.5 to 11. Jeff's went from 6.8 to 11.1, and so on. So this is an urgent need. Ideally, I would see not just insulin, but the GLP-1 inhibitors, because type 1 diabetes has a need, but it's short-sighted, and to not include those meds, a step would be to start with insulin, but I'm thinking long-term, I want more. Because I see the complications. I'm the one helping them through their amputations, through getting them set up for their dialysis and on the list for their kidney transplant, through their appointments with their eye doctor because they can't drive anymore because now they're blind. So I really want to see this move forward, but I want more than what you currently have in it. Thank you. And I'll take any questions.
Thank you, Dr. London. Are there questions? All right, seeing none, we thank you for joining us throughout the morning and into the afternoon today. I don't have anyone else signed up to testify on my list. If you wish to testify, please raise your hand at this time. And seeing no one, I will close the hearing on LD 673. And are there any comments from the committee with regard to requests for work session? All right, seeing none, we will be scheduling a work session, as I said, on all of these bills in the coming days. So with that, we do have 2 additional bills with fairly lengthy lists of folks testifying on each. And so what I'm going to suggest is that the committee take a 45-minute, well, we'll make it, yeah, let's come back at 1:45. So it's a little more than a 45-minute break. I'm going to recommend that if folks want to have a caucus in preparation of the work session, they try and do it over lunch. And then if we need to have more additional time to do it before we go into work session after our next 2 hearings, we can break again, but maybe be able to get through all of it a little bit more quickly by using the lunch break as well. So committee Democrats will send out a link. It'll be our usual Zoom link for our caucus over lunch, and we'll start that in just a few minutes. Representative Morris, did you want to make any announcements?
Yeah, yep, sorry. Yes, I'll go ahead and send out a link through Google Meets right now.
Okay. All right. So with that, we'll see members of the public back here at 1:45 to resume our public hearings. Thanks, everybody.
Good afternoon. Could committee members come back online? And thank you, Mr. Ritchie, for, we need to get started in a minute. Welcome back, everyone. And we are going to start up with our next two public hearings.
I want to clarify because I think.
Rich, could you please? Okay, thank you. I think he's muted now. Sorry. And give me a second, please, to get myself up and running here so I can run this hearing. The hearing that we're going to open now is on LD 675, an act to protect Maine consumers from unsupported price increases on prescription medicines by creating an independent review process. And we will look and see if the sponsor is with us.
Senator Claxton is not on right now.
Senator Claxton's not with us. Thank you, Mr. Ricci. Could you contact the clerk in HHS and ask him if he can join us?
I think he is in judiciary. He sent us an email, which I, of course, have 67 emails, but I did just happen to see that one. So I think he's in judiciary right now doing a public record exception review.
Okay, so maybe we should go on to the next bill, Senator?
I think that would be fine if the sponsor for that bill is available, though, which would be Senator Vitale, who's probably not in our meeting either.
Yeah, I don't see her.
Okay.
I see Senator Vitale.
Oh, yes, she is.
Oh,
here.
she is there. Okay, great.
Yes, Senator
Let's go on to
Vitale.
Senator Vitale's bill.
Great. So I actually am going to open a hearing on LD 686, an act to increase prescription drug pricing transparency. And we're inviting the bill's sponsor, Senator Eloise Vitale, to please join us here at this afternoon meeting of the Health Coverage Insurance and Financial Services Committee. Welcome, Senator Vitale.
Good afternoon. Thank you for being flexible. That's something we all have to be these days. So I will begin my testimony on LD 686. Senator Sanborn, Representative Tepler, esteemed members of the Health Coverage Insurance and Financial Services Committee. My name is Eloise Vitale and I represent Senate District 23, which is all of Saginaw County and the town of Dresden in Lincoln County, and I live in Aroostook. I'm here to present LD 686, an act to increase prescription drug pricing transparency. So many components of our healthcare system are difficult to understand, navigate, and plan for. Healthcare in this country is, to state the obvious, complicated and expensive, and often intentionally so. This is perhaps most true when it comes to prescription medications. Besides the headline-grabbing incidents of skyrocketing insulin prices, EpiPen price hikes, or the apparent price gouging of decades-old generic drugs, Mainers face this on a smaller scale every day. Even before the pandemic, Mainers were struggling to afford their medications. In 2017, 3 in 10 Maine residents aged 19 to 64 reported that they had stopped taking a medication as prescribed due to the cost. Leaving prescriptions unfilled, skipping or rationing doses, or otherwise not taking medication as prescribed can be dangerous and even deadly. This is tragic when we learn of it happening to a stranger in the news. It is devastating when it happens to us, our loved ones, or our neighbors. Picture this, your doctor says you or your child need this medication to be healthy, but you can't afford it. You can't find information to explain to you why this medication costs so much, or why a drug you've been taking to help you for years is suddenly prohibitively expensive. You look for programs that might be able to help you pay for this medicine, but they're few and far between. Perhaps you resort to crowdfunding for this treatment, but your family and friends are stretched thin too. You're faced with a hard decision between purchasing this medication and putting food on the table, or fixing your car that you need to get to work every day. It's a terrifying picture, but it's one far too many Mainers are faced with far too often. This includes a constituent of mine from Phippsburg who reached out to me over the summer in the midst of the pandemic. The cost of his medication had suddenly gone up into the thousands of dollars, and he couldn't afford it anymore. We helped connect him with the assistance we could, but he was understandably frustrated, confused, and afraid. Why was this medicine suddenly so expensive? We couldn't find an answer. Here in Maine, we've made significant strides in collecting data about the price of prescription drugs and what contributes to increases. LD 686 would further clarify and focus the Maine Health Data Organization's ability to request data, streamline the reporting process, and make the information more accessible to the public. After all, they are the ones paying these high prices. They are the ones who skip doses or stop taking their medicine when they can no longer afford it. Shining a light on these price increases is the best way to make informed policy decisions to combat these outrageous prices. It gives us the tools we need to prioritize the health of Mainers, not the profit margins of drug companies. Without this information, we're unable to act. At the federal level, obstructionism has worked for far too long. Here in Maine, we have the opportunity to put an end to it. I thank you for your consideration of this bill and of all the bills you're hearing today that would make quality healthcare more accessible to Mainers. I'm happy to try to take questions at this time.
Thank you, Senator Vitelli. Any questions for Senator Vitelli from the committee? Seeing none, we thank you for your testimony. And I see that Senator Daughtry has signed up to testify as well, but I do not see her in the queue. Does Christian, do you see her in the queue?
She just joined. I'll bring her in.
Okay, great.
Good afternoon. Apologies. Can you hear me? My internet connection, I just had to restart my router.
We're fine. We can hear you fine and see you fine, Senator Daughtry. Welcome.
Wonderful. Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and distinguished colleagues of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Maddie Daughtry, and I am the state senator for Senate District 24, which includes the towns of Brunswick, Freeport, Harpswell, North Yarmouth, and Pownell. And I am pleased to support not only LD 686, but LDs 120, 1117, 675, and 673, also known as the Making Healthcare Work for Maine package. I know that all across Maine, working families are struggling to get by. And each time I talk to a constituent in my community, the rising high costs of healthcare and prescription drugs comes up. These difficulties have not only been exacerbated by the pandemic, but my heart breaks every time someone shares their story with me of sitting down with the bills and choosing where and how to pinch their pennies so they continue to afford their prescriptions, keep the heat on, and put food on the table. In fact, I actually just came from one of those conversations. These stories are all too common, and I'm proud of my Senate colleagues for working and my House colleagues to deliver relief for Mainers. Pharmaceutical companies are doing everything they can to protect their profits, and this often comes at the expense of working families and seniors who have no choice but to take on debt just to afford life-saving and sustaining medications. This issue also hits close to home for me. My mother has a condition called atrial fibrillation. I can never say that, so please excuse me as I call it by its nickname of AFib. And this causes her to have an irregular heartbeat. And without regular medication, she is at risk of blood clot, stroke, and heart failure. And through no fault of her own, AFib is a part of my mom's life. And again, through no fault of her own, so is arguing with health insurance companies and struggling to find the prescription drugs that she can afford. My mom takes 4 medications to control her condition, 2 of which are generic and 2 of which are name brand. And the 2 name brand drugs cost over $1,400 a month, which causes her to go into the Medicare coverage gap by the end of March each year. This past year, she made the tough choice to stop taking one of these drugs in part because of costs. And I know my mom isn't alone. I've watched her talk with her doctor, struggle to find coupons, find ways to be able to make it work. It's a reality for her. That's also a reality for so many folks in our state. And these costs are more than enough to force someone into financial ruin. I'm incredibly grateful for modern medicine that allows people like my mother to live long and happy lives, even with chronic conditions. So why should we allow corporate greed to make these medications unaffordable and force people like her to make difficult and unfair decisions about when and if to take these life-saving drugs? As I said, it doesn't just affect my mother and our family. More than 131 million people and 66% of all adults in the United States have to use some sort of prescription drug. These folks deserve care that is affordable and reliable, and they shouldn't have to fear going into debt just to stay alive. That's why I'm proud to support this package, and I know bills like this, like 686, an act to increase prescription drug pricing transparency, would allow lawmakers to better understand prescription drug pricing and pass targeted legislation to close loopholes and rein in costs. And I urge you all to consider these as the package. They're important as we continue our fight to rein in extreme prescription drug price increases and demand more drug pricing transparency. Mainers depend on us to solve this problem, and we shouldn't stop until we deliver solutions. Thank you for the opportunity to speak in favor of not only this bill, but all of the bills. I'm happy to answer any questions. I know you've had a long afternoon, and like myself, I'm sure many of you have been bopping in and out of committees. It seems like everyone I've spoken to today has 2 or 3 bills. So thank you for taking the time to allow me to testify.
Thank you, Senator Daughtry. Any questions from the committee for Senator Daughtry? Seeing none. Oh, I'm sorry. Yes, we do have one. Yes, Representative Arford, please go ahead.
Hi. Thank you, Madam Chair, and thank you so much, Senator Daughtry, for joining us today. Very quick question. The name brand drugs, I don't know if your mothers are often advertised now on the television. And then we also hear often that these very expensive drugs, there's not just coupons, but that you can contact the companies and the companies will help you afford them, et cetera, et cetera. And I'm just wondering, in your mother's case, did she find that to be true in any shape, way, or form? I'm just curious.
So yes and no. It depends on what's going on. The other issue, so one of my best friends actually is an internist in upstate New York. And we're also lucky to have many, wonderful doctors and specialists in our local area who have not only worked with my mother, to make sure she finds these, but sometimes you just can't. So maybe you get a coupon one month and you're able to make it work. And the next month you're literally having to, almost like balance your checkbook of which prescription costs. And I actually asked my friend who's the internist in upstate New York, I asked her the same question when we were looking at these bills. And I said, what really factors in? And she talked about her thought process of trying to make sure that she's trying to find something that works with someone's insurance plan. And the other sort of part that bothers me is the limits that are sometimes put on these drugs that someone like my mother knows that she has to take every single day. This is something that she has to have, but they put, arbitrary caps. You can understand if it's something that's, the type of narcotic that you really need to keep in track of the limits. But oftentimes we see these plans, even though they're giving you coupons, okay, so you have 2 coupons, you want to stock up and get 2 months, they only let you get 30 days worth of pills. It's a really convoluted system that, we haven't found we're discussing these prescription drugs, we're having these incentives and that makes someone feel like, oh, okay, maybe I can get it this month. But really the reality is people are having to pick and choose, and 1 month it might be fine, and the next month they're going to literally be deciding if they put more propane or if they actually get their prescription. So yes, sometimes they're there. I know all of our healthcare professionals are working hard to make sure that folks get those the coupons or the samples, but it's not enough, and it's not something you can count on.
Thank you so much for sharing your story.
Of course. Thank you, Representative Arford.
Any other questions for the senator? Seeing none, we will call our next person to testify in favor of the bill. I believe that Bonnie Dean is no longer with us. Is that correct? And I mean just with us. She's still in the world, but is that correct, Mr. Ritchie?
Yeah, Bonnie's not on the call.
Okay. Is Susan Kinney on the call?
Susan is not on the call.
Okay. Is Pat Taniashvili on the call?
No.
All right. Is Miriam Wolf on the call?
She may be one of the folks calling in. I need to check the numbers real quick.
Okay, and while we wait for you to do that, I will call Kathleen London if she's still on the call.
Kathleen is not on the call, but Senator Curry is raising their hand.
Okay. Senator Curry, yes, should definitely be called next. Please bring Senator Curry in to testify in favor of the bill. Welcome, Senator Curry. Thank you for being here. Please go ahead.
Thank you, Representative Tepler, Senator Sanborn, and distinguished colleagues of the Joint Standing Committee on Health Coverage Innovation, or Health Coverage, Insurance, and Financial Services. My name is Chip Curry. I'm the state senator for Senate District 11, which includes the 26 rural, coastal, and island communities of Waldo County. I'm pleased to support the Making Healthcare Work in Maine package, which includes LD 686. For some, the pharmaceutical industry, along with its system of research, patents, marketing, and pricing, is distant and abstract. For many, like myself and my father, the issues presented before us today and that you've been hearing all day long are a daily experience. I'm so appreciative of the small tackle box of drugs that help keep my father's chronic conditions at bay. These drugs keep him alive and allow him to maintain a decent quality of life and independence. At the same time, I'm very aware that the pharmaceutical industry has few limits on what they can charge a population dependent on their products. These pharmaceutical companies don't need a reason to jack up prescription drug prices. In fact, we've seen pharmaceutical companies increase prices just because they can to make a profit off of the health of American families and seniors. It's been over 65 years since Jonas Salk, inventor of the polio vaccine, was questioned why he didn't choose to patent the vaccine. He famously declared that the people own the patent, given their tremendous charitable donations that funded the vaccine research and testing. Today is a different world. A world where price is simply determined by what pharmaceuticals companies can get people to pay. When there are few reasonable medical alternatives and life-saving drugs are held hostage by single companies, free market forces fail us. And it is in these times that we look to government for protection. Every day I hear from people in Waldo County who are making terribly tough decisions to either pay bills or afford their prescription drugs. You have heard these stories all day long. In fact, the cost of medication is 256% higher in the US than in at least 26 other countries. All across Maine, working families are struggling to get by. Enough is enough. And we know that the system isn't working and it's time to fix it. That's why I'm proud to support and co-sponsor the bills in the Making Healthcare Work for Maine package. These bills will allow us to take power away from Big Pharma and provide protections to support Mainers. As you've heard today, there are several bills in the Making Healthcare Work for Maine package that focus on prescription drug pricing in different ways. LD 686, an act to increase prescription drug pricing transparency, helps to shine a light on substantial drug price changes. LD 675, an act to protect Maine consumers from unsupported price increases on prescription medicines by creating an independent review process, would then give us the tools we need to hold pharmaceutical companies to account if they were found to increase drug prices for no reason. For far too long, pharmaceutical companies have also purposefully left consumers in the dark when it comes to how and why certain drugs cost as much as they do. 686, an act to increase prescription drug pricing transparency, which would allow lawmakers to better understand prescription drug pricing and pass targeted legislation to close loopholes and rein in costs. These bills are important to me, my family, and my constituents in Waldo County. We need to continue our fight to rein in extreme prescription drug price increases and demand more drug pricing transparency. Thank you for the opportunity to speak in favor of these bills, and I'm happy to answer any questions.
Thank you, Senator Curry. Is there anyone on the committee who has a question for Senator Curry? Seeing none, thank you for your testimony. Before I call the next person, who will be Karen Lee Harrington of MHDO, to testify, I'm going to ask Representative Connor and Senator Stewart to introduce themselves because they weren't with us earlier in the day due to their duties on other committees. So please go ahead, Senator Stewart.
Thank you, Madam Chair. Sorry, Representative Connor, stole your thunder there for a second. I'm Trey Stewart, State Senator in District 251 communities in Southern Aroostook and Northern Penobscot counties, including the town of Linneus, where my grandfather was actually born. Thank you.
Representative Connor.
I appreciate, Madam Chair. I was here all morning, but I will happily introduce myself again.
I apologize, but you weren't with us when we first introduced ourselves.
You
were. Okay.
Representative Brooks.
The chair is
Brooks
an error.
actually wasn't.
The chair is an error. Representative Blyer, were you with us when we introduced ourselves? Yes. Okay. Representative Tepler was out of it when we introduced ourselves, so I apologize, but I know Senator Stewart wasn't here. So I
think Representative Matheson and Representative Brooks were not.
Okay. Well, then I knew there were a couple people missing. Representative Matheson and Representative Brooks, will you go ahead and introduce yourselves?
So I think Representative Connor, you and I must look a lot alike. My name is.
That's it.
My name is Christy Matheson. I represent District 1. Thanks so much, Madam Chair.
My name is Heidi Brooks. I represent House District 61, which is part of this.
Thank you both for the introductions, and apologies to those who I somehow missed this morning, focusing on all that pretty intense testimony. Thank you. So I will now call Karen Lee Harrington of MHDO to testify in favor of the bill. Welcome, Ms. Harrington.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Karen Lee Harrington, and I'm the Executive Director of the Maine Health Data Organization, and I'm here today to present testimony in support of LD 686, an act to increase prescription drug pricing transparency. The Maine Health Data Organization, I'll refer to also as MHDO, is authorized by statute to collect healthcare data, including prescription drug pricing component data. Rule 590, Chapter 570, Uniform Reporting System for Prescription Drug Price Data Sets, explains the provisions for filing prescription drug pricing data with MHDO from prescription drug manufacturers, wholesale drug distributors, and pharmacy benefit managers. Rule Chapter 570 is a major substantive rule and is currently before this committee with a set of proposed changes that are meant to clarify the data submission reporting requirements with which will ensure more uniform data submissions and streamline the data collection and validation process. Sorry, my computer. Several of the proposed changes in Chapter 570 specific to definitions and reporting requirements are defined in LD 686. Included in my testimony on LD 41 is detailed documentation that provides the rationale for many of the proposed changes that are also included in LD 686. As stated earlier by Senator Vitelli, LD 686 reflects MHDO's first year's experience of collecting and reporting on prescription drug pricing component data. LD 686 refines the current requirements by creating administrative efficiencies for the manufacturers. It explicitly provides the authorization for MHDO to collect pricing component data that is most relevant to Mainers and allows for greater transparency in the public reporting of the data that's collected. The bullets that are summarized below in my testimony provide a little more detail on the key revisions that are in LD 686. And I'm happy to go through that, but in the interest of time, I know I'm running probably close to the 3 minutes. I won't go through that in detail, but I look forward to working with the committee during the work session, and that concludes my testimony.
Thank you very much, Ms. Harrington. Are there any questions from the committee for Ms. Harrington? Seeing none, we look forward to seeing you at the work session, and thank you for your testimony. And next, I will call Ann Willison of Consumers for Affordable Health Care. Welcome, Ms. Willison.
Hi, Representative Tepler, Senator Sanborn, and distinguished members of the committee. Thank you for the time you're taking today to listen to everyone's testimony, including mine. I am here this afternoon to testify in support of LD 686. And as previously mentioned, Consumers for Affordable Health Care serves as Maine's health insurance consumer assistance program. And last year we fielded over 9,000 or almost 9,000 calls from Mainers seeking assistance, understanding their health coverage options, many of whom shared their experiences and difficulties accessing the prescription drugs they need. Our polling from this past October shows that 3 out of 4 Mainers remain concerned about the cost of prescription drugs. And concern about the cost of prescription drugs is equally high among all demographic groups and in both congressional districts in Maine. Attached to my testimony, you will find a medical trend assumption chart provided to the Maine Bureau of Insurance during last year's health insurance carrier rate filings. And you will see that the prescription drug rate factor attributed to inflation was the equivalent of over 10, almost 11%, nearly double that of hospital, professional, and other medical service types. Also attached, you will find a page from the Maine Health Data Organization's most recent prescription drug annual report. The new data shows that Mainers spent over $165 million more on the 25 drugs with the highest year-over-year increase in cost from July 2019 to June 2020. Maine's prescription drug transparency law is important. It provides information that is critical to our understanding of an out-of-control cost driver that contributes to increased health insurance premiums. Drug companies consistently set high prices, which forces families to make impossible choices that also interfere not only with the appropriate use of medications, but also with a decline in medical services. National polling shows that 1 out of 4 more than 1 out of 4 consumers decline other medical tests or procedures or put off doctor visits when they experience an increase in drug costs. The polling I previously mentioned shows that 85% of Mainers across the state support policy that requires drug companies to release information to the public about how they set their prices. We believe.
Can you please wrap it up, Ms. Wilson? Thank you.
This is an important measure that will strengthen Maine's prescription drug transparency law and improve the Maine Health Data Organization's ability to access data and provide it to policymakers when you're considering efforts to reduce prescription drug costs in Maine. So thank you very much, and please support LD 686.
Thank you, Ms. Willison. Questions from the committee for Ms. Willison? Seeing none, I believe that brings to the end of my list of people testifying in favor. Since Ms. Cook had to leave, but she has written testimony if any, so that the committee can access that. Is there anyone else in the queue who would like to testify in favor of LD 686? Okay, seeing none. I will call those who I have testifying against, and then again, we'll turn to the queue to see if anyone else would like to testify. And I will call Nick Doherty of Pharma. Testifying in opposition to the bill. Welcome, Mr. Doherty.
Good afternoon, members of the committee. Just wanted to start by saying thank you for the opportunity to speak before you today. My name is Nick Doherty. I'm the Director of Policy for Pharma in the New England region and am down in Boston. We did submit a detailed statement outlining our opposition to LD 686, and in the interest of time, we'll touch on just a few of our issues. I want to start by saying pharma is not opposed to transparency, but we continue to be concerned about the expanding scope of MHDO's authority to request significant reporting of proprietary information from manufacturers. In the enacting legislation, LD 1162, it included 3 reporting triggers that needed to be met for a manufacturer to submit pricing component data. Now, if LD 686 is enacted, MHDO would be able to request NDCs for drugs that fall within the same drug product family of any drug that met one of the 3 triggers, or on the 25-25-25 report that MHDO annually compiles with guidelines from LD 1406, and request any information it deems relevant. Thus, instead of transparency reporting tied to price increases or new market entry as the statute currently requires, so in other words, actions taken by a manufacturer that then triggers a reporting obligation, this bill would give MHDO very broad authority to request significant reporting of proprietary data on whatever the agency decides from year to year, even when a manufacturer has taken no action on their prices or due to the actions of a different manufacturer. Now, throughout the MHDO rulemaking process and initial reporting period, the conversation centered around making reporting process predictable. Yet LD 686 may result in less predictability. This is a problem because aggregating reporting information takes time and resources, which make predictability key for these reporting entities. The expansion of what drugs MHDO may request information for removes any predictability and could result in too much information that does not produce any meaningful data to help patients at the pharmacy counter. For example, MHDO's report presented to the committee in February, it showed that with the inclusion of the drug product family definition in the 25-25-25 report, MHDO captured 170 additional NDCs that were not even on the 25-25-25 report. This expansion of information requests would impose significant reporting requirements on manufacturers and include confidential and proprietary data and the possibility of significant penalties based on actions and reports they have no control over, or data that may not accurately reflect costs with no opportunities to correct or rebut the report. We do appreciate MHDO's desire to use the first reporting report as a baseline and would urge the committee to tighten the existing reporting requirements of who needs to report. And we do stand ready to work with the committee on concrete reforms to help lower patients' out-of-pocket costs at the pharmacy counter. And again, reaffirm we are not opposed to transparency and look forward to working together and hope legislators vote no on LD 686.
Thank you very much, Mr. Doherty. Is there anyone on the committee with a question for Mr. Doherty? I have one while my committee members think for a moment. Mr. Doherty, you said that one possible outcome is too much information that we would end up with. Can you describe what you mean by that, please?
So as 686 is drafted, it would be encompassing any information that MHDO would find relevant. And as such, you could just have a library of information that would take too much time to comb through and actually not result in any meaningful data that could help a patient at the pharmacy counter tomorrow. And that's the concern that we have is too much information might not net actual results.
Okay, I guess I'm just confused because if it's relevant to data that they've already received, how would it be?
No, because this is now, there are 3 triggers in the enacting statute.
Yes.
For price increases or for new price launch. And that's specific to one drug. And as 686 is drafted, by including the definition drug product family, it could be a company that doesn't have any increases or didn't have a new drug launch or new drug launch, but they would still be captured and required to, or potentially required to submit information. So they're being asked to submit information based on another company's decisions, and that's the concern.
Okay, thank you very much for that information. We appreciate your testimony today, and we'll turn to another person wishing to testify in opposition, Sam Hollemeyer. Mr. Hollemeyer.
Hey, thank you, Madam Chair, Senator Sanborn, members of the committee. My name is Sam Hollemeyer, and I'm here on behalf of the Pharmaceutical Care Management Association, otherwise known as PCMA. And I'm here today to provide comments opposing LD 686, which is along the lines of PBM reporting. PCMA is a national trade association representing the pharmacy benefit managers here in the US, otherwise known as PBMs, which administer prescription drug plans for millions of Americans with health coverage. Again, I appreciate the opportunity to speak today to provide comment on LD 686, but I want to focus specifically on page 4 and section 8736 on the public reporting. This would eliminate provision in the state's existing law that protects PBM specific data, and it would allow MHDO to produce a report with data specific to PBMs. While PCMA is not opposed to the data elements required in this bill, it's important to note that requiring the disclosure of claims information, even in the aggregate, must be properly protected to ensure the data could not be reverse engineered to determine confidential drug rebate information. Any public disclosure of negotiated rebate amounts on a drug by drug basis, it could negatively impact competition. The confidentiality of this language should be protected to ensure any information released for public reports meets our proprietary standards. And in fact, the Federal Trade Commission has also warned several states that legislation requiring PBMs to disclose negotiated terms could increase costs and undermine competition. PCMA requests that this language remain intact and not be removed. And that summarizes what I want to talk about today. I want to thank the committee for allowing me to speak today on LD 686, and I'm happy to take any questions at this time.
Thank you, Mr. Hollemeyer. I see that Representative Matheson has a question.
Thank you very much, Madam Chair. Thank you, Mr. Hollemeyer. And I just wanted to make sure I was clear. You're referring to lines 9 and 10, page 4?
Yes, Representative. Page 4, lines 9 through 12. Yes.
Thank you.
Are there any other questions from the committee for Mr. Hollemeyer? Nope. Seeing none, thank you for your testimony. And next I will turn to Ashley Van Meter speaking in opposition to the bill. Welcome, Ms. Van Meter.
Thank you. I too would like to thank the committee to speak on LD 686. I represent the generic pharmaceutical industry as well as biosimilar manufacturers. I would like to echo some of the concerns expressed over the bill that the folks from pharma have articulated. In particular, we worked hard through the negotiation process with the underlying bill that Senator Vitelli had done with this committee a couple of years ago in negotiating important triggers to make sure the generic industry was not overly burdened for reporting things when they had essentially decreased prices, not increased prices. I think some of the important points that I would like to highlight is through the process, and it is important to understand that the information that should be given should not be duplicative, should be relevant, and also not available through other sources. In particular with this, I know that the AMP data as well as WAC prices are readily available to the states through Medicaid, through CMS. Also, we have concerns that this also would increase authority and the scope of reporting. For example, we could have a situation where a branded product trips the triggers in the statute, and then a number of generic drugs, even though they took price decreases, are now going to be expected to report. In many of these cases, these companies have to go to 10 to 12 different departments within their companies to actually get the data. I have an example here where a branded product actually took a price increase of 22%, and there were 15 generics in the product family, and all of them had taken price decreases, some as much as 52%, 35%, and 45%. And with this change of language, these generic drug manufacturers that have no control over what the branded company did would now be required to file these additional reports of proprietary information. And so we have concerns over, you're essentially making the triggers within the underlying statute meaningless. So it's almost putting a situation into play where, you know, if you're going to trip the trigger, if you're not going to trip the triggers, but still be required to give this data, you're essentially rendering those triggers meaningless. And this type of increased reporting, I don't think is going to reduce the drug costs. It's not going to help consumers at the pharmacy. It's just going to overly burden generic manufacturers.
Thank you very much, Ms. Van Meter, for your testimony. And I see that Senator Stewart has a question. Please go ahead, Senator Stewart.
Thank you, Madam Chair, and thank you, Ms. Van Meter, for being here today. I recall the bill that was passed a couple of years ago, just following it through the process and whatnot. And certainly some of those safeguards were put in place specifically with generics in mind. And the benefit there being that it's essentially the same drug, but more affordable for the consumer on the back end. So what would, have you folks been able to do any sort of analysis on what a change like this might actually do to the pricing of some of the generics?
Yeah, a lot of the companies, when we looked at the example that I had given during my testimony, this could happen across the board for many of the most utilized generics. For example, generics of Lipitor, any kind of medicine for cholesterol. We saw where there were often 15 to 20 different generic manufacturers that did. Not only did they not take a price increase, they took substantial price decreases, and they will essentially be punished. And our manufacturers went back to their folks internally and said, you know, what does it take for us to get this type of report through? And as I had testified, they have to go to as many as 10 to 12 different departments to get this information. And a lot of them estimated that this would potentially cause the need to hire new employees or expanded roles, and really feel like the additional burden of this compliance reporting when they've done nothing wrong is definitely going to increase drug prices, because we truly operate like a commodity style where our products and our prices are really fluctuating generally on a downward trend. So this could definitely lead to increased generic prices.
So I'm sorry, I'm actually was putting up my own hand to ask a question. Lost track of the fact that I can just call on myself. But Ms. Van Meter, I guess in regard to this bill, what we're looking at is increasing drug pricing transparency. And for us to understand whether a drug becomes more expensive or less expensive, can you see how that might be part of transparency?
I mean, we definitely support transparency, but in a situation, you know, when we talked about the underlying statute and we worked with Senator Vitale and also NASHP, the understanding was that generic drugs were not showing up on Maine Health Data Organization's list of, you know, the biggest spend in the state of Maine. And so there was an interest in making sure that if generics were in fact saving the state money, they didn't want to overburden the generic manufacturer. And so in a situation where you can get this information already through IQVIA, you can get it through your state Medicaid, through CMS, it's already available. To burden generic companies simply because maybe a branded company had a price increase is overly burdensome. And I don't think it adds to the transparency of what the price increases are, what is causing the price increase, for example, on the branded product, to see that, you know, generics, as we've always reported, are on a downward trend. Having the information of companies that did nothing wrong, I don't think adds to understanding what's causing branded pharmaceutical prices to increase when ours are going down.
I hear you. I understand your concern about burdensome, but I guess I also feel that it's really important in transparency to understand what happens perhaps to a generic price in response to an increase in a branded price. And so I'm a little confused about how we understand those things if we can't collect data without overly burdening you. And I'm also a little confused about your calling it a punishment.
Well, first of all, the idea of the Affordability Board was to call out companies that were taking inappropriate price increases, and to force those companies to report and justify those price increases. And so if you have not done that, but then you still have to report, it feels somewhat of a punishment or an additional burden. Also, the transparency in seeing what happens to generic prices when the brand does take that price increase is readily available, and states can get that data. Actually, you all can get data much more definitive data than as an association we can, because we see blinded and also blended prices where the state can in fact go in and get AMP prices through state Medicaid, as well as it's available through CMS. So it is already available. So if a brand takes a price increase, you could look through, the state Medicaid and see what is happening with the generic drugs at the same time that the brand is taking that price increase.
All right. Thank you. I think I need to ask Ms. Harrington about why we can't just pull data from other sources. I have a feeling she has a reason, but I will make sure to follow up on that. Thank you, Ms. Van Meter. All right. So any other questions from the committee? Seeing none, is there anyone in the queue who would like to testify in opposition to LD 686, who I haven't called on? All right, seeing no one's virtual hand raised, move on to those speaking neither for nor against. And seeing none again, I will close the hearing on LD 686 and ask Senator Sanborn to take the gavel, as it were, again.
All right, thanks, Representative Tepler. So we have one additional bill to hear this afternoon, and it looks like we have the sponsor with us. So Senator Claxton will now open a hearing on LD 675, an act to protect Maine consumers from unsupported price increases on prescription medicines by creating an independent review process. Take it away for us.
Thank you, Senator Sanborn, Representative Tepler, and honorable members of the Health Coverage, Insurance, and Financial Services Committee. I'm Ned Claxton, and I'm proud to represent the folks of Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. I'm here to introduce LD 675, as was just read by your chair. This bill seeks a way to answer what sounds to be a simple question. Is the annual price increase in a given drug justified? We're all aware of the seemingly unending upward trend of drug costs. These changes sap our savings and force us to make hard choices about what to spend money on. With this bill in place, we will have a tool to sort out what price increases are supported by science or manufacturing challenges and which are not. We will also have a tool to generate downward pressure on the cost of medicines. The underlying understanding is it is a fundamental reality that high prices for drugs without any anchoring in how well those drugs actually work is driving up overall healthcare costs. And those spiraling prices lead directly to reduced access and higher out-of-pocket costs for all patients, especially for people with disabilities who often have more healthcare needs. What happens when drug costs increase rapidly or steadily? Insurers commonly restrict access to the medicine and then increase copays as they try to control their costs. This means less access to a given medicine for everyone. This legislation would apply to medication costs paid for by Maine tax dollars. Other payers and insurance have the option of using this information, but this bill focuses on how Maine can get the most benefit for the medicines that are paid for with our tax dollars. Last year, for the state of Maine health plan, the 25 most expensive drugs, based on the number of prescriptions filled and the cost of each prescription, accounted for 44% of the plan's total spend for drugs. 25 most expensive drugs, 44% of the plan's total spend for drugs. Of those 25, costs went down for 8 between 2019 and 2020. For the other 17, one went up less than inflation and 16 increased more than inflation. The range of those increases was between 7% and 1,400%. For the biggest jump in price, the plan cost went from 45 cents per member per month to almost $7 per member per month. It was a total cost to the plan of $1.1 million. How is that huge cost increase justified? What is the evidence that the increase is fair, appropriate, or required? Those are some of the questions that this bill proposes to help answer. In this case, there's a simple reason this increase might be acceptable. 14 times as many prescriptions were written. This is a new drug and was brought to market and had indications expanded. It became more widely used. The increase in this instance was based on science and frequency of use. It has been a life changer for many people and would not be impacted by this bill, even though it cost Maine taxpayers more than $1 million. What about the drug that almost tripled the plan's costs, going from 39 cents to $1.09 per member per month for a total of $175,000? In this case, fewer prescriptions were written for the drug. What is the information to support the remaining increase? For another drug, which cost the plan $820 for every prescription, there were 14 more prescriptions written, but the cost went up 50%. What's the supporting evidence that this is fair? I don't know the answer to those two questions, and Maine cannot set up its own process to fully sort that out. That's why this bill uses independent analysis to determine what drugs have had unsupported price increases. This bill relies on the work of ICER, the Institute for Clinical and Economic Review. They are an independent, nonprofit, nonpartisan research institute that produces reports analyzing the evidence on the effectiveness and value of drugs and medical services. ICER's report include evidence-based calculations of prices for new drugs that accurately reflect the degree of improvement expected in long-term patient outcomes, while also highlighting price levels that might contribute to unaffordable short-term cost growth for the overall healthcare system. Extensive input from 3 independent panels based across the country goes into each report, and they are subjected to public hearings before being published. In determining whether a drug is fairly priced, they examine cost along with the value a drug provides to populations of patients who use it. Each year, they publish a report on unsupported price increases, and it is that report that we would use to determine which drugs had price increases without justification. The panels involved are in California, the Midwest, and in New England. These independent panels review ICER's reports at public meetings to deliberate on the evidence and develop recommendations for how patients, clinicians, insurers, and policymakers can improve the quality and value of healthcare. All are welcome to testify. ICER is clear that cost effectiveness should never be the sole factor in deciding fair pricing of healthcare interventions, but rejecting or ignoring such information serves to keep patients locked into the status quo, a broken system where drug makers charge whatever price they like, insurers respond with barriers to access, and patients struggle to afford and access the care they need. That would be a true ethical strategy. It is a true ethical strategy for our nation. Patients deserve better. From an article in the Wall Street Journal 2 years ago, here are some real-world examples of how ICER information and analysis can help with the cost of medicines. In the first instance, the makers of a cholesterol-lowering drug called Praluent, which first went on the market for $14,600 a dose, offered to sell it for as little as $4,500 after rebates and analysis. A new drug called Aimovig is expected to cost up to $10,000 a year. It went on sale for $7,000. Another life-saving gene therapy for children that its makers said might cost up to $5 million a year was priced at $2.1 million. This is from the Wall Street Journal in November 2019. Here's how this process would work. Every year, the state health plan identifies the 25 medicines that cost the plan the most money that year. For those medicines with a manufacturer proposed increase in cost that is greater than the consumer price index, the ICER database is used to figure out what a fair price is for those drugs. It would be based on clinical evidence, changes in manufacturing costs, and the CPI. Those prices become the supported prices to be paid to manufacturers of those medicines for the next year. Manufacturers can accept those prices, or they can charge more. If the manufacturer decides to charge more than the supported price, then the state can bill them for 80% of the difference in cost of the plan between the supported price based on evidence and consumer price index and the manufacturer's net revenues for that drug. Any revenue collected from these penalties will be used to offset the cost of medicines to the state. The goal is to create some downward pressure on the cost of medicines based on good evidence and analysis. It is not to penalize manufacturers. The hope is that the state will be seen as an informed purchaser, that the prices will be seen as fair to the manufacturer, and that taxpayers will save some money. I've included some questions and answers at the end of my testimony, and I hope they will address some of the questions you might have. Before I conclude, and in order to again try to address some of the quite understandable concerns of patients and families, I want to note that legal review of the work of ICER has been found to be compliant with the Americans with Disability Act, the ADA. I also want to highlight a key policy statement from ICER and point out that they do not use any quality adjusted life years calculations in the recommendations about cost-effective drugs. Their policy is, in considering cost effectiveness, policymakers cannot use cost effectiveness analysis that use the cost per quality adjusted life year or similar measure to identify subpopulations for which a treatment will be less cost effective due to severity of illness, age, or pre-existing disability. In addition, for any treatment that extends life, policymakers must use cost-effectiveness results that weigh the value of all additional lifetime gained equally for all patients, no matter what the severity of illness, age, or pre-existing disability. To do otherwise would be unethical and against the oath I swore as a physician. Thank you for the opportunity to offer this approach as a tool to help move toward a healthcare system with sustainable access and high-value care. I will be happy to try and answer any questions you might have.
Thank you, Senator Claxton. Are there questions for Senator Claxton? All right. Seeing none, we thank you for presenting the bill this afternoon, Senator. And next we'll hear from Senator Joe Rafferty. Good afternoon, Senator. Go ahead.
Thank you, Senator Sanborn. Representative Tepler and distinguished members of the Committee on Health Coverage, Insurance, and Financial Affairs. I am Joe Rafferty, and I proudly represent all of the people of Senate District 34 in the Maine Senate, and I'm here today to testify in support of LD 675. I'm testifying in favor of this bill and the larger package overall for several reasons. The COVID-19 pandemic has emphasized the need of legislative action to be taken to address our healthcare system in Maine and across the country. Mainers are ready for action, and these bills deliver. The cost of medication is over 250% higher here in the United States than over 20 other countries. While federal action is needed, Mainers have never been ones to sit around and wait for problems to be solved. As legislators, we are representatives of the people of Maine, and we owe it to them to do the same. Waiting for change simply won't cut it. LD 675 fines pharmaceutical companies that cannot publicly provide justification for increases on their drug prices. Too often, these companies give phony or inadequate explanations of price hikes. This bill makes it so not only will that not happen, but in the event that it does, these companies risk receiving fines. It is clear that many of the companies only speak the language of the dollar, and this bill gives us and the people of Maine a voice to speak back. As a phys ed teacher and coach, it was not uncommon to have to carry some students' EpiPens during class or sporting events, as we often left campus. One student left their EpiPen, and I'll share this story with you, with me on a regular basis, and we had it in a first aid bag for quite a while. I usually carried the bag. Then one day, those EpiPens became extremely valuable. All of a sudden, we had not only to carry it around, but we had to protect it from being stolen because the pen itself became so valuable. I used to be able to leave it in my office or on the sideline, but that changed. Kids used to have one with me, another one in the nurse's office, typically the front office, and any other place where they spent an abnormal amount of time, abnormally large amount of time. When the pens became more expensive, at one point rising from around $100 to nearly $600 without any real explanation, many students had to switch to one pen and carry it with them all the time. I watched this shift change before my eyes. It was and is heartbreaking, and we need to prevent escalated costs for these pens and other life-saving drugs. I want to thank my fellow lawmakers, President Jackson, Majority Leader Vitelli, Senator Claxton, and Senator Breen, who introduced these bills, as well as other co-sponsors for standing up for Mainers. This package takes action by establishing the Office of Affordable Health that will prohibit price gouging on life-saving medicines. It increases the transparency of prescription drug costs. It places fines on pharmaceutical companies when they introduce price hikes with faulty explanations, and it provides emergency supplies of insulin for our diabetic neighbors when they are in desperate need. I am proud to support these bills. It is what the people want and need. Now it's time to deliver. Thank you for the opportunity to testify, and I'll do my best to answer any questions that you may have.
Thank you, Senator Rafferty. Are there questions for Senator Rafferty? All right, seeing none. I got a message that Miriam Wolf might be joining us, who was on a list from a prior bill, wanted to testify about all the bills. So Christian, is she available? She's on a phone line. Okay, great. So we're going to pull her in on a phone line. All right. Ms. Wolf, you can unmute yourself and go ahead.
Madam Chair, members of the committee, thank you for having me here to share my story. My name is Miriam Wolf, and I'm from York, Maine. I've been retired for 5 years and have enjoyed spending my time daily going for walks in the woods and performing the upkeep on my parents' old home. But in 2009, I developed constant and severe anal pain that has made it nearly impossible for me to stay active and enjoy my life. To help control my pain, the doctor prescribed analgesic suppositories. But when I got to the pharmacy counter, I was shocked to learn that using just 2 suppositories a day would cost $540 a month for a supply. As I only receive $840 per month from Social Security, there was no way I could afford the prescription, so I left it at the counter. It seemed utterly ridiculous to me that the medication would cost nearly 2/3 of my monthly income. This year, I finally received an explanation of my worsening symptoms and was diagnosed with Crohn's disease. To manage the condition, my doctors suggest that I begin Remicade infusions, which are priced at about $3,500 per month. I don't know how I'm going to pay for these bills, but while I figure things out, I going without these medications. I avoid leaving my house because I worry not having quick access to a bathroom. And when I have to go somewhere, I don't eat that day to eliminate the risk of having an accident and have thus lost a considerable amount of weight. I used to be a psychiatric nurse before I retired, and I've seen the prices of drugs steadily, both for myself and my patients, rise over the years. We need relief from this. That's why I'm asking you to vote in support of LD 686 to expand on the previous efforts to increase transparency and drug pricing tactics. The entire package of bills is pivotal to curb the drug prices and hold Big Pharma accountable so that patients like me can afford the drugs we desperately need. Thank you for your time and for listening.
Thank you very much for your very personal testimony today. And thanks for your patience in joining us so late in the afternoon. Are there any questions? All right, seeing none, again, we thank you for being here. Next, we'll hear from Lori Dumont. Ms. Dumont, you may unmute and go ahead.
Can you see me? Can you hear me?
We can hear you, and now we can see you.
Okay.
Go ahead.
Thank you. Chair Sanborn, Chair Tepler, and members of the committee, thank you for having me. My name is Lori Dumont, and I'm from Brewer, Maine. 4 years ago, the price of insulin changed my life, but more importantly, changed the life of my brother forever. My brother had just learned that his insurance company had stopped covering his insulin. He went to the pharmacy to get new vials and was informed that his short-acting insulin would be $750 a month and his long-acting insulin would be $650. He couldn't afford this. He couldn't afford that with his limited income as a taxi driver and made the difficult decision to start rationing his short-acting insulin to make it last longer. 3 days later, he was found unresponsive in his home after not showing up for work. His core temperature was 88 degrees. His organs had shut down due to the diabetic ketoacidosis that had occurred without the insulin his body needed. Miraculously, paramedics were able to revive him, and he was airlifted to a hospital in Bangor and admitted to the intensive care unit on life support and not expected to live. I was at the hospital every day as my brother fought for his life for a month. In addition to being his caregiver and primary advocate, I had to start to make the difficult decisions that accompanied this trauma. And somehow, after the worst month of our lives, we were still faced with the monumental task of finding a way to pay for the insulin he needed after he was discharged. And I may add, as well as help paying for the exorbitant medical bills. All of this trauma and financial distress could have been avoided if insulin were affordable. As others have said, it's been almost 100 years since insulin was discovered, and there is still no affordable option for people like my brother. The package of bills you're considering today will help countless families across Maine to afford the necessary prescription drugs, especially the life-saving ones. No person should be left rationing their necessary medicine because of its unaffordable price. LD 695 would provide a check on drug company price gouging, which is obscene, and protect patients like my brother who ration their drugs because of high prices. I urge you to vote yes on LD 695 and this entire package of bills to fix our broken drug pricing system and make drugs more affordable for patients across Maine.
Thank you for your testimony, for sharing your story with us. Are there any questions for Ms. Dumont? All right, seeing none, thank you for joining us.
Thank you so much.
Next we'll hear from Kate Endy.
Good afternoon, Senator Sanborn and Representative Tepler, members of the committee. Thank you for the opportunity to provide these comments. My name is Kate Enty. I'm the Policy Director of Consumers for Affordable Healthcare. As you know, CAKE serves as Maine's Consumer Assistance Program and has a helpline where we hear from thousands of people who have questions about their coverage options, how to apply for and enroll in insurance, as well as issues and questions regarding accessing healthcare. Through this work, we often hear from people who have difficulty affording their prescription drug medicines. And it is with that experience that we support this bill today. As both myself and Ann Wallison, our executive director, have already outlined in previous testimony today, the experiences of our helpline callers are not unique. And there's many situations in significant data that shows that when prices increase, people don't access the medicine that they need, and it has negative health outcomes. So for the sake of time, I just want to highlight that 3 of the drugs that were most recently reviewed by ICER in their most recent report included 3 drugs that were also among the 25 costliest drugs in Maine, as reported by the Maine Health Data Organization. And the cost paid by individuals and health plans in Maine for just those 3 drugs exceeded $147 million over the 12-month period from June 1st, 2019 to June 30th, 2020. And so we know Mainers are paying more for the medicine they need, including older Mainers who typically pay more than half of prescription drug expenditures out of pocket. And addressing unaffordable and rising drug costs is truly a matter of life and death for many people. Polling conducted last fall by Critical Insights revealed that 82% of Mainers support enacting a law that penalizes drug manufacturers who increase drug prices without sufficient evidence to justify those increases. Mainers have compelling concerns over high drug costs and the effect that those costs have on access to healthcare and affordability. This committee took significant steps during the 129th legislature to address prescription drug pricing. However, clearly more needs to be done. And so for these reasons, we urge the committee to build on the progress that we've already made in Maine by supporting LD 675 and the entire Making Healthcare Work for Maine package to strengthen transparency and lower prescription drug costs for Maine people. And happy to answer any questions you have.
Thank you, Ms. Endy. Are there any questions for Ms. Endy? All right, seeing none, next we'll hear from Kathy Kilrain Del Rio. Good afternoon, Ms. Del Rio, go ahead.
Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee. Thank you so much for your patience today. My name is Kathy Kilrain Del Rio, and I'm the Director of Campaigns and Healthcare Advocacy for Maine Equal Justice, a nonprofit legal aid provider working with low-income Mainers to increase economic security, opportunity, and equity for people in Maine. I've submitted testimony in support of all the bills you've heard today, in addition to LD 675. We've long known that healthcare costs and the cost of prescription drugs are a major obstacle for many Mainers to maintain good health. A Kaiser Family Foundation report found that in 2014, Mainers per person healthcare spending was more than $1,500 higher than the national average. A report from the Maine Center for Economic Policy in 2019 found that in 2018, Mainers spent 17% of their consumer expenditures on healthcare compared to only spending 14% in 1997. Unsurprisingly, as healthcare costs increase, our ability to pay for other basic needs is limited. The impact of rising costs disproportionately harms those who have the smallest or no financial cushion, including those who have low incomes and those on fixed incomes. When faced with the choice between paying for food, housing, transportation for work or school, and healthcare, many Mainers skip necessary healthcare or try to make their prescription stretch by taking less than prescribed. For example, in 2018, 125,000 Maine adults didn't get the care they needed when they needed it because they couldn't afford it. You've heard many powerful stories from individuals today. And I just wanted to share a little more from the perspective of low-income Mainers. Many lower income families have incomes that fluctuate, making them move between main care and other healthcare coverage. Many private health insurance plans, either provided by an employer or through the marketplace, have costs that are still too high for lower income families to afford. An unexpected medical bill, serious illness, accident, emergency, or ongoing prescription costs or care for a chronic condition can quickly spiral a family into debt and even the loss of housing or transportation. In turn, that can negatively impact their ability to work or to be successful in school. When we have to make these trade-offs, our health suffers in many ways, as you've heard from so many people today. For these reasons, we support all the bills before you, including LD 675. When it comes to the escalating costs of prescription drugs, a multi-pronged approach like those proposed by the combination of bills before you is desperately needed. LD 675 will provide checks on pharmaceutical companies that unnecessarily raise prices on needed medicines, which creates great harm for Mainers' financial stability. People across our state who are struggling to make ends meet need you to stand for them. Their lives should be more important than huge profits for drug manufacturers. In addition to the positive impacts for individual Mainers that these bills could provide, getting the rising costs of healthcare and prescription drugs under control could also reduce costs for our main care program and make federal subsidies on the marketplace stretch further. Getting a handle on healthcare costs that are exorbitantly high could allow us more resources to fund areas of our system that are struggling. Together, the bills before you this morning and afternoon can make a serious and needed impact on the cost of healthcare and prescription drugs in our state. For these reasons, we urge you to support all the bills that you've heard today. And thank you so much for the opportunity to speak. I'm happy to answer any questions.
Thank you, Ms. Calderine Del Rio. Are there questions? Seeing none, we thank you for your testimony. Next, we will hear again from Hillary Koch. Good afternoon. Go ahead.
Hi, Hillary Koch again with T1 International. Thank you again for your time today. I know you're very tired. I'm sorry I don't have my teen or testimony in verse this time for you. Insulin is a 100-year-old drug. In fact, it is 100 years this year. Its patent was sold for $1 because those who discovered it knew it was a life-saving medication, and they wanted to ensure that everyone in the world would have access to it. But 3 pharmaceutical companies, Eli Lilly, Novo Nordisk, and Sanofi, referred to in the industry as the big 3, control 90% of the global insulin market and have adopted cartel-like behavior, leading to a crisis enough to make anyone's stomach turn. A vial of insulin costs on average $5 to produce, but it sells for almost $350, and patients need several vials a month to survive. Knowing that patients must purchase insulin or face death, the big 3 have raised the price of insulin over 20 or 25 years, as you've heard today, often actually on the very same day, leading to a price increase of over 1,200%. This anti-competitive behavior is illegal. And in January, the Senate Finance Committee Chairman Chuck Grassley and Ranking Member Ron Wyden released the findings of a 2-year investigation revealing how the drug companies have employed practices to keep prices high. Consequently, my organization, T1 International, led by patient advocates, joined others and economic justice advocates to launch the Investigate Insulin Now initiative, asking the Federal Trade Commission to investigate the insulin cartel. Maine Representative Shelley Pingree, along with other members of Congress, have also asked for the FTC to investigate the big 3, who control nearly all of the insulin in the United States. Pharma has also used things like patients' assistance programs to trick lawmakers and allies into thinking that they offer a solution. They don't. Unfortunately, organizations like Beyond Type 1, who you've had written testimony from today, accept money from pharma and in turn promote these assistant programs, which then actually contribute to the rising costs. But the impact of the price of insulin is more than just on paper. It has real life consequences for those who depend on it, as you've heard today. It's priced so high that 1 in 4 Americans ration insulin. People literally starve themselves to try to use less insulin, but they often end up in the ER or die. I recently did some math to price my son's insulin. If my son's insulin needs never change, and we know that they will, and the prices never change, and we know that they will, the cost for insulin from today until his 75th birthday would be over $800,000. And that's just the cost of his insulin. That doesn't include the supplies to get the insulin into his body. So this brings me to LD 675. If pharmaceutical companies can produce reasonable explanations for the price of their increases, great. If they can't, they should be fined for it and consumers' costs offset. Because we know that withdrawing their drugs would result in fatalities, we think that particular piece of the bill is really essential. So we strongly support LD 675 and we vote for you to pass it. Thank you.
Thank you, Ms. Koch. Are there questions for Ms. Koch? All right, seeing none, thank you for joining us all day today. I will next just ask if there's anyone else who wishes to testify in favor of the bill. That's the list that I had. All right, seeing no hands go up, we'll switch to those who are signed up to testify in opposition to the bill. And we will start with Ben Chandok.
Can you hear me okay?
We can, go ahead.
Excellent. Good afternoon, Chair Sanborn, Chair Tepler, and members of the committee. Thank you for your time this afternoon. My name is Ben Chandok. I'm testifying respectfully in opposition to LD 675. I represent the Biotechnology Innovation Organization, or BIO. We submitted written testimony as well, so I'll keep my comments brief. Specifically, we're concerned about codifying the use of ICER's UPI report impacting the cost of prescription drugs in Maine. ICER is known for setting the benchmarks that were referenced in the supportive testimony for using a metric called QALYs, which measure the value of therapies and then places a price tag on the value of a human life here. It's been widely criticized for discriminating against persons with disabilities, seniors, and other patients with chronic disease. And although UPI report does not use QALYs, the bill as written does not include any parameters on the methodology that ICER could use to produce that report. ICER created this report, the UPI Unsupported Price Increase Report, just 2 years ago, and it only examines whether new clinical evidence could justify a price increase. So it does not consider any non-clinical factors that go into the pricing of medicines, and ICER itself and background materials acknowledge that it's not a full economic analysis of the included products. And it's not intended to classify price increases as completely unjustified, just unsupported based on clinical evidence. But we're concerned because LD 675 treats the UPI report in a way that's outside the scope because it authorizes fines based on the report. So reiterating again that the UPI report is not a comprehensive economic analysis that examines all the factors that go into the price of a medicine, we're just concerned that as a non-governmental entity that's not accountable to the public or elected officials, that ICER could change the underlying methodology of the UPI report from 1 year to the next. So therefore, if the bill is enacted, biopharmaceutical companies could be fined just based on whether ICER decides to use a different methodology or has a different opinion of how that UPI report could be constructed. As a reminder, Maine, to emphasize, Maine has a growing bioscience industry with 457 bioscience establishments that employ over 7,500 Mainers. So on behalf of our members, BIO urges the committee a no vote on this legislation. Happy to take any questions.
Are there questions for Mr. Chandok? Representative Tepler.
Thank you, Madam Chair, and thank you for being here, Mr. Chandok. My question is, it was my understanding that there is another state that uses the ICER UPI report and that state requires that the report not include the use of QALYs. Is that correct?
My understanding is Washington State had a similar bill. While not in my region, my understanding is that an amendment was adopted in committee that prohibits the use of QALYs in the production of the UPI report. I am not sure whether that bill passed.
It's my understanding that it did. So
okay,
put that out there.
Are there additional questions for Mr. Chandok? All right, thank you. Next, we will hear from Nick Doherty. Good afternoon, Mr. Doherty. Go ahead.
Good afternoon, members of the committee. Thank you again for the opportunity to speak before you today. My name is Nick Doherty. I'm the Director of Policy for Pharma in the New England region, and I'm located down in Boston. We also submitted a detailed statement outlining our concerns in opposition to LD 675. And for the sake of time, we'll raise just a few issues because the speaker before me did bring up a lot of the concerns that we have. We'll point out LD 675 does take a very narrow analysis. It takes ICER's unsupported price increase assessment, which focuses only on whether new clinical evidence exists, and then uses it in a manner that's inconsistent with even ICER's description of the purpose. So on the very first page of the 2020 UPI report, it does read, UPI reports are not intended to determine whether a price increase for a drug is fully justified by new clinical evidence. And the concern that we do have is LD 675 still relies on ICER's UPI assessment as the sole determinant of which drugs have an unsupported price increase. And do want to, again, just follow up on the previous speaker's comments that this bill does rely on a report. And in the past 2 years, the protocol, the report has changed on multiple instances where ICER did not anticipate an issue within their more recent report. And so they arbitrarily reverted back to 2019 protocols when determining if 2 different products would be included in the report. Another issue that we would bring up is that it's a very narrow view of pricing, and it does not acknowledge disruptions or changes in the supply chain that lead to price increases, such as increased manufacturing, labor expenses, as well as market change. So the concern we do have is that this bill relies on a report that is constantly adjusting its metric and would then penalize past pricing decisions on an unpredictable and constantly changing benchmark established by this non-government entity. We would again also follow up with what Bio said relative to QALYs. And the concern we have is that this is a reliance on a report that it's known to discriminate against the most vulnerable citizens within our state. And we believe that patients, especially those that are vulnerable, need concrete reforms to help them lower the price they pay for medicines at the pharmacy, such as making monthly costs more predictable and sharing the negotiated savings on medicines. So unfortunately, this bill does not meet those objections, and that's why we are unable to support this bill and hope that this bill does not move out.
Are there questions for Mr. Doherty? All right, seeing none, we thank you for joining us again. And next we'll hear from Bill Murphy. Good afternoon, Mr. Murphy, go ahead.
Sorry about that, trying to unmute. Thank you, Chairman Sanborn, Chair Tepler, and members of the committee for the opportunity to speak in regards to some, it's just concerns about LD 675 as written. I'm Bill Murphy, Director of Advocacy and Public Policy for Epilepsy Foundation New England. The foundation certainly is not opposed to drug pricing transparency and lowering the cost of prescription drugs. However, because of the grave potential for harm to many patients, we feel that LD 675 as written is not the best way to achieve this goal. Indeed, it's a complex issue. To be brief, I'd like to highlight just some of our concerns. I've also submitted more detailed information to the committee that hopefully answers any other questions you may have. But our concerns include that the Institute for Clinical and Economic Review, ICER, is specifically referenced in the bill. And we do not feel that ICER is an appropriate source of information, and certainly not a transparent one. ICER cherry picking research that truly highlights the concerns that matter most to patients and real world evidence. LD 675 resembles bills in other states provided by the National Academy of Association of State Health Policy. And the template lacked input from patients and people with disabilities when it was developed. We're concerned also that the legislation is written codifies reference to an independent.
Mr. Murphy, you seem to have frozen a bit. If you could turn off your video camera, we might be able to hear your testimony better.
Sorry?
Mr. Murphy, you're breaking up on us and your video is freezing. So if you turn off your video camera, that may allow us to hear your words better. And I'll just ask you to back up and say the last sentence over again.
Mm-hmm. Trying to stop my video, sorry.
Okay.
Okay.
There you go.
Yeah, sorry about that. Not use quality. The methodology does not preclude the use in future years. There's also the potential for ICER to change its methodology in the future after the report is signed in this law, with significant implications for disabilities.
All right, Mr. Murphy, we're unfortunately not
having
able
ICER
to hear you.
In the patient-centered manner, like the patient-centered outcome research Institute PCORI. Can you hear me now?
You're breaking up, unfortunately, pretty intermittently, but we do have your written testimony, and it may be better at this point for us to rely on that. So I'm going to direct the committee to please make sure that you carefully consider Mr. Murphy's written testimony, as we're having trouble with his audio connection. And I am sorry about that, Mr. Murphy. That's the drawback, unfortunately, of this method of doing business. And I'm amazed it works as often as it does, but today it does not seem to be working for you with us.
Pretty intermittent, so
yeah,
thank you.
I'm sorry. Okay, so all right, next we'll hear from Nolan Ritchell. Good afternoon, go ahead.
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. My name is Nolan Reichel. I'm a litigation partner at Pierce Atwood, where I specialize in commercial litigation, administrative law, and appellate litigation. I appear before you today on behalf of Pharma to provide testimony in opposition to LD 675. Whereas Mr. Doherty discussed some of the policy considerations concerning LD 675, I'm here today to talk about the legislation's significant constitutional defects. First, LD 675 grants effective lawmaking authority to ICER, which is a purely private out-of-state organization. Excuse me, and the bill does not impose any standards or procedural requirements on ICER with respect to its decision-making. This sort of delegation of lawmaking authority to a purely private actor, particularly one that is not subject to Maine law or any oversight by the legislature, violates the non-delegation principles of the Maine Constitution and the Due Process Clause of the 14th Amendment of the United States Constitution. The fundamental principle here is the need for a democratic link between the people of Maine and the people who make public policy decisions on their behalf. Legislation that breaks that link by granting power to unelected private actors violates the Maine Constitution and the United States Constitution. Second, LD 675 violates the Supremacy Clause of the United States by seeking to alter the economic risk-reward balance struck by federal patent law. Here, federal patent law preempts 675 because the legislation seeks to diminish the return pharmaceutical manufacturers can earn with respect to drugs that are on patent, and does so in a way that strikes a fundamentally different economic balance than is struck by federal patent law. The Federal Circuit's 2018 decision in Biotechnology Industry Organization versus District of Columbia relied on precisely this reasoning to strike down a DC law that sought to prohibit the sale of prescription drugs for what was deemed an excessive price. Finally, LD 675 impermissibly regulates outside of Maine's borders. The LD seeks to penalize drug manufacturers with respect to the sale of prescription drugs, but drug manufacturers don't sell drugs in Maine. They sell them to wholesalers outside of Maine. Additionally, the ICER report on which LD 675 relies concerns national drug prices. So the LD penalizes drug manufacturers for the national drug pricing decisions they make, regardless of what prices may be charged in Maine. And finally, LD 675 seeks to compel out-of-state companies to send products into Maine against their wishes. The United States Constitution forbids states from regulating outside of their borders in all of these ways. And I'm happy to address any questions you might have.
Thank you, Mr. Reichel. Are there questions for Mr. Reichel? All right, seeing none, thank you for being here with us today. Next, we'll hear once again from Ashley Van Meter.
Hello. Again, I would echo some of the testimony from the previous person, as well as from bio and pharma. As we've detailed in our written testimony, LD 675 would violate the Dormant Commerce Clause by imposing in-state consequences on out-of-state prices. It also is preempted by federal patent law insofar as it applies to patented drugs, and also violates the Due Process Clause. LD 675 regulates sales outside of Maine, as was just articulated by the previous person testifying. The Commerce Clause is violated whenever a state law attempts to regulate any out-of-state transaction, either by express terms or by its inevitable effect, which would unfortunately happen in the case of LD 675. Also, the constitutional problem is not the connection to in-state transaction. The problem is the regulation of out-of-state upstream transactions. The Supreme Court has long held that a state cannot regulate the prices charged in out-of-state transactions just because those transactions will have an impact on prices in in-state transactions. The District Court of Maine would be held to the precedent that has been set by the Federal Circuit Court that I just outlined the holding of that case. Also, 675 is preempted by federal patent law. By capping price increases to only those approved by ICER on the basis of evidence per ICER protocols, LD 675 would essentially interfere with the federal patent laws and also thereby affecting the Supremacy Clause. The purpose of patent laws is to subsidize the development of new drugs and then therefore enable the creation of generic drugs by allowing inventors to charge above market prices for a limited period in exchange for full disclosure of the chemistry of their drugs. By imposing strict caps on the prices of brand name drugs, LD 675 interferes with the balance between patent-based incentives for innovators and efforts to keep prices low, a balance that is reserved only for Congress to strike. Also, I had mentioned that LD 675 violates the due process clause. LD 675 creates an irrebuttable presumption of unjustified price increases for all drugs listed on the ICER annual report. There's no hearing, no notice from Maine indicating whether a drug manufacturer will be fined. Once the ICER report is issued, fines are automatic, so that firms are first told of their liability when the state tax assessor informs them that they must be fined that given year, and there's no appeal process. Even if ICER's internal procedures were relevant, they fall short of what due process requires. Given there is no hearing, manufacturers are not able to review ICER's evidence of unsupported price increases, and again, there is no appeal process set. And for these reasons, AM unfortunately has to testify in opposition, and we have submitted written testimony that explains this to a greater extent.
Thank you, Ms. Van Meter. Are there questions for Ms. Van Meter? Senator Stewart.
Thank you, Madam Chair. And thanks again, Ms. Van Meter, for your testimony. So can you give a rundown of which states have actually passed a proposal like this? Or are we soon to be the only one?
Maine will be the only one. Washington State did have a bill, but the bill failed to come out of the Senate committee. It did not meet deadlines. So Maine would be the only state in the country to do this type of bill.
Representative Morris.
Yes, thank you, Madam Chair. Looking at the testimony from, I guess it's called Nash P, and similar to on their last, they talk about that they've worked to work out what they say all the legal issues. You have talked about the Dormant Commerce Clause a little bit today, and it's also in your testimony. You just further explain sort of that issue and what you see as the issue with that?
Sure. Well, when I was referring to the Dormant Commerce Clause earlier, we were talking about the case that the association that I work for, AAM, filed against the AG in the state of Maryland, Frosh. We won that case in the district court and also on appeal at the Fourth Circuit, that a law that was similar to 1117 did in fact violate the Dormant Commerce Clause, in that they were trying to regulate out-of-state prices, similar to what is happening in this case. So there is an analogy between what we saw in AAM versus Frosh, also with 1117, as well as with this bill. A lot of the issues that were pointed out in our briefs and also amicus briefs in those cases are evident in the bill 1117 as well as 675, unfortunately.
Okay, are there any additional questions for Ms. Van Meter? All right, seeing none, we'll next hear from Jennifer. Well, I guess first, sorry about that. We will hear from Superintendent Chopra next against the bill. Good afternoon, Superintendent. Go ahead.
Good afternoon, Senator Sanborn and Representative Tepler, members of the committee. I am Superintendent of Insurance Eric Chapa, and I'm here today to testify in opposition to LD 675. This bill task would involve 3 state entities: the state tax assessor, the Bureau of Insurance, and the Attorney General's office. I will testify solely on the Bureau's role as written in the bill. The Bureau supports lowering health costs. Lower health costs result in lower premium costs. However, the Bureau has concerns with a number of aspects of its proposed responsibilities under this bill that are unclear. Among them are which consumers would benefit from the unsupported prescription drug price increases fund: consumers who buy the particular drug with a price increase, consumers in the fully insured market, all consumers in the state, including the uninsured and consumers in ERISA plans. If consumers to benefit are those who buy the particular drug with the unsupported price increase, how would the Bureau identify them, and what methodology would the Bureau employ to determine how much offset each would receive? Finally, if all insured consumers in the state are to benefit, what methodology would the Bureau use to benefit consumers in ERISA plans or uninsured Mainers? Would it benefit main care beneficiaries? With so much unclear, the Bureau does not support this bill at this time. Thank you. I'd be happy to answer any questions.
Thank you, Superintendent. Are there questions for the superintendent? I'm a little bit troubled by your testimony, Superintendent, so I want to try and ask you kind of a blunt question. You're in opposition to the bill because it would give the Bureau of Insurance a pool of money to defray consumers' healthcare costs, and you're not exactly sure how you would dispense that money? Is that accurate?
And in fact, yeah, we need clarity. Again, I think it's we're willing to work with the sponsor to assess it, but at this time, we'd like more clarity on how those mechanisms would work.
Okay, so as I read the bill, it allows you to determine how those mechanisms would work and for you to cooperate with other state agencies to determine the best method. So are you asking us to simply take that out of your hands and perhaps, for example, assign it to some other agency? Or are you just saying that you don't want to make those determinations as to how to lower people's costs on drugs? I'm very confused as to why an agency wouldn't want to have a pool of money that they could use to help lower consumers' costs on drugs and then go about the process of figuring out exactly the best way to dispense that money.
Well, those are fair questions. I think given that the amount of money involved, I think I'm asking for more clarity on how that would work and what pool of consumers. I mean, I only regulate less than 30% of the market, less than 30% of the citizens in the state of Maine. And therefore, I mean, how would I distribute the funds more broadly than that?
Okay, so you'd like us to give the money to someone else instead?
I'd like to discuss it more.
Okay, all right, thanks. Representative Tepler, go ahead.
Thank you, Madam Chair, and thank you, Superintendent. I guess, yes, I was going to sort of follow up along the lines of what Senator Sanborn was asking. If this section of the bill were altered so that, and just for example here, one of the other bills that we passed in this package were to take responsibility for the monies produced from this bill, would that make you comfortable with this bill?
Well, my testimony says that it's strictly limited to the Bureau's role. If the Bureau doesn't have a role, then I guess it would.
Okay.
Okay.
Thank you, sir.
Are there additional questions? All right, thank you. Next, I will do a last call for anyone who wishes to testify against the bill before we go on to those who are registered to testify neither for nor against. All right, seeing no one's hand raised, I will call on Jennifer Reck to testify neither for nor against.
Hello, good afternoon, Senator Sanborn and Representative Tepler and members of the committee. I'm Jennifer Reck, Project Director for the National Academy for State Health Policy's Center on Drug Pricing. NASHP works with state officials and legal experts to craft model legislation for state action on drug pricing, and LD 675 builds off NASHP's model legislation on unsupported price increases. I am not here to testify for or against the bill, but to provide information and to help answer questions. People in Maine want to understand why drug prices are increasing so much, and the Independent Institute for Clinical and Economic Review, or ICER, conducts an annual report that helps answer that question. The report is a review of available scientific evidence to determine if drug price increases are supported by new clinical evidence. In other words, did prices go up because these drugs somehow got better? Or did drug companies raise prices on products simply because they can? In its latest report, ICER found that 7 out of 10 drugs reviewed had price increases unsupported by new clinical evidence, contributing to $1.2 billion in additional US spending, including well-known brand name drugs for conditions like arthritis and Crohn's, such as Humira and Enbrel. The annual report prepared by ICER represents a credible, unbiased, and freely available basis for state action. Funding for ICER's research comes exclusively from nonprofit foundations without ties to insurance or pharmaceutical industries. ICER does have critics, however, which include organizations that receive funding from drug companies. Many of them raise the issue of the Quality Adjusted Life Year, or QALYs. However, QALYs are not used in ICER's report on unsupported price increases, and therefore concerns about QALYs do not have any bearing on LD 675. This can be confirmed through a review of ICER's methodology, which is entirely transparent and documented, and also invites manufacturers of products under review to participate in the process to ensure fairness and accuracy. ICER is also happy to answer any questions on its report for the committee. And NASHP also has a legal analysis of this bill that addresses the legal issues that have been raised in opposition. Thank you. I'm happy to answer any questions.
Thank you, Ms. Rack. I guess with regard to the legal analysis, is it like a memo that you could provide to the committee to address the points that Mr. Reichel noted?
Yeah, we have a broader legal analysis, but we'd be happy to pull the relevant points into a memo form and share it with the committee. Absolutely.
I think that would be helpful, given that you didn't kind of rebut point by point what Mr. Reichel talked about, and he used a lot of lawyer jargon that perhaps those of us who aren't either in law school at the moment or have graduated from law school, as I look over at Senator Stewart's box, it might have not been the most accessible piece of testimony without an ability to sort of rebut it point by point. So I would encourage that assistance for the committee. Are there additional questions for Ms. Reck? Okay, seeing none, we thank you for joining us today. Is there anyone else who wishes to testify? Oh, Representative Tepler, go ahead.
Thank you, Madam Chair. I would appreciate, not from Ms. Reck, but I'm just asking Colleen to ask if someone from the Attorney General's office with an interest in this area of law could join us for the work session. I think it would be hugely helpful. We need the state's legal interpretation of these issues. So since we're not all in law school like Senator Stewart or lawyers like Senator Sanborn, and if I missed anybody who's also an attorney, I apologize. So it would be helpful to have that assistance from the Attorney General's office.
Yep, agreed. Okay, so seeing no additional folks wishing to testify, I'm going to close the hearing on LD 675. And are there any additional requests for the work session from Colleen? Okay, Representative Matheson, go ahead.
Thank you, Madam Chair. Just maybe some background information on ICER and QALY. I think those two things are a little bit confusing to me, and I'm getting differing information from the testimony. So I think that would be really helpful for me.
Yeah, I would agree on that. All right, anything else? Okay, As we noted earlier, all of the 5 bills that we heard today will be scheduled for work sessions in the coming days. And with that, it is 3:47, and we have a number of work sessions to tackle this afternoon. I'm gonna take some chair's liberty here and just announce that this afternoon we will not be taking up LD 368 or LD 1063. We'll reschedule those work sessions for another day. And we will, I think, be able to take up the remainder of the bills that are on our work session schedule for this afternoon. Representative Morris, how much time do you folks still need to prepare, or are you guys pretty much set after we have a break?
I think we're pretty much set.
Okay, great. So with that, let's take a 15-minute break and come back right around 4 o'clock, and we'll work through these work sessions. I think they should be fairly straightforward. All right, we'll see you at 4 o'clock.
Let me just call Trey.
Okay, it is 4:01. Let's start with LD 800.
Want me to go through the analysis, or do you, in the interest of time, do you just let me know how you'd like to proceed?
Sure. I think on this one, why don't you pop the analysis up and we'll just look at it very quickly.
Sure. Okay, great. I can run through this real quick if you want, or highlight.
Yeah, I don't think you need to read all the words, but just give us the highlights.
Sure. This is a bill that was introduced on behalf of the Secretary of State's office, and it would amend the laws that govern requirements related to administrative procedures for state finances to explicitly allow a state department or agency to impose a surcharge for payments made by credit card or debit card for various government payments. It also would amend the Consumer Credit Code provisions to allow a governmental entity to impose a surcharge for payments made by credit card or debit card for registration fees and goods, and would include under the definition of governmental entity a state department or agency. Under existing law, state departments and agencies do have procedures to accept payments by credit cards or other electronic means, but the statute requires that any administrative fees associated with this method of payment to be absorbed within their existing budget. And so the testimony from the Secretary of State's office talked about how they seek authorization to impose a surcharge to accept these payments, and also updates references in that statute to debit cards. There are a couple things to consider. One is the Secretary of State's office did ask for a technical amendment to Section 1 of the bill. The language as drafted refers to ability to impose a surcharge. They've asked for adding reference to or service fee to recognize that debit card transactions are sometimes treated differently and incur service fees pursuant to their contract as opposed to surcharges. So they've asked for that clarification. The second piece is that under the existing law that does allow governmental entities to impose a surcharge and pass that along to consumers, there are specific requirements that the surcharge be disclosed prior to the transaction to the consumer, and two, that the surcharge does not exceed the associated costs of administering that. And so the suggestion from a technical perspective is whether you wanted to add that provision similarly to state departments and agencies in terms of requiring disclosure with specific language, or you could also incorporate it by a cross-reference to the existing statute. We've heard before too in testimony on a related bill that other entities like merchants, representatives of the Retail Association of Maine, has asked if the committee would consider expanding the scope of the bill to allow other types of sellers to impose a surcharge. The bill as drafted only would provide an exception for state agencies. And then lastly, I just note a suggestion from the Maine Municipal Association to clarify the definition of governmental entity. They've suggested that as drafted, it doesn't specifically reference plantations, which are a form of local government. And so they would suggest that in addition to the specific references to counties, municipalities, and quasi-municipal corporations, you add a reference to plantations in the definition of governmental entity. I'm happy to answer any more questions. We've talked before about some of the legal issues that have been raised about these types of provisions. We don't yet have the fiscal information. And the last thing I would mention is I do believe you have a representative from the Secretary of State's office in the Zoom, Mr. LaChance, who can answer any technical questions if you have them. I don't believe the Secretary of State herself was able to join us.
Thanks, Colleen. So I think
it makes sense to, I think you suggested 2 amendments potentially.
Three.
One was the technical amendment that talked about a service fee.
Yep.
Do you think that's just a wording thing? Is a surcharge and a service fee, are there 2 different things?
I mean, it could be a wording thing. I think there was some concern. I had a discussion with the Secretary of State yesterday that they were concerned that it might, that it, as drafted, it might not provide for their ability to account for those because of their current contractual relationships with their vendor. So that was a suggestion from them. And I think if Mr. LaChance has any, particular things to add about that, he could. But that's my understanding of why they are suggesting that.
Okay, and then the cross-reference, so the provision for other governmental entities that is currently in the statute has a limitation, has a cap on what amount can be charged. And so your other suggestion, if I'm understanding it correctly, was just to add a cross-reference or to incorporate that same language into this paragraph. Is that right?
If you thought that that was appropriate to include that, and also the second piece is the consumer disclosure piece.
Right. Okay. So I was thinking they were already going to be cross-referenced, but I guess
think they are arguably because of governmental entity, the definition of governmental entity, but because I think there could be some ambiguity potentially. And so that's why I think, just to be clear, either to cross-reference or to include that.
Okay.
Language.
Okay, great. Are there additional questions from the committee? All right, seeing none, I'm just going to go ahead and make a motion ought to pass as amended with the language change and the cross-reference. I saw Representative Tepler's hand go up first for the second, but thank you, Representative Connor. Is there any further discussion on the bill? Representative Morris.
Yes, thank you, Madam Chair. I will be brief. I am certainly sympathetic to I will be supporting the motion, but I am certainly sympathetic to what the retailers. However, I think that needs to be a separate bill and a separate public hearing if we were ever going to consider something like that. And I'm not sure where the committee jurisdiction. So that's my only statement.
All right. Thanks, Representative Morris. I will also say that I generally oppose surcharges, even though I run a business where we accept many hundreds of thousands of dollars worth of credit cards every year, because it's built in. It can be built into my pricing. But when we're talking about statutorily set registration fees, we can't, unless we agree to just raise all those registration fees for everybody, we can't build it into the pricing. So that's why I think government surcharges are different. I don't like that they're different, but sometimes that's just the way the cookie crumbles. So that's why I am supporting this, but am fervently opposed to changing the rule with regard to retailers. So I'll just draw that distinction out a little further. Representative Matheson, go ahead.
Thank you, Madam Chair. I just want to make sure that we're not making any mistake here with both of those charges listed under the new bill as amended. I just get a little nervous when it says surcharge and service charges. I have no problem with the bill as it is, as long as we're not charging two charges, we're not allowing 2 charges that I'm not aware of just because of the wordsmithing. So that's just a comment.
Yeah, I don't think we are, because I think we're going to incorporate by reference the rule that you can only pass along the actual cost, basically, as opposed to creating some kind of $5, blanket surcharge or something like that, or service fee. But
would the word "or" help there, Madam Chair?
Colleen?
I think it already does say "or." Or it would say "or" as I've suggested it. It's not an "and," but I can think about how to I understand what Representative Matheson is saying, and that has tripped up the legislature before, those kind of things in legislation. So I'll think about it, and if I can make some changes, I'll make sure to clarify that.
Okay, great. Any further discussion on the motion?
Can I just ask one more question?
Yes.
Were you sympathetic to the idea of adding the reference to the plantation that the Maine Municipal Association recommended, or not? I just wanted to clarify that.
I am sympathetic to that. Does anyone have any issue with adding plantation to the list of government entities intended to be covered by the bill? Representative Tepler.
I don't have any objections, but I don't know if plantations collect any fees or taxes that would come under this, because I believe that they're generally part of the unorganized territories. I don't know if that's exactly correct, but I'm open to adding them in anyway.
If they never use it, it doesn't seem like a bad thing to have in there.
Reasonable.
Yeah.
Right. I mean, there could be some permit fees, maybe transfer station or something like that. I'm thinking, it might be a small fee.
Okay. So we'll take that as a friendly amendment. All right. Is there any other discussion on the bill? Seeing none, the clerk will call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart.
Yes.
Senator Stewart, yes. Senator Brenner is absent. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 12 yes, 1 absent.
Next, we're going to turn to LD 984, an act to allow procurement of surplus lines insurance for commercial forestry and construction equipment. And it was brought to my attention that Representative Martin had actually intended to testify at the hearing, but had a health crisis that day, actually, and was not able to attend the hearing. So I wanted to invite Representative Martin to join us and provide his testimony on the bill for us today.
Can you hear me okay?
We can. Representative Martin, please go ahead. Oh, now you're on mute. Okay, go ahead.
Hang on just. Difficult to get.
You keep muting yourself. Just try once and then we'll be able to hear you. All right, you're still on mute at the moment. There you go.
You got me okay?
We do. Go ahead.
Okay, thank you. Thank you for having me this late of the day and appreciate this. This issue has been a major issue in my district primarily because of the large instruments that are being insured, and very often because of the way in which the industry is proceeding, that is the insurance industry, they are not making the loss complete. So as it is, people are losing substantial amount of money, and all of a sudden they got to go out and replace a piece of equipment that's worth a couple $100,000, and they're only getting about $50,000 for it. And that leaves them in a position where it's very difficult for them to proceed to move forward. And so I think we had a system that worked fairly well, and then it got changed for reasons which I don't need to talk about today, but it has resulted in a situation where some people are being mistreated as a result by the insurance industry. And I think that anything we can do to put the surplus system back in, and I think the Bureau can also provide for that, we can make a difference in my district in particular.
Okay. Thank you, Representative Martin. Are there questions from the committee for Representative Martin?
All right, not seeing any. It's nice to hear your voice, Representative Martin, and thank you for joining us this afternoon to provide your perspective.
Yeah, appreciate it,
from your district.
I'll be around for the work session, so that'd be great.
Okay, great. Which is what we're going to do right now. So Representative Martin will move you back through the wormhole to the attendee list, and I'm going to call on Superintendent Chapa to join us and give us an update on what the Bureau has been discussing with regard to this bill. Good afternoon, Superintendent.
And thank you for the opportunity to update the committee. When this issue was first brought up recently, we started focusing on the issue of coverage, because coverage is something we think can make a lot employers eligible for export to surplus lines. It's not price, because the statute's pretty clear. Price is not a reason for an export to surplus lines, but coverage may be. And we're in the process of modifying the bulletin, and it'll be out very shortly, like within the next couple of days at most. That'll make it clear if the coverage, if you can get better coverage in the surplus lines, and the producer still has to do a diligent search. That's a given. The producer's still going to have to do a diligent search in the admitted market, because the admitted market ought to be the market of default, given all the consumer protections there. But having said that, if after a diligent search the actual coverage is better in the surplus lines market, then that particular employer would be eligible for export. It'd have to be on an employer by employer basis, but it does give the opportunity for an employer who wants enhanced replacement costs, and that's not available in the admitted market, to get that through the surplus lines market. And that's clarification we're going to include in the bulletin.
Okay, great. And you mentioned that that bulletin would be out in the next few days.
Yes.
Okay, great. So with that in mind, my proposal, folks, is going to be that we would table this bill and wait for the Bureau to issue the bulletin, and then circle back with the sponsor to determine whether any sort of bill is still necessary at that point. All right, so unless anybody, I don't want to cut off discussion. If there are further questions or additional comments on the bill at this point, but seeing none, I would move to table.
And I will send Colleen
the second
as soon as we issue it.
Great. So it's been moved and seconded to table. It's no roll calls required, just your hand in your box on the video if you're in favor of the tabling motion. It's unanimous of those present. And so we will wait for the Bureau to issue the bulletin, and Colleen will flag it for us, and we'll schedule it for an additional work session when that happens. All right, thanks everybody. Thank you, Superintendent, for joining us. The next bill that we'll pick up is LD 1011, an act to include excluded individuals on insurance cards. Colleen, why don't you do a quick rundown on this one for us?
I'll share this quickly. LD 1011 would require an insurance policy used as evidence of insurance or financial responsibility under the motor vehicle laws to list any person explicitly excluded from the policy on that card. I think, as everyone knows, under current law, Owners and operators of motor vehicles are required to maintain minimum amounts of motor vehicle financial responsibility. And the law does provide that when a law enforcement officer stops an operator for a moving violation, or that operator is involved in an accident that must be reported, the officer shall request the operator to produce that evidence of liability insurance. The sponsor did suggest, if the committee moves forward, to add a specific application date to the language of the legislation so that insurers would have the ability to update their processes to comply with the requirement. So he had suggested an application date of January 1 of 2022. You did have some concerns raised about whether or not this was necessary and what would the administrative cost for insurers to do this. You did have some testimony from representatives of the Maine Association of Insurance Companies indicating that one member insurer will do this, or will list an exclusion on the card, but only if evidence of other insurance for that excluded individual is provided. And then there was a question raised about what are the consequences for the insurer if the name is not listed on the card in error. There is a requirement in current law in the motor vehicle responsibility language that does provide that an insurance producer, broker, or agency may not be held liable for any inaccurate insurance identification card if the card was based on information contained in the records of that person, or was issued based on false or misleading statements made by the insured. But that's specific to insurance producers, and it does not extend to insurance companies. And then lastly, it was suggested further technical change if you went forward to consider amending the language to specify that the exclusion of coverage of a particular individual is made by endorsement to the policy. And then the last thing I would mention is I do think you got some additional information and testimony that came in email today that Christian forwarded from a law enforcement officer in the sponsor's district. And I'll stop there, and I'm happy to answer any questions that you might have.
Okay. Are there questions for Colleen? All right. Seeing none, is there discussion about the bill? Representative Connor.
Thank you, Madam Chair. I believe the sponsor is here, and he made mention that the representative or the law enforcement officer is here as well. I didn't know if the committee would permit him to speak or not.
Sure, we can have the law enforcement officer speak. I think we already heard from the sponsor of the bill, but I'll allow it. I don't know his name. He could raise his hand.
I think it's Mr. Mitchell.
Okay. Christian, you can bring him in. Good afternoon, Mr. Mitchell.
Hi.
Go ahead and tell the committee why you're in favor of the bill.
So I'm here today to provide you with valuable information regarding a law enforcement perspective on this particular LD 1011, an act to include excluded individuals on insurance cards for auto insurance. I'm Danny Mitchell Jr. I'm the Chief of Police of the town of Winter Harbor Police Department. We are home to the Spitic District Canadian National Park. I've been a law enforcement officer since 1991. I'm a graduate of the Maine Criminal Justice Academy. I hold a bachelor's degree in public safety administration, associate's degree in legal technology, as well as a degree in computer science information security. A couple of years ago, I came into this situation with a person that we had arrested for OUI. The husband-wife team had an auto policy in full effect at the time of that stop. But later, when the husband received his insurance bill, he requested that his wife be excluded from the policy to avoid the large rate increase he had just received for her conviction. With an excluded driver, the insurance company will not cover any incidents involving the excluded person operating the motor vehicle. So in this case, the insurance company excluded his wife from the policy, but the policy holder still allowed his wife to operate the motor vehicle. So when law enforcement officers stop people, like in this case, it's very common to ask for proof of insurance or insurance ID card. And this could be for any vehicular stop. It's not contingent upon the seriousness of the stop. The ID card shows a name, policy number, as well as effective date and expiration. The card does not, include the excluded person's name on the card. So law enforcement has no way of knowing if the operator of the vehicle is excluded from the policy, like in my previous example. The only way that we would know that is to call the insurance company during the traffic stop and wait to get an answer. But the purpose of the excluded driver is a workaround to increasing insurance rates due to a high-risk driver. So people who are involved in motor vehicle crash with an excluded person will be liable for their own damages or their respective insurance companies. So if this law were to pass, the names of excluded drivers would be printed on the insurance ID card. Law enforcement would be able to, at that point, easily see if a person is excluded from an auto policy and be able to help prevent harm to others by being able to take law enforcement actions for operating a motor vehicle without proof of financial responsibility. So without this, nearly all excluded drivers on a policy will go undiscovered and will continue to operate a motor vehicle and not have insurance responsibility as Title 29A, Section 1601 requires. So that's kind of it in a nutshell.
Okay, thank you. Yep, thanks for being here and for presenting your testimony. Senator Brenner has a question.
Thank you, Madam Chair. Good afternoon, Officer Mitchell, and thank you for joining us. My question for you is, are there other states that require this?
That I don't know. I don't know if there are others. I know that I've never worked in another state in law enforcement.
Okay.
So my 30 years in law enforcement here, this has been kind of brought to my attention by my own experiences.
Have you heard it from other departments in the other towns and county sheriffs?
Not necessarily. It's not something I've readily discussed. I have with a few other people individually that have heard of things like this happening. So I guess it's kind of, I believe it happens more than what we know, because again, the only way for us to know is to actually sit there during a traffic stop and call somebody's insurance company. So, and that's not usually feasible or a good use of time.
Thank you so much.
Representative Tepler.
Thank you, Madam Chair, and thank you for being here, Officer Mitchell. My question is kind of a follow-up on Senator Brenner's. Can you think of other incidents where you think this has happened in your district or the area that you patrol?
I cannot accurately say that would have, I believe I've run into this before, but again, without actually calling the insurance company, there's no way to know that. High-risk drivers, people, I believe people get excluded from policies all the time. But again, without having this information at hand, we won't know. And it's too bad. It would be too bad for the general public to run into this on a regular basis without, that the individuals have been excluded from a policy, yet the insurance company is no longer responsible for the damages or the accident or the actions of that individual who's driving the vehicle. Yes, in a civil suit, that would be the case, not otherwise, not straight up.
I guess I'm just really wondering about the level of responsibility of the person who has excluded someone from their policy, but continues to allow them to drive the vehicle.
I couldn't agree more. However, I think that's what we're talking about, probably ending up in a civil suit. Somebody's probably going to have to sue somebody in order to recover damages, rather than being able to go to somebody's insurance company, report it, and just have a regular seamless process of reporting, an accident and being able to recover from harm from the damage.
Representative Connor.
Thank you.
Thank you, Madam Chair. I just have a follow-up, if I may, to Representative Tepler's question there. I think it would be good conversation starter if this bill were to pass and somebody did try to call their insurance company to state, I want to exclude, if my wife was caught with an OUI and I called the insurance company to have her taken off, that could be a good conversation starter with the insurer. Hey, you do realize that if you are caught with her driving, you are fully liable and we are not liable for any. So I just think that would be a good conversation starter. But I did have one question for Officer Mitchell. Do you think this would make the roads safer? Or is this something like has been brought up that we just don't know?
I absolutely do believe it would be safer. When you have a regulation like this in effect, it is a deterrent in some cases. You know, you're not going to deter everybody. Obviously, the person was driving OUI. You know, the chances of them, you know, driving while excluded from a policy, I think I think you have a high chance, because insurance rates do have a tendency to increase in larger steps for things like OUI. So I do believe it will make things safer. It gives law enforcement the information that they need at their fingertips to be able to ascertain, hey, is this person doing this? Look, if there are fewer people, then we will see fewer, you know, we won't see a whole lot of excluded names. But when there are when the person is excluded, we'll see that information, then we'll be able to take corrective action at that point. So I do believe it will, yes.
Thank you. That's all I have, Madam Chair.
As far as one other thing real quick is that the insurance company typically, they exclude somebody, does put it in writing that that the person acknowledges that the insurance company is not responsible for any damages or any incidents that takes place while this excluded person is operating that particular motor vehicle.
Representative Quinn.
Thank you, Madam Chair, and thank you, Officer Mitchell. I actually was in an accident with an uninsured driver who struck our vehicle, and we ended up being responsible because obviously they didn't have insurance and we needed a car. However, I'm just wanting to clarify, this bill is specifically if someone is removed. It's not where if you have your teenage child and you just forgot to put them on or something like that. This is not involving that situation, correct?
Correct. I think in a regular, for the most part, my belief is that if like for your example, if a child, you know, a teenage driver just coming, oh, gee, I forgot to put them on. I think the insurance company would go for that. I think they would cover that under the regular policy. That would be my opinion. That may be, you know, we'd want to check with insurance providers at that point in time, but this would only be if somebody is excluded. So this is a very specific, a very small area of that we're tackling here, but yet I think it could make a huge difference, because I think you're going to find there's a lot more excluded drivers out there than what we really know.
Representative Arford.
Yes, thank you, Madam Chair, and thank you, Officer Mitchell, for being here. Very quickly, you used the term corrective action. I'm just curious, does that involve a fine? What would corrective action be in this case?
Title 29A, subsection 1601, failure to provide evidence of insurance financial responsibility.
But what would be the consequence be if they were in fact
that would be a ticket for that individual. At that point in time, there could probably be some other actions that we could take, such as whether that would include towing the vehicle or something like that. I would have to check, or getting somebody there that is able to drive that vehicle.
Thank you.
Are there additional comments on the bill? Or sorry, excuse me, questions for Officer Mitchell? All right, seeing none, we're going to thank you for joining our work session, and we're going to send you back through the wormhole to the attendees list.
Thank you for taking the time to listen.
Mm-hmm. Okay. So is there any additional conversation on the bill? All right. So given that that was quite a bit of new information, I think we're going to request, or not new information, but certainly new testimony and a new perspective. We are going to request a caucus, I think, at this time. Representative Tepler, go ahead.
Before we caucus, Madam Chair, can we ask a representative of the insurance company who had testified against the bill to come back and sort of just review their concerns for us?
Yeah, sure. I think Mr. Bernier testified against the bill, but I could be wrong. If somebody in the attendee list wants to raise their hand to come on back up, that would be fine.
Mr. Bernier, Ms. McHale, Mr. Garrity, Mr. Sultan, all of them.
They all testified against, and they're all here.
Yeah, so one of them needs
all right.
to step
Somebody needs to raise your hand.
Pick one if they're really there.
You're gonna have to play favorites.
Right. Vivian McHale raised her hand, so we'll have Ms. McHale join us.
I'll get my video started here. Thank you so much. I just want to clarify, we were neither for nor against, but since you didn't have any other takers, I thought I would chime in and get the conversation started. The committee did have 2 questions for State Farm, and so I do have a little bit of additional information for you. I believe it was Representative Morris who asked about the process that it would take in order to provide this information on State Farm's cards. This won't surprise you, I don't think, but it will sound something like this. The enterprise technology section of State Farm would put this in the queue of their compliance regulatory work so that it would be compliant with whenever the effective date was determined. The first step would be to redesign the card, add a field for the excluded driver's name, and then program the system to include that, to pull it from the customer's records and print it on the card. Once the programming is done, the cards are redesigned, the cards are reprinted. So I'm not going to stand here today and tell you that's some huge heavy lift, but it will take time. So our testimony specifically was asking for the effective date in place. And Representative Arford asked specifically whether we had any documentation of the situation described by Representative Thornton and now by Officer Mitchell, and they really don't. It's honestly not a situation that has come to State Farm's attention. And I believe that there are 241 exclusions by endorsement currently in State Farm's stable of insured. So if that gives you a sense of the scope here, we still kind of question the necessity of this. Certainly appreciated Officer Mitchell's testimony, but I'll leave you with that. And the representatives who were opposed to the bill maybe want to speak to it, but I did want to report back that we did get to your questions.
Thank you, Ms. McHale. It's helpful to know the numbers there. Do you know what percentage of the market? I know we have a very competitive auto insurance marketplace, so I assume State Farm doesn't have a huge market share, but do you know what percentage it is roughly?
You know, I do not, but I can find out. I know that we are second to, I believe, Progressive, but I can try to find out that percentage for you.
It's all right. I just was trying to put the 240 some odd
of course
context of what that might be statewide, but
of course, right.
Thanks.
Thank
okay,
you.
We'll send you back through the wormhole and invite Mr. Sultan to join us.
Thank you, Senator. I was diligently searching my files for my policies to give you a specific answer to the question of, I think that the one raised by the chief, I think that's one you're asking about, whether an excluded person is not then covered in the other policy. And I want to give you the right answer, and I can't put my hands on the policy language to be certain. But because they are excluded, I would believe that they are. There would be no coverage. there may be other types of coverage involved because of the owner of the vehicle would still have some coverage. So there would be a question there.
So I think our question was sort of the broader, if you could explain why we shouldn't pass this bill, having just heard that it would make our roads safer, from, the chief. So you were opposed to the bill in the first place. So remind us why that was the case.
Maine already has the lowest uninsured rate in the country. And I think we're fourth lowest. So it's around 4%. We have been at that level for quite a while. 30 years ago when I started, it was in the mid to high teens. So we have done a lot. You really can't get much lower because of people's habits, I think, and so on. The roads aren't safer because people are insured. If they have an accident, you have coverage and you can protect your own liability for causing an accident. And you can also obtain coverage to try and protect yourself for first party coverage, so your med pay and things like that, and for damage to your automobile. How people drive and their risk profiles doesn't really is not impacted by insurance. So having an uninsured driver out there is still going to be up to what risk profiles they have. We do know that uninsured drivers tend to be riskier than insured drivers, just because of the acknowledgement that there is liability and that you can cause by being a risky driver. So we don't think putting an excluded driver or mandating that is going to improve the safety on the roads.
Okay, Representative Blair.
Thank you, Madam Chair. Thank you, Mr. Sultan. So my question to you, though, is it's not a matter of making the roads safer. I think that's a piece of it. But the other piece of it is we have somebody who's breaking the law, and we're now bringing it up to the officer's eyes that he is breaking the law. Without putting this on the insurance card, they don't know that they're breaking the law. So I think that's more of the issue. And so my question to you is that if you're against this bill, why? So if you're against this bill, why? Is it because of producing the cards? What makes you not in favor of the bill?
As I testified in the hearing, one of my members does put excluded people on their card, but they will not do so unless they see another policy for that excluded driver that is in hand and placed for coverage, so that they know that. Otherwise, that driver is still a member of the household. Remember, your auto policy covers members of your household, regardless of whether or not they're named as an insured or not. So if you as a parent, partner, spouse, whatever, try to exclude somebody, this particular company wants to know that they are at least covered somewhere else, so that they don't pick up that liability and that there isn't other coverage to pick up that liability and stuff. We think it's one way that carriers can compete. As was mentioned earlier, it's a highly competitive marketplace. I think there's over 200 licensed auto carriers in the state. And it's just one way for us to compete. Some do, some don't. We prefer not to have that mandate because the card information is limited to how much room you can do. And it takes a lot of money to have to rearrange and reprogram that kind of information.
Okay, I'm gonna just remind all of the attendees that the chat function can't be used for substantive comments. It's to be used only for administrative purposes. Representative Tepler, go ahead.
Thank you, Madam Chair. And Mr. Sultan, I am a little confused about whether or not an individual who's specifically excluded from a policy is covered under that household piece that you were talking about. Is that what we're still struggling with, about knowing if I exclude my teenage son from my policy in order to get a better rate, is that son still included as an occasional driver, as a member of the household?
No, he would not be an occasional driver. He'd certainly be excluded. What I
Okay.
I mean, that's just a fact. The question is whether or not there could still be some kind of coverage given if that son then goes out and has an accident under your policy. I wanted to be certain.
Uninsured motorist might cover him in that case?
Well, that's not, I want to be certain about my answer. And so I couldn't put my hands on my folder of policies to give you that answer. And so I couldn't find it while we were searching,
Okay.
talking about this.
So then the question is really whether or not giving the police officers the information that someone is excluded from the policy will allow them to remove those drivers from the road more regularly, which is, I think, the safety issue, than otherwise. And I guess that's the question out there, whether that's happening and how often it's happening, and whether it's worth making the insurance companies pay to change their cards to create that element of safety, and whether it's really a significant element of safety.
My members' representatives say that this happens very little. I mean, it's a rare instance that someone is excluded. I mean, it's just does not happen that often.
Okay. My last question, my question, which is the last of my questions, is whether, it's not necessarily the last question, is whether there is any other state that is requiring this of their insurers.
I do not know the answer.
Okay. So does that seem to indicate no, or are you saying there might be and your members haven't told you that?
Yeah, my members primarily write in New England and the Eastern Seaboard. None of them mentioned this to me, that it was something that happened in their other states.
Okay. Senator Brenner, did you have your hand up? No. Okay. All right. So given all of that, I will just tell the committee that I'm still wondering what problem we're trying to solve exactly, because I don't think we have a rash of folks out there driving in contradiction to their exclusion on the policy. And I'm not even sure that the officer mentioned ever knowing that to have happened, and the insurance companies don't seem to think it's an issue, perhaps because they're pretty careful about not allowing for those exclusions to actually be used to avoid higher rates. I am questioning what the bill is for, so I guess I'll just say that it's a regulation, and I'm not sure it regulates in the effort to solve a problem. Representative Arford, go ahead.
Yeah, thank you, Madam Chair. One more quick question. Another way of looking at this is how many people are in accidents that give an insurance card that is actually not, that they are not listed on as a member, or they're not actually covered by that insurance.
Right.
When it's, I mean, do we have any numbers on that?
Right. It sounded like we asked that question of Ms. McHale,
Okay.
and she said it wasn't common.
I mean, that would honestly, I just will say this. I think it's actually a really worthy idea, and I really want to thank the sponsor for bringing this. Wherever we go with it now, I'm not sure, but it seems like we don't have all the information. At least I don't feel I have all the information. We have some questions that if we had answers to them, we might have a more definitive sense of what the best thing to do is right now. But I also realize that we need to address this bill possibly now and not continue with it. So
Yeah, we have over 100 bills left to vote, and this one is probably not worth having multiple work sessions on, to just to be blunt. Representative Quinn.
Yes, I'm on the website everquote.com, and it's showing that 41 states allow exclusions on the insurance cards, on the insurance policies. It said, what's an excluded driver on an auto insurance policy for the title? So I don't know if that would answer some of the questions, but it's posted.
Yeah, I don't think it answers my question, because my question's about the card. It's clear we allow you to exclude from the policy, but whether the state mandates that it be printed on the financial responsibility card, I think is the question. And I'm not sure if that's what that website talks about. You're certainly absolutely allowed to exclude in Maine from the policy, where nobody's debating that. But the question is whether it's printed on the actual proof of financial responsibility card.
Okay.
As mandated by the state.
Yeah.
Thanks, though.
I'm just trying to figure out the answers for it.
No, I appreciate that. I really do. I really do. Okay. I think that the best thing to do right now is just to take about 5 minutes and head off to caucus and then back. And we'll be back at 5 p.m. exactly, please. Thank you.
Heather, just to give you a heads up, I don't know if you're still there or not.
Yeah, I am.
I've got a jet in a couple minutes for class at 5 o'clock anyway, but I'll circle back with, is it Colleen that I touch base with, or?
You just have to record your vote with your presiding officer, and then they'll get it back to Christian.
Okay. All right.
Just send an email to just send an email to Rose, and she'll send it back to Christian.
Okay. Unless, of course, you guys are still going at 7, in which case I'll just see you then.
Hopefully not. I think we won't be. Christian says no. All right. But I'm going to run off to caucus now. Thanks,
All right.
guys.
See you guys. Thanks.
Okay. All right, we'll wait for a few more people to come on back.
Can you hear me?
We can. Do you want to start your video back up, Representative
Yeah.
Evans?
Yeah, it says you cannot start your video because the host, okay, here we go. All right. Okay, thanks.
I turned it off for you, so I guess I had to turn it back on for you. Okay, great. All right, so having digested the information that we received today, I'm going to make a motion to pass as amended with a couple of amendments. One of which is to change the effective date or add an effective date to the bill. Colleen, we had a conversation about wanting to have the language be clear that if the policy is, for example, renewed this December, the insurance company doesn't need to issue a new card in January to comply, right? It would be the policy date that governs. So it'll take a full year and a half before those cards need to be reprinted, right?
Changed.
So
Yep.
yeah, so like my car insurance policy renews in December. My card wouldn't have any requirement that it have an excluded person on it until the following December.
Right. Typically our application dates apply to the contract year. So on or after that date.
Yep.
So the requirements would apply and be incorporated as the year goes on for whatever policy. So I can make sure
Great.
that. And you were January 1 of 2022 is the date that you wanted.
Yes.
Right. Yeah. Okay.
Yep. And then the other suggestion was that the only people who needed to be listed were those who were excluded by endorsement, not those who were excluded by accidental omission or oversight or just moved in or something like that.
Sure. Yeah. Or inadvertently. Yeah. The language of it, the bill as drafted refers to explicitly excluded from coverage, but I think I would add reference to endorsement to make that clear. So,
okay.
Thank you. Yep.
So that's the motion, and Representative Connor has seconded. Is that a second, Representative Connor? Yes. Okay. Is there any further discussion on the bill? All right, seeing none, all those, the clerk will call the roll. Yes, that's how this works. I'm tired.
Representative Quinn.
Yes.
Representative Quinn, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 12 yes, 1 absent.
Okay. Colleen, let's quickly pull up the bill analysis for 1141.
Or 1141, this is a bill that relates to amending the Service Contracts Act to include motor vehicle theft protection programs and warranties. Go back to the first page. It amends the laws governing service contracts to add the replacement of motor vehicle key fobs and repairs, replacement, or maintenance of leased vehicles as items that are permitted to be included in service contracts. It also would make clear that motor vehicle theft protection programs and theft protection program warranties are also part of the act. and exempt from provisions of the insurance laws. As you heard at the public hearing, the Service Contract Act does have specific provisions requiring registration with the Bureau of Insurance and does require those contracts to include certain disclosures to consumers. The Bureau of Insurance did suggest a technical amendment to the language of the bill rather than enacting some of the separate definitions as proposed. Suggested amending the definition of service contract in section 7102 subsection 11. I think I can, in my opinion, I think it works either way. I think the bill as drafted probably works, but if the committee is interested in making those technical changes, I could certainly work with the Bureau to make the drafting a little bit cleaner from their perspective. We don't yet have their fiscal information, and I think Mr. Yardley is still in the attendee, is an attendee if you wanted to hear from him, and Mr. Garrity, who is the primary proponent, may also still be here as well.
Okay, I'm not sure if that's necessary. Is there any discussion on the bill? All right, seeing none, I'll entertain a motion. Representative Tepler.
I'll move ought to pass as amended. I think it's amended. Colleen, is it amended?
It would
If
be
you'd
if
like
we
to
had
make those
her make the
technical changes. Good, yep.
Okay. Yes, I'll move ought to pass as amended, and just caveat emptor.
Senator Brenner. Okay. And my comment was that I was hoping we could have amended the bill to prohibit robocalls from folks selling these types of warranties, but that seems non-germane to the bill. So unfortunately, we'll pass it without that provision. Is there any further discussion on the bill? All right, seeing none, the clerk will call the roll.
Representative Quint.
Sorry. Yes.
Representative Quint, sorry. Yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks. Representative Brooks, absent. Senator Stewart. Senator Stewart, absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 11 yes, 2 absent.
Okay, great. Moving right along, let's pull up the bill analysis for LD 1176.
Is LD 1176. This was a bill that relates to assessing the value of motor vehicles. The bill would provide that if an insurer uses the value of a comparable motor vehicle to assess the value of a damaged motor vehicle, that the insurer must use a comparable vehicle in Maine, New Hampshire, Vermont, Massachusetts, Connecticut, Rhode Island, or New York. One of the issues that was raised at the public hearing was whether or not this legislation was necessary. You did receive testimony from representatives of auto insurers that described the process that they currently use. They generally do look to use the same geographic location or regional location to establish value, and only if the comparable vehicle is difficult to find in the same make, model, or features would the insurer look to comparable vehicles in other locations. And the Bureau of Insurance noted that they, in response to some questions from the committee members, that they have had few, if any, complaints formally registered with the Bureau about this issue. And then the way that the bill was drafted, it seemed to explicitly prohibit the use of motor vehicles in other areas. So it was suggested that perhaps that language might make it more difficult to value vehicles or cause delays in the process, particularly without this flexibility that might be needed to recognize unique circumstances. Representative Fay did ask after the public hearing that I, at her request, put together a proposed amendment that would clarify the language in the bill as drafted. And so this language on this slide here in yellow is sort of highlighted where the changes would be, but primarily the changes would recognize that insurers would use those designated states that I mentioned to the extent comparable vehicles are available in these states. And then the language would allow an insurer to use comparable vehicles in another state only after determination that comparable motor vehicles are not available. We don't yet have any fiscal information on this proposal. I will stop there and happy to answer any questions.
Representative Tepler.
I'm going to make a motion ought to pass as amended by the sponsor's amendment that we just looked at.
Okay. Is there a second? Representative Matheson seconded it. Is there further discussion? All right, seeing none, the clerk will call the roll.
Representative Quint.
Can you actually come back to me? I'm looking at something on the screen.
Sure. Representative Connor.
No.
Representative Connor, no. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
No.
Representative Morris, no. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks. Representative Brooks is absent. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. And Representative Quint.
Thank you for coming back. Yes.
Representative Quint, yes. That is 1, 2, 3, 4, 5, 6, 7, 8, 9 yes. And I'll turn it over to Colleen to clarify minority report.
Yes. Representative Blyer and
No,
Connor and
he's-
Morris.
oh, Connor and Morris. Yes, sorry.
Yeah.
Are you ought not to pass, or do you have a separate amendment?
No, I'm not to pass.
Thank you.
Okay, great. So I think, someone correct me if I'm wrong, that brings us to the end of our work this afternoon. And it's only 5:12. That's not bad at all.
Not too bad, yeah. Can I just
That's
say
really not
one
bad.
thing I wanted to mention is we did receive the fiscal information on a bill that was previously voted ought to pass, and it was divided report on LD 603, which was the bill related to healthcare pharmacists as designated as healthcare providers. There is no fiscal note needed, so we can report that bill out just with the straight ought to pass, ought not to pass reports. So you will see some follow-up emails from Casey Milligan in the next couple of days asking you for your approval for the signature for LD 603. Just wanted to pass that along to you. And then the last thing I would mention is I did forget one bill to add to our work session schedule this week that I think we could add to Thursday's schedule. It's LD 1119, Senator Miramont's bill related to monthly credit card billing. And since we have public hearings scheduled on Thursday afternoon that relate to financial institutions, financial services, I was hoping we could add it to the work session schedule for Thursday. Okay, great.
Sounds like a plan.
Thank
Yes,
you.
That's right. That was in this grouping.
It
of
was, and
bills.
I spaced on it, and it should have been done today, and I forgot. So if we could add it to Thursday, that would be great, especially given the memo that came out today. So that would be great.
Yes. Yes, great. And Colleen, I will send you and Christian and Representative Tepler a note shortly after this about our scheduling process for tomorrow as well, because I have some conflicts.
Oh, me too. So great. So that's good. Maybe we can do it by
So many
email. That'd be good.
conflicts.
Perfect.
Yeah, so I'll shoot you a note. And we can do it by email. Representative Tepler, do you have anything else?
Yeah, I just want to add that Representative Brooks let me know that she lost internet and that's why she wasn't present. So I asked her to get in touch with Christian regarding voting.
Okay, great. Anybody else have a comment, or are you just waving goodbye? All right, we'll wave goodbye to you as well, Christy. All right,